Now, thank you, sir. Now I would request Dr. Vinay Redoso to please present Tulsi saplings to Dr. Rajesh Arora, sir. ठीक है ठीक है ठीक है Thank you, sir. Now I would request Dr. Vikesh Shukla, sir, to present Tulsi saplings to Dr. Bhupesh Sharma, sir. Thank you, sir. Now I would request Dr. Navneet Sharma, sir, to present Tulsi saplings to Dr. Mallika Pathak, ma'am. Thank you, ma'am. Thank you, sir. Now I would request Dr. Indu Singh, ma'am, to present Tulsi saplings to Dr. Prakash Paligar, sir. Thank you, ma'am. Thank you, sir. Now we are starting with scientific session second, that is stem cells, tissue engineering, and pharmacology. For that, I would request Dr. Bhupesh Sharma, sir, Professor and Center Head of Department of Pharmacology, MIT Institute of Pharmacy, MIT University, Uttar Pradesh, to please introduce Dr. Rajesh Arora, sir.
Good morning, everyone. So it's my pleasure to introduce Dr. Rajesh Arora, Scientist G and Additional Director, DRDO, DPAS, Delhi. His innovative contributions in the area of drug design and development using biotechnological interventions have received wide international acclaim. He was actively involved in the training of trainers and responders during the Commonwealth Games 2010. Dr. Arora has been visiting scientist in European Union. He is a recipient of several prestigious international and national awards, including DRDO Laboratory Scientist of the Year Award 2010 and DRDO Technology Group Awards. He serves on the editorial boards of more than 25 international journals. Dr. Arora has more than 250 publications, 17 patents, and 14 books to his credit. Today's the title of his talk is Modern Biopharmaceuticals from Evidence-Based Complementary and Alternative Medicine, Walking the Right Rope, Reverse Forward. I welcome Dr. Rajesh Arora.
A very good morning to all of you. And thanks to Dr. Bhupesh Sharma for kindly introducing me and the esteemed members on the dais. Off the dais, I can see many of my friends and students here. And it's indeed an honor and a privilege. And at the outset, I'm very grateful to Dr. Navneet Sharma, uh, who has also been our student in MAS. And it was very kind of him to have invited me to give this opportunity to share what we do in DRDO. So especially for the students, I think this is an opportunity for you to know a little bit about DRDO. So I'm going to be speaking on a topic that is, in fact, the theme of this very conference. And I must say that I work in the life sciences cluster of DRDO, which is in fact the lifeline of the armed forces. And we do some work on biopharmaceuticals for very specific purposes that includes the military applications. And then I will be focusing on molecular farming and how from nature biosimilars and biopharmaceuticals have been developed. And I'll then delve upon three case studies. One is cancer, the second is radiation countermeasures, and the third is a little bit about biothreat mitigation and the way ahead. So effective translation of Chem-Biopharm research into applications is very vital, and it's the very theme of this conference. So before I begin, I would like to give, for the benefit of the students, the a glimpse about DRDO, which is dedicated to nation building, the organization to which I belong. And it happens to be the largest R&D. Is it visible to all of you? May I have your attention, please? You can see the slides? Okay. So DRDO is the largest R&D organization in the country, and it's mandated to strengthen the armed forces, and the activities are very well aligned with the national defense strategy. In fact, DRDO has been a harbinger of Atmanirbhar Bharat, wherein we had been developing technologies, and that is the very motto that has been given by our Honorable Prime Minister, Shri Narendra Modi ji, to take it forward. DRDO is clustered into 8 technological domains, and we have a strong partnership with several industries, academia, and private partnerships, and also S&T agencies, and more than 500,000 crores worth of indigenous products have been inducted in the Indian Armed Forces, and they are being used. And DRDO is undergoing a big transformation, wherein we will be a big contributor to Atmanirbhar Bharat in coming years and take India to the first position and being a developed nation by 2040. So DRDO technologies have placed India amongst the world's elite group of 4 nations that have the multi-level strategic deterrence capabilities. And you would have seen from the media also that the ballistic missile defense technologies have been developed by DRDO and inducted into the armed forces. So we are amongst 5 nations that have its own ballistic missile development program, 6 nations to have developed a nuclear powered submarine, 7 nations to have its own main battle tank, and a 4th plus generation combat aircraft Tejas. And very recently, a few days back only, you saw the MIRV soaring into the sky, which has brought us into the elite nations of, amongst the elite group of nations that possess this technology, which is very, very complex. So these are the clusters of DRDO, wherein life sciences happens to be the yellow one, happens to be the area where we work. And if you look at our country, it's quite diverse. Extreme terrain and environments are there. Probably no other country has such an extreme terrain and environment. We are surrounded from all sides. The total border is approximately 15,000 kilometers. So we have to take care of the soldiers' health and other security related issues. And we continuously strive towards this. In life sciences, people do ask that what does DRDO do in the area of life sciences? So we work for the warfighter, we work towards mitigating the threat, we provide operational support to the soldiers, and we also develop human capital. So right from the beginning, the moment the soldier is inducted, the DRDO technologies take him and make him into the soldier that we see today. So we work in diverse areas, right from selection, the food and nutrition, providing protective clothing and equipment, the health and well-being, performance enhancement, CBRN training, man-machine interface, that's very important, motivation, self-development. So almost every aspect of the soldier is looked after by DRDO. The canvas of R&D activities are very, very diverse. So before I come to my own, I'm sorry, this is not working again. So before I get back to the lecture, I would just like to show a video of a film that we have made on the institute to which I currently belong, that is the Defense Institute of Physiology and Allied Sciences, because I can see that many of the students at the back, they're feeling that it's going to be a very boring lecture. So probably a film would be better for them to see. So let us, sound bhi kar dijiye. So let us just sit back for 10 minutes and see what we do in DIPAS.
The importance of strategic location of India. Indian armed forces play a pivotal role in protecting our geopolitical boundaries. The Indian Army deploys soldiers in the hostile terrain and extreme weather conditions, which is a formidable challenge for their sustenance and performance. A soldier must always be fit to fight, both physically and mentally. The insurmountable and invincible courage of Indian soldiers, their intelligence and reasoning ability is what gives them an unmatched reputation. Their dedication towards the nation is what keeps us sleeping peacefully in our beds. Physiology, an experimental scientific discipline that provides a thorough understanding of normal body function, is of central importance in medicine and related health sciences. Good health leads to all work accomplishment. Research in military physiology was started in 1952 at Defence Science Laboratory, New Delhi. The essence of a full-fledged physiology institute was felt from the ashes of Sino-India War of 1962. The need was to prepare Indian military for similar conflicts in the future, and therefore, with recognition of environmental physiology and ergonomics as prime thrust area, the Defence Institute of Physiology and Allied Sciences, DIPAS, was officially instituted on 20th September 1962 at Delhi Cantonment and shifted to its present permanent premises at Dimarpur, Delhi in the year 1993.
DIPAS is the only institute in India that conducts physiological and biomedical research on soldiers to improve their operational efficiency in extremes of environment. The institute was established with a vision to be a center of excellence in the field of environmental physiology and human factor research.
With a motivated technical team of scientists and diligent administration, over the years, DIPAS has developed core competence in the areas of physiological adaptation to environmental stress in myriad ways. This has enabled DIPAS to design and develop many life support systems and technologies for improving the habitability of Indian armed forces. The three-stage acclimatization schedule of 14 days for high altitudes for induction of troops was given by DIPAS. Intermittent hypoxia exposure at sea level using multi-crew human decompression simulation chambers has evolved as an effective strategy for rapid induction in emergency-like situations. DIPAS has developed solar-powered, solar-heated oxygen enrichment shelters for providing extra oxygen under hypoxic conditions. A fuel-efficient space heating device, Bukhari, has been developed for proving relief in sub-zero temperatures. It also has low carbon monoxide emission and is safe from fire hazards. Due to scarcity of water at high altitude, a solar snow melter has been designed and developed to provide drinking water from snow. The melted snow water can be collected in a solar-powered water storage tank. Besides the devised solutions for habitability in extreme climatic conditions, DIPAS has also developed same pharmacological approaches as prophylactic and therapeutic modalities for sustenance like GFIT developed from medicinal mushroom Ganoderma, quercetin, a physical performance enhancing nutraceutical bar, and a ready-to-eat cognitive enhancer, Cognobar, that improves mental functioning like memory, decision-making and alertness. Frostbite is the severest form of cold injury and is a serious medical problem for our soldiers working in the glacier region. Aloe vera-based cream Local has been developed for offering effective protection from frostbite, sunburn, chafing off skin. DIPAS has developed a potent herbal wound healer, HerboHealer, in the form of topical cream using sea buckthorn extract that promotes rapid and aesthetic healing of normal and chronic non-healing wounds. To harness the ancient knowledge of yoga towards improving our soldiers' health, this institute has been working on scientific evaluation and validation of different yoga asanas. DIPAS has developed customized yogic modules for armed forces operating at high altitudes and in deserts. Thousands of soldiers are being trained using these yogic modules at unit locations with real-time recording of various physiological parameters. Ergonomics is one of the sole areas of research for optimizing soldiers' performance through human-centric approach. Over the years, many state-of-the-art facilities like 3D motion analysis system, electromyography, eye tracker, metabolic measurement system and simulation, and human modeling software. Valuable recommendations were provided with respect to light combat aircraft, bulletproof troops carrier. Customized guidelines are also provided for load carriage under various natural terrains. The ergonomically designed 70 and 90-liter backpacks, combat boot, multi-purpose load carriage ensembles, flexible water bottle and lightweight snow boot have been developed. The institute has collected anthropometric data of more than 10,000 Indian Army troops belonging to different ethnicities using 3D whole-body human scanner. 13 combat uniform sizes covering entire ethnic population were developed and adopted by Indian Army. Another remarkable achievement of the institute is development of female full-body protector, Prabala, based on Indian female anthropometry. This is a lightweight protective ensemble and the first of its kind for safeguarding the female troopers in riot-like situations. Noise-induced hearing loss in military and industrial environment is considered one of the most common occupational health hazards. Active noise-reducing ear defenders and stellar earplugs are designed to provide protection against the high impulse noise levels encountered during firing of weapons. It also provides minimal disturbance from the background noise for smooth communication. DIPAS is working towards optimization of sleep and cognitive functions under stressful environments. It has a state-of-the-art human sleep laboratory to carry out research in the field of electrophysiology and neurophysiology. A fatigue monitoring system is developed for pre-flight assessment of mental fatigue of Indian Air Force pilots to avoid aviation accidents. DIPAS has a human climatic chamber facility that simulates hot dry and hot humid conditions that are prevalent in real terrains of desert. The chamber is well equipped for conducting research in the field of heat physiology. Prolonged stay at high altitude areas causes systemic hypertension and associated cardiovascular problems. To counter such issues, DIPAS carries out extensive research on cardiorespiratory physiology. Adequate nutritional support is a must for maintaining highest level of physical fitness under different operational situations. The periodical review of nutritional requirements followed by adequate recommendations for the armed forces and paramilitary forces is a regular activity. DIPAS has good infrastructure with some sophisticated test equipments and facilities like anechoic chamber, bomb calorimeter, high-performance thin-layer chromatography, atomic absorption spectrometer, fluorescent bright field microscope, flow cytometer, in vivo imager, confocal microscope, and so on. With the advent of modern technologies, huge amount of data is generated. DIPAS is making a systematic attempt to compile and analyze this data and derive desired knowledge by improvising bioinformatics to tackle the situation. DIPAS is in close collaboration with academic institutes of excellence like AIIMS, JNU, IGIB, Delhi University, Bharathiar University, ISRO, IITs and industrial partners for research and development of its products. DIPAS has international collaboration with Kyrgyzstan. The efforts have culminated into the establishment of Kyrgyz-Indian Mountain Biomedical Research Center in the year 2011. And the high-altitude field station at Syok Pass was inaugurated by Honorable Prime Minister Narendra Modi in 2015 with sophisticated research infrastructure. As the whole world is grappling with the pandemic of COVID-19, DIPAS has played a key role in the war against COVID by establishing the Molecular Investigation Facility during May 2020 with concordance from ICMR India. As a part of preventive measures against transmission of coronavirus, many products such as UV sanitization box and handheld UV device, a 2-piece breathable PPE, herbal spray Herbo Schwas, an IgG ELISA test kit called DIPAS VDX, and customized yoga packages have been developed. In a parallel effort to curb the current pandemic, a vaccination drive has been initiated by DIPAS with the help from state and central agencies. Maintaining highest level of cognitive and physical performance would be possible using integration of modern technology in 10 sciences. For example, genomics, proteomics, transcriptomics, nutrigenomics, etc., nanotechnology and system biology. Continuing with the persistent efforts to optimize the human-machine interface, thereby enhancing our soldiers' performance and efficiency, the Institute is presently engaged in design and development of bio-inspired passive exoskeleton, extreme cold weather clothing system and formulation of ergonomic recommendations for use of ballistic headgear with sister laboratories.
Now our endeavor is on disruptive technologies that include genomic cards for precision medicine, for sustenance and performance in extreme environments, and molecular therapeutics.
DIPAS is an indispensable pillar of life science cluster that strengthens technological bone of DRDO. DIPAS is in quest of making a powerful and self-reliant Bharat. DIPAS is unique and to become unique. Dr. APJ Abdul Kalam once said, "To become unique, the challenge is to fight the hardest battle which anyone can imagine until you reach your destination." DIPAS, scaling new heights, establishing new frontiers. Jai Hind.
Thank you. After a glimpse of what we do for the soldiers, we primarily provide service to the soldiers. So now I will get back to the lecture. So I had thought that probably for the benefit of the students, this is an opportunity to share what DRDO does, so how DRDO impacts the lives of the soldiers. So you won't get this opportunity many a times. So I thought that I must share this film with you. So getting back to the lecture again. छोड़ दीजिए नहीं यहाँ नहीं है okay yeah so again getting back to the lecture, the highest recognition is the Nobel Prize, and this was accorded to natural product entities. It was a challenge that the natural products were never given a Nobel Prize. So this was accorded in the year 2015 in the form of recognition to Professor Yu. Excuse me, please. Who is there to operate this? Can you just remove the screen? Niche wala screen. So this 2015 Nobel Prize in Physiology was given to Professor Yu for the discovery of ivermectin from Streptomyces ivermectis. And artemisinin from Artemisia annua नहीं जाएगा? Full screen कर सकते हैं? Okay. Okay. 1 minute. Sorry for this inconvenience. I guess there is. Can you get back to the presentation, please? You open this PowerPoint presentation. No, not this one. The middle one. Yeah, so the 2015 Nobel Prize went for the discovery of natural products that included ivermectin and artemisinin. So artemisinin is an antimalarial compound that, okay, thank you. Artemisinin is an antimalarial compound that finds very good use, particularly for the management of cerebral malaria. And ivermectin, many of you would have heard during the COVID also, it was administered to patients. Now, this particular discovery was given the Nobel Prize in the year 2015, and this is from one of the slides from the Nobel laureate, Professor Yu. So Shakespeare once said that what's in a name, so that we call a rose by any other name would smell as sweet. So why I'm taking you to this is that there is something in the name. And Professor Yu too, who got the Nobel Prize, said this, that my first name Yu was given by my father, who adapted it from the sentence in Chinese that translated as deer bleat Yu, while they are eating the wild how in the Chinese Book of Odes. And interestingly, please take care of this.
Yes, sir.
I'm sorry for the inconvenience. There is some problem with the
No, sir. It's
slides, I guess.
It's done, sir.
आप डायरेक्टली स्लाइड को ही प्रोजेक्ट कर दीजिए ना।
एक मिनट।
So anyway, till they are doing this. Hello. Yeah. Yes, so very interestingly, Yu means wild how, which refers to Artemisia annua. And the name of the scientist who got the Nobel Prize was also Professor Yu. So there's quite a similarity between the name. And that she was named by her father. So there is something in the name as well. We would have got the Nobel Prize in India primarily because of the research that was done in CDRI and CMAP. CMAP and CDRI both had contributed to this, but we missed the bus and the Nobel Prize went to China. As you can see from this slide, that the initial research work was carried out at CMAP, and the technology was given to CDRI for doing the pharmacological studies. And the entire work started way back in 1984. And the Nobel Prize came in 2015. So we missed the bus because we could not translate it. So that is the importance of translational research. Nevertheless, around 70,000 hectares are under Artemisia cultivation, thanks to the work that has been done at CMAP in Lucknow. Now, cancer research has its origins in military. Almost all forms of innovations and technologies that come, they owe their origin to defense research. Whether it is the internet that we use, whether there are so many anti-cancer drugs or other chemical molecules of biopharmaceuticals, most have come from military research. So there's a connection between anti-cancer drugs and radiation protection where we work. So I just wanted to bring this, that many of the anti-radiation drugs that are there, they belong to the category and they were developed by the US Department of Defense. So cancer is not one disease, it is multiple diseases, and it is one of the leading causes of death, and it almost the second leading cause of death. And just yesterday, I was able to see from the cancer statistics 2024 that has been published, which shows that more than 2 million new cancer cases are expected in the US alone. And that's a very grim situation, and you can imagine for the world how things are changing. The estimated cancer deaths, of course, are increasing day by day. And the problem is that it is also getting to the developing nations rather than being confined to the developed nations due to a variety of reasons. I'm not going to go into the details of that. And cancer statistics 2019 showed that there is some hope because both in men and women, 30 to 50% of cancers are in fact preventable just as a result of lifestyle changes and other changes. So there is a very good connection between radiation and cancer. Why I'm trying to bring that upon you time and again is that because we work in both areas, in the area of radiation and cancer biology. And we have to focus on weapons of military destruction for developing the counter strategies, particularly against chemical, biological, radiological, and nuclear weapons. For military missions, we need unique biopharmaceuticals, and because the needs are very unique. So here you can see that we have developed several technologies. Dr. Nidhi Sandal, I'm told, will be speaking from INMAS. So she will also tell you about some of the drugs that have been developed at INMAS. And these are very essential for our military purposes. Handling NBC emergencies is a priority for us, being in DRDO, and as a result of the technologies that we had been developing over the last several years, we were able to handle COVID. During the COVID pandemic, we were able to bring out more than 250 different kinds of innovative products for management of COVID. The anti-cancer drug market stands at nearly plus 220 billion because this data is from 2022. And if you look at the top 15 best-selling drugs of 2018 and even maybe 2024, I was trying to get this data yesterday, but could not get it, that more than 6 out of 15 drugs, almost 40% of the drugs are anti-cancer drugs. Plant drugs are of most economic value, and these are some of the anti-cancer drugs of plant origin, which come from the plant Catharanthus roseus, vincristine and vinblastine, on which I have worked. Podophyllum hexandrum, I've worked on this too, which yields etoposide and teniposide. Taxus brevifolia, I worked for some time. Combretum, yes. Hippophi rhamnoids and Camptotheca acuminatum. So today I'm going to be focusing only on Catharanthus, Podophyllum, and Camptotheca acuminatum. Now, these are the FDA-approved anti-cancer drugs, which include right from vincristine, vinblastine, etoposide, paclitaxel, teniposide, a huge armamentarium of drugs. And they're all FDA-approved and used. And so if somebody tells you that plants are of no value, just tell them that it is not so. Most of the allopathic drugs that we use today owe their origin to natural products. Though nobody wants to accept that, I'm repeating this, but still, even as on date, you can just see that the FDA-approved drugs, all of them owe their origin to natural products. But what are the problems with these natural products? They are usually secondary metabolites, which are high value but low volume compounds because they are produced in very less quantities in the plant. And that is wherein the necessity of manipulating the plants with biotechnological techniques comes into being. These are the Catharanthus alkaloids, which are used in anti-cancer therapy. And the co-discoverers of vinblastine, here you can see Robert Noble and Charles Beer and Helena Jalakovsky. I'm sorry for the mispronunciation. This simultaneous work was done at Eli Lilly's, where Sovoda was also working. And this resulted in the discovery of vinblastine, which is a compound that is produced by Eli Lilly, and almost exclusive rights are with them. And if there is a shortage in the world for pediatric patients, then also the company is responsible for that. Few years back, there was a huge shortage of these drugs in the US. So it is, in fact, vincristine and vinblastine are the world's most essential chemotherapeutic drugs, which are used for a wide variety of cancers, as you can see. And vinca alkaloids are in clinical use almost everywhere around the globe. And it increases the survival rates substantially, and it's primarily used for childhood acute lymphoblastic leukemia and non-Hodgkin's lymphomas. And the chances of surviving have been raised from 10% almost in 1961 to 95% in 2015 and beyond. So initial staging of lymphomas is a difficult thing. And at INMAS, we have used FDG PET CT for identification of these tumors, and their therapy has been suggested accordingly. So these are some of the regimens, because these anti-cancer drugs are usually used in combinations. And here are again some pictures you can see, wherein after therapy for almost 12 months, the cancer has almost vanished. The international market for these catharanthus drugs is very huge, and because they are the source of the anti-cancer compounds, and the charm is that these drugs cannot be synthesized because of the very complex biosynthetic pathway, which has its origin right from tryptophan and geraniol, and the stereospecific condensation leads to cycloganin production, and then again it leads to vinblastine. So it's a very long cascade of reactions that are involved. So having a synthetic molecule is very difficult. But what are the alternate pathways? The alternate pathways include the terpenoid indole alkaloid pathway engineering, which can lead to increased production of these metabolites. And we were able to increase the production of these metabolites using biotechnological methods, particularly the hairy root culture technology, wherein we produce transgenic plants for improving the production of these alkaloids. Here you can see the hairy roots, and we upscaled them in bioreactors, and the production was sustainably shown to be very high. And they were also characterized by NMR and UV and also ESI. So the emerging trends include the use of high throughput transcriptomic data for discovery of the MIA biosynthetic genes, so that they can be engineered and the compound production can be taken forward. For pharmaceutical production, very recently in Nature, there was a paper early last year, wherein they showed that the de novo synthesis of strictocidine, tabasonine, vindoline, and catharanthine is possible in engineered yeast strains. Then coming back to the nuclear technologies, the risks are very high. Why I'm getting back from cancer to radiation protection, because that is a priority area for us in DRDO. And these are the scenarios which can exist during nuclear and radiological emergencies. It's a big challenge for the military and civil population, because of, you are very well aware of the Chernobyl incident, the Fukushima incident, and the Mayapuri incident that happened in Delhi itself, wherein large amounts of radiations were released. So we have to develop those technologies. We are working on radioprotectors, and nearly so far, more than 6,000 compounds have been screened. This is the US FDA approved data. There are not many products which are available. So we employ HTS-based cell reporter models for screening of these compounds. And one of the plants I mentioned, that Podophyllum hexandrum yields podophyllatoxin, which is an anti-cancer, as well as a radioprotective molecule. So we have been able to evaluate the radioprotective efficacy over a period of years, and now the drug is almost in final clinical trials in large animal models, that is in monkeys, and very soon we would be having a drug available. So alternative production systems were established, and an endophyte Tramites hirsuta was isolated by us, and we have made it independent of the plant production. So we have developed this technology which can be upscaled in bioreactors, and the consistent production of these anti-cancer and radioprotective compounds has also been established by us. And they compare very well when compared based on chemical fingerprinting using advanced technologies. Similarly, with camptothecin also, we were able to isolate an endophyte and characterize it and show the production of camptothecin in bioreactors and characterize the chemical compounds, which are very akin to those found in the natural sources. Similarly, for rutin also, we did this and carried out EPR of the rutin and established the radioprotective efficacy of these compounds. Another interesting anti-HIV compound is astragaloside, which is isolated from Astragalus membranaceus. And we were able to establish transgenic plants in this also for the production of these compounds. Then we isolated a radio-resistant bacteria, and which has again resulted in the production of compounds, which is by far one of the most radio-resistant bacteria in the world. Michael Daly in the United States had isolated Deinococcus radiodurans, which till date was the most radio-resistant bacteria. So when Michael Daly came to us in INMAS, we requested him to send a sample of the bacteria to us. So in exchange, we also sent our own sample, and our sample was in fact more resistant than the world's most radio-resistant bacteria. So we've isolated a compound from this, which is again in clinical trials. Dr. Hemant Gautam would be aware of this, and it is now under clinical trials in hare primate models, and it has shown very good results. So very soon we would again be having a drug for this, for our soldiers from this particular compound. We've evaluated the radioprotective efficacy and it works very well. Then biothreat countermeasures, again, is one area. I'm not showing, due to paucity of time, the data on many of the works that we do. And particularly we work on category A agents and antimicrobial resistance, because the antibiotic resistance is becoming a big problem. So we've been working in that area, and we have very, very good leads in this direction. So now the microbe says that I am fed up with this guy. And so then they decide that let us become pathogenic. So that is how they speak to the scientists. They become pathogenic, and we have to develop countermeasures against that. So these are some of the highly antibiotic resistant bacteria where we have developed the countermeasure technologies. And in fact, the drugs that we have developed are better than the third generation or fourth generation antibiotics which are there. Now, the projected size of the biopharmaceuticals market right from 2020 to 2030 in $1 billion is approximately $860 billion. So you can very well appreciate Dr. Navneet's initiative in organizing this conference, because it's a huge area where the market is very extensive. So what is the need of the hour? The need of the hour is capability building. And as you can see from this slide, academia industry partnerships, skilled human resource, industry oriented curriculum, enhanced R&D investment. So all these startups, etc., everything has to come together if we need to get into translational research. And so what is going to rule in the years to come? So these are the recent trends, and the of course, artificial intelligence in biopharma technology is going to be very, very important. And all those biometabolic pathways that I've shown, they can very well be predicted and implemented upon using AI technology. So this is the future of the world as far as biopharma technology is concerned. And just yesterday, again, today morning also, I just went through a list of the novel drugs that have been approved in 2024. So you can see just on 14th of March, the drug to look for is Resdifra, which is used to treat non-cirrhotic, non-alcoholic steatohepatitis with moderate to advanced liver scarring. So this is going to be a wonder drug as far as liver cirrhosis is concerned, and it is coming up. And just on 14th of March, a few days ahead, I mean a week ahead, this particular drug has been approved by FDA. So future directions and challenges ahead in the area of pharma technology and translational development. One would be the heterologous production of the biopharmaceutical compounds in different systems, particularly yeast and other small models, microbial models, wherein you can produce it in large quantities in bioreactors in no time. Sorry. Then the biosynthetic machinery engineering, which I showed with respect to Catharanthus roseus. So that is one area. Then the third would be gene silencing, bioreactor optimization. I have 1 minute or so. Okay. Bioreactor optimization, downstream processing, synthetic biology as an alternative source, and microbial production on a large scale. Now, out-of-box technologies would be new monoclonals, immunotherapy, because immunotherapy is fast coming up as a very good system for management of the cancer patients. Then CRISPR technology and self-healing pharmaceuticals. So with this, I would like to thank and acknowledge the help and support of all my seniors, colleagues, and of course, my students who have been educating me on a daily basis. And I'm very grateful to them and all my colleagues and seniors. And also, I would like to thank many of my collaborators over the period of years, right from almost across the globe. and for funding also. And special thanks to some of the people who specifically contributed to the bacteria that were used for transgenesis. So with this, I would like to thank for a very patient hearing, and if there are any questions, I'll be very happy to address them. Thank you so much.
So, thank
I'm
you,
sorry if I've taken a little bit more time, but
No problem, sir. So, thank you, Dr. Arora.
Yeah,
We can take one or two quick questions. If you have any query, any question, please raise your hand if you have.
any questions or queries?
Okay. So, Dr. Arora, I just want to know what was the content in CognoBar?
Yes.
Because we are interested in neuropharmacology. So, what kind of content was there in CognoBar?
See, Cognobar is a very interesting pharmaceutical ingredient that we have incorporated in it. It is basically tyrosine, and it results in cognitive benefits. And particularly, we have conducted clinical trials in high altitude, because in high altitude, when the soldier goes, there is a lot of cognitive deficit that occurs at high altitude. So what we have done is that we have carried out clinical trials in soldiers when they are there in low altitude and when they go to high altitude. So that is one area where we have been able to show that it alleviates the cognitive malfunctioning that occurs at high altitude in cases of hypoxia. The second thing is that for particular military missions, if you need to maintain the cognitive base of the soldiers, so you can give this particular formulation, and then the soldier can perform the action for maybe a particular time window, and then get back to his duties. The third application is for fighter pilots, wherein extreme concentration is required for mission operations, so it can be used there as well. And of course, in general scenarios also, for certain people who have a cognitive deficit, it can be employed. We are not interested in that. You can take that up in your university if you want to. We have transferred this technology to the industries. We have got a FSI license for this because we went through the nutraceutical route for this. And very shortly, it will be available partially in the market for specific purposes, because right now we have not made it for the general public. Thank you. So if there are no further questions, there are two things that I can presume, that either you've understood everything, or the second one, which I would prefer to say if I were on your side, that everything went above the head. So thank you very much for a very patient hearing.
So, thank you, Dr. Rajesh Arora. And I now request Simran to further continue.
Thank you so much, sir, for giving us valuable insights about the modern biopharmaceuticals from evidence-based camp, walking the reverse rope forward. Now, I would request Professor Malika Pathak ma'am to please felicitate Dr. Rajesh Arora, sir. पीपीटी है जो ऑनलाइन से कनेक्टेड है ना उनकी अभी रुक जाओ नहीं अगर वो बोल Thank you so much, sir. Now I would request Dr. Bhupesh Sharma, sir, to please introduce Dr. Pawan Raghav, sir.
So, Dr. Raghav, am I audible to you?
Yeah, yes, sir.
Yeah. So, yeah. Again, it's my pleasure to introduce Dr. Pawan Kumar Raghav, who is the research scientist in UCSF Health, San Francisco, California. He completed his MSc in Bioinformatics from Punjabi University, Patiala, PG Diploma in Chemoinformatics from Jamia Hamdard, and MPhil in Bioinformatics from the Global Open University, Nagaland. He completed his PhD at INMAS DRDO, Delhi. His main research interest is in the field of drug designing against cancer stem cells. Dr. Pawan Kumar Raghav has worked as Scientist D in the Stem Cell Facility AIMS, New Delhi. He is the recipient of several awards, including the ICMR Travel Award, Research Excellence Award, and many more. He has published almost 40 publications, including international research articles, book chapters, books, Indian intellectual property rights for 3 patents, etc. Today's topic for his talk is impact of HLA antibodies in clinical solid organ and bone marrow transplantation. I welcome Dr. Pawan Kumar Raghav for his talk, and I request that this talk can take 15 to 20 minutes. Over to you, Dr. Pawan Kumar Raghav.
Okay. So are my slides visible? Hello?
Yes, sir, the slides are visible.
Okay. First of all, I would like to thank Dr. Navneet Sharma to invite me for a talk on important topic on impact of HLA, single HLA unique antibodies in clinical transplantation for solid organ and bone marrow transplantation. So here in the UCSF, we are working on the clinical transplantation, and we have the data for solid organ transplantation for liver, heart, kidney, and bone marrow as well. So this is the figure which represents my earlier work, which shows the role of HLA in COVID-19. So now today I'm not going to talk about the COVID-19, but here I want to talk about the impact of the HLA antibodies. So that's it. So the lymphocytes are the prominent markers of HLA class 1 and class 2 molecules. What happened during the clinical transplantation, during bone marrow transplantation or the solid organ transplantation? The clinicians need to match the recipient and the donor HLA matching. So if the recipient HLA matching is matched with the donor HLA genes, then it's a perfect match. If it doesn't match and shows some mismatches, then clinicians cannot proceed with the transplantation. So one by one, I will talk about what is the HLA matching, what is the typing, and how clinicians do the transplantation in the clinical settings.
So, Dr. Raghav, we are unable to see your slides. Can you share it?
Yeah, I'm just sharing its Are you able to see my slides right now?
Yes, now they are visible.
Okay. So I begin with the background. So approximately 0.1 billion adults have been listed as the waitlist candidates for the kidney transplantation in the United States. This is the report of Organ Procurement and the Transplantation Network in 2021 report. So wherein 62% waiting for the transplantation are male and 38% are females. So I'm facing some problem. My slides are not moving. So pre-existing HLA antibodies, sorry for the inconvenience. So pre-existing HLA antibodies produced in the sensitized patient sera are barrier to the organ transplantation. So it is important that to identify the HLA antibodies in the post-transplant patients, which have been shown to be strongly associated with the poor graft function and the graft loss. The serum IgG antibodies bound with the HLA antigen that decide the sensitization level and rejection of the organs. So it is important to prior detection of anti-HLA antibodies in the patients that aid in selecting compatible donors to minimize the risk of antibody-mediated rejection. So anti-HLA antibodies therapies are not efficient to prevent the antibody-mediated rejections. They are very less efficient, and there is some regular drugs, IVIG, clinicians are giving to the patients, but is not effective. So where are the knowledge gaps? The single antigen bead SAB method assay is the most sensitive method widely used to measure the serum donor-specific antibody titers of HLA antibodies, but provide lots of the false positive. So however, its poor correlation with the flow cytometry cross matches obscure the clinical relevant HLA antibodies. Despite its role in transplantation, the potential epitopes where antibody binds to the HLA epitope allotypes remain largely unknown. Some epitopes have been identified using adsorption assay and the mouse clonal antibodies. However, the epitopes of the HLA antibodies in transplant patients have been poorly characterized. So applet is a set of the amino acids where antibody can bind is important, and its matching is important and is a key focus for preventing the donor-specific antibody formation and prolonging the viability of the transplanted organs. Yet specific applet mismatches instigating the alloimmune response remains unclear. So our main objective is to determine the significance level of the alloantibodies that can serve as a biomarker in rejection of the kidney transplant, and to map the HLA antibody epitopes by defining the reactivity on single antigen beads. So this represents the overview what we are doing in our clinical R&D lab. So we have the technique, we are using the technique that is Luminex single antigen bead assay that is required to detect the antibodies in the sensitized patient seras. So we have the patient seras and we detect the antibodies in the seras. So this technology which we are using, the HLA molecules are conjugated on the beads. So that is detected by the that is incubated by the serum antibodies, and this that further incubated with the secondary antibodies to detect the serum antibodies of the patients. So these Luminex techniques have the 122 core HLA molecules, whereas the IMGT database reported more than 60,000 sequences of the HLA molecules. But the 120 are the common among the patients, which occurs frequently. So here, what we are doing, we we extract all these conjugated beads HLA sequences and prepared in multiple sequence alignment to locate the unique amino acid. So we have the data for over the period of the 8 years that is associated with the HLA antibodies in human kidney transplantation. So like in the small map that I will explain in later, that black one represents the all the 122 core HLA anti molecules, and the red one, which we have detected in our cohort, that is antibody positive. Then we have the data for NGS HLA typing data using the KDX machine. And we do the HLA mismatching, like the recipient having this type of the HLA sequencing and donor have this. If the HLA of recipient and donor doesn't match, then we have the mismatches. Like here, A11O2, recipient having the A11O2 gene and donor having A11O1 gene, that is a mismatch. AT is a match, B37 is a match, CW5 is a match, DR53, and here in the donor it's DR51, that's a mismatch, but here is a match. That means we have the total mismatches. In our R&D lab, we have created our own program using the Python and the R programming to match and mismatch, to calculate the mismatches and the matches between the recipient and the donors for at a large scale, because we have the data of our patients about 73,000 samples. So it's very difficult to do it manually. So we created a program. We are using that program. It is working very good. So for the functional assay, what we are doing here, we are doing also the cross matches. So there are two type of the cross matches. First is the flow cytometry cross matches, and second one is the complement dependent cytotoxicity cross matches. So what we did in the cross matches, we have the recipient serum with HLA antibodies. We incubate with the donor lymphocytes, B cells and T cells, and assess that whether these antibodies are killing the cells or not. So in the flow cytometry, we plot the graph along median channel shift and the fluorescent mean intensity of the antibodies. And we look at the based on the threshold for the B cells and the T cells, how much antibodies are the real and how much they are killing the cells. And this is based on the complement dependent cytotoxicity assay. We found two types of the cross matches, like the negative cross matches and the positive cross matches. For the negative cross matches, no donor specific HLA antibodies found. There is no lysis. That means where there is a lysis, there is a positive cross match, and clinicians do not do the transplantation for that particular patient. So we have prepared the multiple sequence alignment of the 120 core HLA molecules and locate where are the unique amino acid, and where we called it the potential epitopes. So we have the real experimental clinical data. We are using the bioinformatics techniques to locate the epitopes, and we are doing in the clinical settings. And the same thing which we are locating on the three-dimensional map to locate whether the particular unique amino acids are buried or it's exposed and are available for the antibodies. So here we are doing the flow cytometry cross matches. We have the single antigen bead assay to identify the epitopes, and we are doing the three-dimensional mapping and these sequence matching also. So this flow chart which we have developed to identify the transplant patients, which making the antibodies against a single unique HLA specificity. Over the period of the 8 years, 73,000 sera tested for the HLA antibodies, out of which 24,857 sera positive for the HLA antibodies. So out of which 2,436 sera with a single HLA antibody specificities detected by the SAB assay, which comprised of the 650 patients, out of which 176 patients display a single unique HLA antibody specificity in all sequential sera. That means we tested the same patient seras multiple times. Some patient tested like 20 times, some patient tested only the 2 times. That is due to the availability of their patient samples. So this flowchart is to screen out the single unique HLA antibodies detected in this cohort. So out of which 157 patients display a single unique HLA antibody specificities in all sequential sera, at least one serum with MFI 5000 or higher. Most of the patients are the kidney patients, but non-kidney patients are from lung, like other organs also, lung, heart, kidney, bone marrow, kidney, pancreas, kidney, liver, and pancreas. So we are focused on this cohort, which displays a single unique HLA antibodies with the MFI more than 5,000 or higher. And we are not considering any MFI which is less than 5,000. So out of 157, 107 patients with a single unique HLA class 1 antibody specificity were displayed. And out of which 42 patients attained single unique HLA-A antibody specificity, 49 attained single unique HLA-B antibody specificity, 16 patients attained single unique HLA-C antibody specificity. Whereas from 50 patients for the class 2, 50 patients attained or displayed the single unique HLA class 2 antibody specificity. Among them, 51 attained the HLA-DR antibody specificity, 35 displayed HLA-DQ antibody specificity, and no patient displays HLA-DP antibody specificity. That means clinicians can do the transplantation without the DP antibody, and but HLA-DQ and D are important in the class 2. So, so this 157 patient which displays a single unique HLA antibody specificity in all sequential sera with at least one serum with MFI 5,000 or higher, we calculated the frequency of these patient cohort, and among them we obtained 46 single unique HLA specificities for class 1 and class 2, wherein 33 single unique HLA specificities belongs to class 1 and 13 single unique HLA specificities belongs to the class 2. So when we compare the frequency of all patients among the male and the females, we are surprised to know that males making the more antibodies as compared to the females. That is unexpected, because in general, females should make the more antibodies due to the previous transplantation or pregnancy-induced antibodies. But here the scenario is totally different. So we want to know that these males making the antibodies are from the previous transplantation or previous transplantation, or females making due to the pregnancy-induced antibodies. So here you can see that the males making the more antibodies as compared to the females with no prior transplant as well as with any transplant. That is also very unexpected. So here among the HLA-A, A80, among the HLA-B, B37, and among the HLA-C, CW5, and among the HLA-DR, DR53, and among the HLA-DQ, DQB10603 having the higher frequency of antibody detection. But their calculated panel reactive antigens that represent that the how many percentage of the donors are incompatible. You can see that these patients having the higher frequency, but their CPRA is very low. That means the clinicians can do the transplantation at these CPRA values. But this is not can be done with for the DR53 antibodies, because their CPRA is very high. So according to this data, it shows that the males making the more antibodies as compared to the females. That is very unexpected, and these antibodies do not have any prior transplant. The males making the antibodies without any prior transplant. That is also unexpected. So we want to calculate the HLA immunogenicity in the male kidney prior transplant patients. So we extract this male patient data, which having the prior kidney transplant. We want to see that whether the HLA mismatches trigger the production of the HLA antibodies. So here we are unexpectedly got this information that antibodies percentage of the antibodies are higher without any mismatches. That means mismatches do not trigger the production of the HLA antibodies. So after that, we have in our cohort, majority of the patients.
Dr. Raghav,
Yes.
sorry to intervene, but we request you to please conclude in next 2 to 3 minutes. Thank you.
Okay. So we found that all the HLA antibodies are stable and they retain their original reactivity. So we construct this phylogenetic to locate that the detection of the antibodies. Then red represents that the antibody was detected in our cohort, in this cohort. And after for mapping the single unique HLA antibody specificities, we extract all the HLA molecule data regarding their PDB structures and their sequence information, so that we have constructed a multiple sequence alignment to locate the single unique amino acid, which is represented with the yellow highlights here. So these sequences shows the multiple sequence alignment for the class 1, and these are the multiple specificities for the antibodies, particularly for the HLA AAT, CW17 and CW7. So this slide shows the multiple sequence alignment of the class 2, and the yellow highlight shows the unique amino acids, which belongs higher for the DRB as compared to the other molecules. So we extracted all the three-dimensional data with the higher resolution to map the unique amino acid on the three-dimensional structure. Only the two structures with the complex structure of the antibody and the HLA molecules have been reported till now. So we have more than thousands molecules of HLA, but only two co-crystal have been crystallized. So based on that, we have we mapped the three-dimensional we mapped the unique amino acid on the three-dimensional structures, and we found that for the HLA class 1, these highlights the exposed amino acids. So this is for the HLA-B, and for the HLA-B, HLA B13, B18, and 63 and 82 shows the exposed amino acids. For HLA-C is CW1, CW5, CW7, CW9, CW16, and CW17 shows the exposed amino acids. So this is for the DR molecules, and for the DR molecule, DR4, DRB3, and DR53 shows the exposed amino acid. And this is for the DR molecules, and this shows the DQ2 and DQ5 shows the exposed amino acids. And for the flow cytometry cross matches, most of the cross matches are negative for the class 1 and the class 2 as well. We did the cross match for class 1 for T cells and class 2 for the B cells. And this is the threshold which we have used for the T cells cross match is 50 for median channel shift. And for the median channel shift for the class 2 for B cells, we have used 120 threshold. So we have the data for 301 cross matches, which constitutes of 82 patients for the class 1 and 49 patients for the class 2. And most of them are negative. That means for the single unique HLA antibodies, clinicians can do the transplantation with the negative cross matches data. That means most of the antibodies are negative, and clinicians can do the transplantation. So these are the flow cytometry histograms to show the clear antibodies detected by the single antigen bead assay. So we also did the donors typing for the flow cytometry cross match. If we have the donors typing available with us, then we do the HLA, calculate the HLA mismatching and do the flow cytometry cross matches. If we don't have the donors typing available with us, then we cannot do the cross matches and cannot be done for transplantation. So there is one database, European and American database, which shows that which having their own registry, which represents the applets, unique amino acids. but that is very old, and they have some lack of information like the flow cytometry cross matches and the 3D classification. So when we compare our flow cytometry cross match data, you can see here that only one for HLA class 1 HLA-A molecule, only one is positive cross match. Most of them are negative. But this positive cross match having the buried amino acid. So we are curious to know that how the flow cytometry cross match are positive even for the buried amino acid. There are the other partially exposed and fully exposed amino acid are located on the three-dimensional structure of the HLA molecules, but all cross matches are negative.
So, Dr. Raghav, can we
Yeah.
continue now?
Yeah, sure. So this is for the class B similarly. So finally, we conclude that most of the cross matches are negative, only few are positive, even that the amino acids are buried. So the conclusion is that the epitope mapping is advanced antibody interpretation and identification. This helps to distinguish clinically relevant antibodies and improve the efficiency of the organ allocation, that improve management of HLA antibodies and enhance transplant outcomes. No significant correlation was observed neither between the B cell median channel shift and MFI, nor between the T cells median channel shift and MFI, suggesting the inadequacy of MFI as a sole indicator of the immune response strength. Unfavorable outcomes in the flow cytometry cross-match analysis. It uncover patient-specific variation in the flow cytometry cross-matches outcome, with some patient develop single unique HLA antibody specificities, exhibiting positive research result for buried epitopes. So right now we are working on the cross-reactive epitope groups as well as the multiple antibodies, which would explore the influence of the donor-specific factors on flow cytometry cross-matches outcome. So thank you so much. This is our technologist group. This is our clinical services group, and this is our second antibody group, and this is our R&D lab group. So thank you so much.
So thank you very much, Dr. Raghav, for this extensive work, sharing your extensive work. If we can have any query, if you have any query, please, you can ask quick questions. Do we have any query? Ma'am, you want to ask? Yeah.
Dr. Raghav, thank you so much for such an interesting talk. Actually, it was a pleasure to hear. I just wanted to ask, you said something about women developing less antibodies as compared to men, what you expected. Did you think of a reason why it happened, and what was the reason probably for that?
For finding the reason, that is what the project we are working on. Actually, in general, females should make the more antibodies due to the pregnancy-induced antibodies as well as the previous transplantation. But in this cohort, for single unique HLA antibodies, female are making the less antibodies as compared to the males. So that is unexpected. But we need to compare with our cross-reactive epitope group data as well as the multiple antibodies. It happens that when patients making the multiple antibodies, and in that case, the female should make the more antibodies. So right now we are working on that project.
Thank you so much. Hopefully it will be.
Yeah, thank you.
Dr. Pavan, I'm Dr. Rajesh Arora this side. So hope you recognize me from the
Yeah,
Inma
sure.
Service.
I know.
Yeah,
Sure.
so
Very much.
nice listening to you. And I had a question that currently are you working on the COVID related antibodies as well and trying to improve upon the immune response?
No, sir. Right now, we identify the role of HLA in COVID, and we have identified the some alleles. If the patient's making the having the some alleles like B44 and some HLA-C alleles, they are protected from the COVID-19, and the some alleles are susceptible for the COVID-19. So recently we have published I think We have published in Human Immunology paper. So we have reported several alleles which are susceptible and protective for the COVID-19. But we are not working on the COVID-19 antibodies.
Okay. So the alleles that you've seen, you've also, because there are reports, large number of reports, which say that there is an increased risk of heart diseases, particularly
Yeah.
heart attacks and brain strokes in COVID patients, both due to the disease and also due to the, maybe due to the vaccines that were given. So even today morning also, I read one of the news that there is an increased risk of cardiovascular malfunctioning and brain strokes as a result of the vaccines that have been administered. So any kind of alleles are maybe changed, or maybe there is some kind of a difference in that. Could you comment, please? Based on general, if you may not have worked on it, I can understand, but based on your expertise, can you comment on this, please?
Yes, sir. Actually, in our recent paper that we have published recently, so we consider several factors for males and females, both of them. Like if the patient was admitted with the COVID, so we consider like the fever and hypoxia and several criterias. But for the heart diseases, we don't have the data for that. Sorry.
Okay. Thank you very much and wish you all the best.
Yeah, thank you, sir. Thank you, sir.
Yeah, so Dr. Raghav, thank you very much for this nice presentation, and you are doing a very great job. Thank you very much. I request Simran to please continue with next speaker.
We are honored to have with us Dr. Yogesh Verma, sir. I request sir to please join us on the stage. Can you all please give a big round of applause for him? Now, I would request Dr. Malika Pathak, ma'am. She is currently the professor at Miranda House, University of Delhi, and her specialization in physical chemistry, quantum chemistry, spectroscopy, and computational chemistry. Now, I would like to call her and please introduce Dr. Yogesh Verma, sir.
Thank you, Simran. So, good morning, everyone. I hope you are all in cheerful mood. You look preoccupied with your phones. Please pay a little attention. Right. Okay. So I have the pleasure to introduce Dr. Yogesh Verma, who is the scientist, a senior scientist at NMAS DRDO. He has completed his MSc and PhD in biomedical science from University of Delhi. He's also got another MSc degree in bioinformatics from Punjab Technical University. He joined NMAS DRDO. I hope you know where is NMAS. Can we have an attention, please? Hi, everyone. Can we have your attention, please? Right. So do you know where NMAS is? Yeah, so where is it? Near North Campus, yes. Right. So he joined NMAS DRDO as a scientist C in the year 2009. He's got many publications and many patents to his credit. He's presently working in the areas of molecular biology, bioinformatics, stem cell research, regenerative medicine, tissue engineering, and analysis for repairing, regenerating various types of tissues for defense applications. I hope you will listen to his talk with a lot of attention. So we welcome Dr. Yogesh here. Thank you.
So good morning. I think all are awake, right? So thank you, ma'am, for the nice introduction. And firstly, I would like to thank organizer for inviting me here, giving me this wonderful opportunity. So as ma'am said that you all must be knowing in mass, where is this in mass? What is this in mass? So basically, it is a Defense Research and Development Organization Institute. Full name is Institute of Nuclear Medicine and Allied Sciences. It is near Vishwavidyalaya Metro Station. So probably you might have gone over there for probably training purposes also. So I have given the topic of my presentation is tissue engineering and stem cells. So so students, they might be knowing what is this tissue engineering stem cells, because regularly we are listening about what is the stem cells, tissue engineering, regenerative medicine. So what I'll do, I'll try to tell you the basics about the tissue regeneration. What is this? How stem cells are being used? What is the regenerative medicine? What is the purpose of this? And then slowly I'll come over to the work which we are doing in INMAS with relation to tissue regeneration. So because this is a defense institute, so we work towards the welfare of the soldiers, and along with that, the civilians are also getting treated. So there are different type of injuries which normally defense personnel they face, and the most common injury it occurs to lower body, basically to the appendages, right, hands, legs, and the system which are affected are muscles and the bone, most of the times. And the normal treatment, if you see, there is in case the injury is not of that severe repercussion, so on field or the patient is taken to the hospital and the treatment is given. But in most of the time, we can see in the trauma cases also, if there is a mangled tissue, so what is done surgically? The injury is sutured, or sometimes the hands or the legs they are amputated. So in that case, the person is crippled, and for the defense personnel, it is very I mean not it is not good, because he has to leave the job and he has to take the voluntary retirement. So, and the problem with this is that in case if we want to do some kind of transplantation, so what happened? There is a graft versus host reaction, which what I feel, I think everybody might be knowing. And the direct application of the cells to that area is not possible, because the area at that time, it is full of inflammation. The conditions are adverse. So the direct transplantation, the regeneration is not possible. So here comes the role of tissue engineering. I think backside students, they can also pay attention. So this is not the research which I'm talking about. This is the tissue engineering, where what we do, we combined different areas of science. Basically, it is a interdisciplinary field where we combine cells, basically the stem cells, the materials, basically the biomaterials, and the growth factors. We combine them together to make a scaffold or a kind of material which can be transplanted to regenerate the injury. And I'll go one by one with all the terms. Do I have the presentation ke liye any pointer or something so that I can pinpoint? Chalo, I'll use this, no issue. So I'll give an analogy how tissue engineering is helpful. Suppose this is a room, this is empty room, and there is nothing in this room, right? So there is no AC, no light, nothing is there. So do we feel comfortable? No, right? So that is basically this is basically the empty room where we can come and we can go. Similar thing happen with the cells also, right? If we use any material in the body, cells may not like to stay there. We need to give them some support. So like we have chairs, we have electricity, we have everything. So we will feel comfortable. So that is what we have to provide along with the scaffold material. We have to provide them with the other amenities which we are having here. The same thing happen when we do the transplantation. Scaffold, that is why scaffolds, they are used with the cells as well as the growth factors. Growth factors, they provide the cues for the proliferation and differentiation to the cells.
And this is the procedure which we used in the tissue engineering purpose, where the cells are taken up from the body. They are incubated with the materials which we take up and the growth factors, and they are retransplanted back. The biomaterials are simply the material which are compatible with the body, like the like coat and shirt and shoes. They all are biomaterial which are biocompatible. Now, if I specifically come over to the stem cells are those cells, and this query can also be raised that why stem cells are taken, because they have the infinite property of proliferation as well as differentiation. They self-renew, they make their bank inside the body, and they provide the new cells to the body whenever there is a requirement. There may be injury, there may be other issues with the body. At that time, these cells are always available. And we must have read about the different type of cells. The stem cells, basically, they are totipotent, pluripotent, and multipotent. And induced pluripotent stem cells are also there. And recently, there was a report that the induced pluripotent stem cells have been made for the animal also. Recently, it was there where they have, the scientists, they have induced the expression of the genes used by the Yamanaka for making the iPSCs and inhibiting the expression of P53 gene. So that is how they were able to produce the iPSCs of the animal, basically the elephant origin. Along with that, the cells, basically the mesenchymal stem cells and their excreted factors, they are also used for this purpose. So this is the first part which is used for the tissue engineering purpose, right? The first component. And there are other applications of these stem cells also. Then coming to the second part, the growth factors. So growth factors, why they are required? Because if we use only cells and the biomaterial, cells will not grow. Just like us, if we don't get the food, water, we will not survive. So same thing is there, the growth factors. And third thing is biomaterials, which we use. And any biomaterial we cannot use for the purpose of the regeneration or the repair. So biomaterial should be biocompatible. It should be biocompatible. It should have biofunctionality and should have some physicochemical properties which are compatible with the human system. So these are, I mean, the basic properties which a material should have. And the biomaterials, they are classified as per the polymers, metal, ceramic, and the composite material. They have different application. I'll come down to that. And there are different methods of making these biomaterials. And once we synthesize, we characterize them, then they are tested in vitro and as well as in vivo. So, and whenever we are working with the biomaterial, we should follow some guidelines, the guidelines which are given by the American Society for Testing and Material. So we should follow. And apart from that, once the material clears those guidelines, we should take that material for the GLP evaluation for DCGI clearance. So these are some of the materials which are already in the market, like vascular grafts, lenses, heart valve, then artificial hip joints, implants, these are already there. And nowadays, these materials are also being used for the human-machine interface. So just like biosensors and all those things, they are coming into the picture. Now I'll come over to the activities which we are doing in INMAS. Right, so we are basically focusing on the hard and soft tissue regeneration, soft tissue muscle or the muscle regeneration, corneal bioengineering. It is basically the outermost layer of the eye, which is transparent in nature, which is very specific property. The bone marrow transplantation, wound healing, these are some of the areas on which we are working. So coming to the first part, I've already given you the basic that what tissue engineering requires. It requires three things: cells, scaffold, and growth factors, right? So here, what we have done, as I said, the defense injuries, they are complex in nature and they need different type of regeneration depending upon the injury. Here we have tried to make a scaffold which is consisting of natural as well as the ceramic type of material. We have made a bilayer scaffold. The upper part of the scaffold or the one layer of the scaffold will regenerate the soft tissue, whereas this lower part, the layer edge, it will regenerate the hard tissue, right? And now this is only the scaffold. We wanted to give it some growth factors, right? So here we have identified by doing the data mining that BMP4, the bone morphogenetic protein, it is a molecule which can give rise to angiogenesis, osteogenesis. So we have used this molecule by doing the data mining, retinoic acid. It was embedded inside the drug delivery system made with the alginate. And this whole scaffold, it was transplanted into the rat model. The model was created, and we have seen that this scaffold was able to regenerate the muscle as well as the bone tissue. So I'll show results one by one. So here you can see we started with the finding of the molecule which can regenerate multiple type of tissues. So here what we have done, we have used the gene expression omnibus database, that is the microarray data. We have compared the mesenchymal stem cells control with the whatever was available, and then we have found out the genes responsible for the induction of multiple processes. Here you can see we have screened out some genes on the basis of different processes like osteogenesis, adipogenesis, the myogenesis from the different across the database, and we found out that there is one molecule which was coming common among all the processes, and that was bone morphogenetic protein. This bone morphogenetic protein, direct application of this protein might not be that successful because protein, they have short half-life. So now we wanted to see like how this BMP4 can be induced in the in vivo system. So again, we did the data mining and drug to gene interaction, and we found out that this BMP4, this can be activated by the retinoic acid, which is already FDA approved drug used by us also. But this was only the predicted interaction. So what we did, now we did the in silico. We prepared the model of the BMP4 protein, retinoic acid, docked them, did their MD simulation studies to find out the stability between these two molecules. And what we found out that this retinoic acid has the very good binding with the BMP4. So it is likely to induce the different processes regeneration. Then I said, now the molecule is ready. Now we wanted to make the drug delivery system. So here we have used alginate. So alginate, basically, it is a negatively charged molecule. Anything, if we use negatively charged molecule with the cell, it will be repelled. The membrane of the cell is also negatively charged. So what we did, we converted this alginate molecule into the positively charged molecule, characterized it, loaded with the retinoic acid. Then we have seen whether the retinoic acid is getting released from the system or not. So what we found out that there was the consistent release from this drug delivery molecule. So now the drug is ready and the drug delivery system is ready. Now we wanted to know what is that scaffold which we should use for the regeneration purpose. Already I have shown that what we have used, but all these biomaterials, all these combinations, most of the combinations are known, well reported in literature. So how to find out the optimum concentration and the combination? This is similar to the dish or anything which we make in the house also. Any dish, many times we standardize to how to get the best taste, best flavor. So how to do this? So there are many techniques. Earlier, the QBD technique was there. Now we have used this, the in silico technique, which is known as response surface methodology, where you give the input and it will find out what would be the best optimized condition where the scaffold, the biomaterials can be combined and get the best results. But here you have to do many experimental results. You put the output into the system and system will give you the result. So here, by doing this, we zeroed down onto 4 combination, which we have given the name GCT 0, 10, 20, and 30. So here you can see the scaffold was prepared. These are then we did all the physicochemical characterization as I described earlier. The SAM characterization, because this porosity and all this is required, because if the scaffold doesn't have the porosity, cell will not go inside it, they will not reside there. Then the strength, why strength? Because the tissue which we want to repair, suppose bone we want to repair, the scaffold should also have the similar mechanical strength. Otherwise, it will not support the growth of the tissue. So the mechanical strength, then we did the swelling studies. Then what we did along with the scaffold, now we wanted to see the biocompatibility of the cells, because cells have to reside there. So we did this with the human mesenchymal stem cells as well as the mouse mesenchymal stem cells. We did all the biocompatibility studies here, the degradation studies, and this I said earlier, this is the loading and release of the retinoic acid from the drug molecule. And then that scaffold was ready. Scaffold, cells, drug delivery system, and retinoic acid combined together. It was transplanted in the tibialis area of the rat, the Sprague Dawley rat. And these are the MRI the images, and you can see this is that combined system. And within 7 to 14 days, we saw the significant improvement in both muscles as well as bone. So if you can see, there is a small hole here. It was drilled inside the bone. You can see here, this is the control negative, so healing was not there. But in this system, you can see within 14 days, the injury was able to repair. So, and this was basically the combined scaffold, the soft tissue as well as the hard tissue. So we saw, I mean, the good results were there, and we filed a patent on this also. We did the hematology analysis, we did the histological analysis. So there were not much differences, but yes, because once we produce the injury, there is lot of the muscle degradation. So we can see the increase in the some values which are increasing in case of liver function and kidney function test. So that was the first part. Then we identified what is the molecular mechanism, how this BMP is getting activated by the retinoic acid. So that I'm not showing here. Now coming to the second part, that was one type of scaffold. This is a different type of scaffold for only for the muscle repair. Again, here we performed the same database mining, the modeling, docking, biocomputation analysis. And here one new thing what we identified was that here the drug which we found out, it was raloxifene. It is a different type of drug. It is also approved by FDA. And the raloxifene here is inducing the STAT3 expression. STAT3 is required for the cellular proliferation. So this is the new information which we got by these blotting experiments and the other experiments. And this we are going to publish this also soon. Again, the RSM was done, new scaffold was produced, and the muscle injury was, we were able to show that muscle injury is getting healed. Now, as of now, the scaffolds which we are using, they were without cells. Now our endeavor is to embed these scaffolds with these cells. Now, using these cells as such in these scaffolds, the cells will not survive, because they need growth factors, they need the media, they need many things. Here what we did, we are trying to develop a technology where cells can be freeze dried. Simply dry them, just like antibiotics. We can get from the chemist, mix the water and resuspend them, revive them. So this technology we are trying. And again, here we have optimized the combination of 3 components and earlier results. And here how we standardize, we chose the mesenchymal stem cells. Mesenchymal stem cells, normally when we characterize them, they should show the expression of the marker, and they should differentiate into 3 lineages: adipocyte, chondrocytes, and your osteocytes, right? So here we freeze dry them for 24 hours, revive them, and these cells were able to differentiate one more time after freeze drying them. So this here you can see these cells are in the form of powder. These vials, I think they are not visible here, but here you can see they look like a powder, and they were able to revive. Other studies also we are doing, like the RNA, DNA integrity and other cell differentiation, other thing. So this thing also we have patented. So now our idea is to embed those scaffolds, maybe dry scaffold or maybe the hydrogel or other type of scaffold, to embed those scaffold with these type of cells. And apart from that, this technology of freeze drying can also be used for many other purposes, right? Like for blood banking and other thing. So that was about the hard tissue, soft tissue, and the muscles. Now this is about the cornea. The outermost, basically here we want to regenerate the corneal stroma part. So basically this is the cornea, and this stromal layer of the cornea is made up of biomaterial. Basically this is mostly the collagen type 1, type 2, type 3. And the one of the very unique property of this material is that this is transparent in nature. Till now, whatever I have shown is not transparent. They are all opaque, they are dry, and we can't see. All the combination is same. Only few biomaterials are known, natural, the synthetic, their combination. But this is the challenge here, how to make the biomaterial transparent. So here, again, we have standardized many combinations, and one very few combinations we have zeroed upon. And here you can see, this is one of the combination out of the 5 combination. Here you can see this is transparent in nature, and its transparency was around 85%, which is equivalent to the cornea. That is why we are able to see. And this transparency is basically due to collagen present in the corneal layer. What happens if the collagen in the corneal layer is arranged uniformly, then we can see through. If they are crisscrossed, the cornea become opaque. So that is the main problem. So here we then we have seen the biocompatibility of the cells, then the degradation. And why degradation is important? Because once the tissue starts growing, so the biomaterial should degrade and should be taken over by the resident cells or the resident tissue.
Yogesh, another 5 minutes.
Right. Okay. Fine. It is done, almost done. And this is one more of the application where we have used the bone marrow cells. We have coated them with the biomaterials, and we have seen that yes, the targeting of the cells was more towards the bone marrow in the femur, and more number of cells were surviving, as well as after radiation injury, more animals were surviving. And this is the last application where we have made a thermoresponsive formulation for the wound healing purpose. And here we can see all the processes, the different phases of the wound healing. They are getting induced, like hemostasis, wound healing, hair regrowth, and this all has been characterized. So these are few of the application which we can thought of. There are, apart from this, there are other applications also, but it depends all on the combination, composition, application, what kind of application. So that is all from my side, and I want to thank again organizer and our director and DRDO for funding, and all my lab members, and all the some of the images I have taken from the Google. Yeah, thank you very much.
Thank you, Dr. Yogesh. It was such a pleasure to hear you speak. And actually about the applications, cornea, muscle, I mean, really something that is valuable for all of us.
Right, ma'am.
So it's a really, really great work. Thank you so much. Is there any question that the students want to ask? Are there any questions from the students? Yeah.
Yeah, she is there.
Can we ask you to come in the front, please?
Thank you for the wonderful presentation, sir. I just want to ask whether you being a research organization yourself submit application for the drug approval to CDSCO, or you give this technology to some other research institute?
See, what we do, because normally after doing these experiments like preclinical, if you want to give it to the company, in my experience, they won't take it. They want all the regulatory approval, like your preclinical from the GLP certified lab.
Right.
Only then they will say that, yes, we are ready to take it. From here, the technology will get it validated for the efficacy and toxicity by the GLP certified lab. Then we'll put the application for the DCGI. So this process is it is going on.
Okay.
So for different type of things.
So
But
because
yes,
we are seeing many products that are coming into this limelight, these stem cell based products these days. Recently, CAR T cell therapy has also
yes,
been
it is
approved by
also there.
DCGI.
Yes, it is.
So I
also-
think it's the next generation biotherapeutics.
Right, right,
Stem
right.
cells.
Right.
And secondly, any of the products have been gone into the human clinical trials and passed the clinical trials yet? From the
No, not
organization?
yet, because
Okay.
these are all very new technologies. Like
Right.
if I talk about the cells which we are drying, this is very new. similar the scaffolds which we are using, because till now the titanium implant, the other alloys implant, they are being used, and the materials which are being used, they are used since long, like PMMA, then there are a different type of bone cement, and there are other things. They are simple material, and there are many properties which affect their functionality. Like if you take the natural material, we can't tune them, right? Whereas the physical material, we can tune them as per our requirement. That is why not many new things are coming up. Yes, but at the R&D level, there are many things, many products coming up. They are mostly under various clinical trials. But slowly, yes, these are things, because like in case of defense injury, we have complex injuries. So for complex injury treatment, things are not available. And at the site and even at the hospital site also. And the last resort is the amputation. So that is the main issue.
Because practically what we observe is that these type of products, they show very promising results in the preclinical trials, animal studies. But when it goes to human trials, either the availability of patients becomes an issue.
Right, definitely.
And then the results, the proper clinical results becomes a problem.
Right. So that is why in case of corneal tissue injury, we have already, the project is where we have three objectives for the synthesis, characterization, and the animal studies. And the fourth objective is to give it to the third party for the clinical validation, preclinical validation, so that once the project gets over, we are ready with the product for filing to the DCGI.
Okay.
So that is how we are doing it.
That's all from my side. Thank you.
Thank you.
Thank you so much, Dr. Yogesh. It was a pleasure, I must say once again, to hear you speak.
Thank you.
So on behalf of the audience and from the organizing committee, thank you so much.
Thank you.
Thank you so much, sir, for sharing immense knowledge with us about tissue engineering and stem cells. Now, I would request Professor Malika Pathak ma'am and Dr. Bhupesh Sharma sir to please felicitate Dr. Yogesh Verma sir. Thank you so much, ma'am. Thank you so much, sir. Now, I would request Professor Malika Pathak ma'am to please introduce Dr. Hemant Gautam sir.
Hi, everyone. I'm back once again to introduce one of the most renowned speakers of today, Dr. Hemant K. Gautam. He's the Chief Scientist and Professor at Institute of Genomics and Integrative Biology. I hope you've heard the name, IGIB? No response, right? Okay. So he's the Chief Scientist and Professor at IGIB. He's also the part of the Academy of Scientific and Innovative Research at Delhi University campus. Sir did his master's and PhD in microbiology from IARI in New Delhi. His postdoctoral experiences are from France and Israel. He has been the recipient of SARC Award, Bharat Excellence Award, Biotechnology Award, Israeli Government Fellowship, and he's a UNESCO Fellow. He's authored many, many papers and many, many books, and has submitted around 500 novel sequences to the NCBI database. He's the biosafety expert from the Department of Biotechnology, India. So we are really, really lucky that we are going to hear him speak. The title of his talk today is Exploring Microbiome, a treasure trove for novel pharmaceutical fascinated molecules. We welcome you, sir.
Thank you for the introduction, and thank you, Dr. Navneet and organization, to invite me and share my views, what I'm doing in the IGIB. So mostly I'm not speaking very hi-fi science, very simple science for the common people. And I understand the two things in my topic is first is technology and second is source. So everyone have a dream. They will develop some drug, something for the humankind. So the people normally who are working, the PhD students and the assistant professors especially, because they face a lot of problems for the technologies. So where they will go, where they get the permission, other things. So a lot of technologies now are available at very low cost. So you can have anything to do for the science. If you really want to develop something, so then you should know what is the technology, which field is available. So MIT is the good because they are a multidisciplinary department is there. So it is the major advantage if you are working in the MIT. So you have a lot of different departments. So I just try to explore how to can other people can help you, or you can be helpful to the other peoples. So this is something for the drug discovery or whatever novel bioactive molecules. So you understand everything that, or you agree that God and microbes is the same. You find everywhere. You find a God and you find the microbe. Any damn thing you can microbes. But the problem is that till today we know only 2% microbes. So to explore the other things, so you should be aware the technologies. Another thing is that the technology, the identification of microbes is very quickly. Otherwise, you can see the other thesis long back, half of the thesis for the identification of microbes. So there are the new technologies which can be helpful to identify the microbes. So challenges of pathogen diagnostics. So most challenges, the drug and drug discovery and antibiotic resistance. Three main things, keywords is my talk. So wrong diagnosis means the burden of hospitals issue, the AMR and patient suffering. So how you quickly identify the microbes, that is the one main challenge. And the wrong identification is the really give the problem this. In the COVID times, many people died not due to the COVID, they died due to secondary infection like pneumonia and other things. So challenges in test discovery, that because what is the challenges? So this is the field where every people have the dream. They can discover one drug, but here the time, patience, risk, safety, and antimicrobial. These are some challenges. So new antibiotic development, only 15 antibiotics and the development of new mechanism of actions. So lack of incentive and companies. So the government is also not take the incentive because it takes the long time. So why it's so difficult to discover the new molecules? Case study, one company analyzed compound for the antibiotic activity, 67 experiment using purified proteins and 3 using whole bacteria. So they found the 5 potential leads. So mostly companies are following the same route. So it is very difficult. So you can see that after one drug, it will take about 12 to 16 years. So if you have a patience, and the failure is so much in this case. So this is the recent the one article from the Indian Express. The Indian discovered antibiotic get FDA approval, took 16 years to reach the market. So you can understand the drug discovery process. So it is not so easy. So another challenge is that the hospital-acquired infections. As I informed you earlier, the Indian hospital mostly gram-positive infections, and Western hospital is the mostly gram-positive, and Indian hospital is mostly gram-negative. So this is the report. So this is the problem with the hospitals also. So whatever things is developed in the US or other countries may be helpful, maybe control the infection in India or may not be. So this is the another things this for who are working this is the two things. When we working antimicrobial resistant, CLSI and UCAST. Earlier we all use the CLSI method for the to study the antimicrobial resistance. But now the UCAST, Union also they have the other things. So what is the advantage or disadvantage this? Because earlier thing the E. coli, amoxicillin, chloronic acid, 99% CLSI standard. Why UCAST is at 52.3. So let us see the difference. So definitely, so I support my earlier point that the Indian hospitals, there are different type of microorganism which may work from the abroad medicine approved in the abroad may or may not be. So that's why in case of P. acne, the clindamycin cutoff value 64 microgram per ml CLSI, but UCAST is 32 microgram. So this is also give the if you don't know cut off the value, so you give the continuous, give the more antibiotics, and give the more resistance. So technology advancement in the last 20 years. So earlier what happened, research in the natural product downfalls, high input, target compound present in small quantities, rediscovery of known compounds, time consuming process, purification and characterization, non-availability of natural product libraries. So what happened after that? Advance in microbial genomics, improved natural product sourcing, combinatorial biosynthesis, natural product libraries, metagenomics, high throughput screening, new sources. And new discoveries and technologies, mole bio era, genomic era, post-genomic era, proteomic era, and post-human microbiome project. So microbiome, so this, and now is artificial intelligence, machine learning, gene editing, correction, CAR T cells recently. So this is all the new technologies. So if you are a pharma student, you should aware that what are the technologies available today in the market. So new discovery, so you see, this is the whole platform for drug discovery from initial to end. Approval clinical 4 trial. So it took about the 16 years. So if you have a patience, if you take a risk, then only you can. Otherwise, normally company do. So it is very. If anyone say I am discovering the drug, so you can understand how much time it will take. So technology advancement. So let's go our opinion. One human genome was completed in 7 years, and total expenditure was $700 million. In 2001, human genome was sequenced 1 hour and expenditure $500. So let us see the metagenomic analysis, fruit and vegetable will cost approximately $300, $400 only. Quick, reliable identification of microbes. This is very important. For sequencing method is $50 only. So this is otherwise normally. Earlier days, 10 years back, we took about the 6 months to identify 100 microbes. But nowadays, only 15 days you can identify the microbe with full authenticity. Because here, nobody can fraud. Earlier, you can say, my search told or my guide told this organism, maybe this or that, but no. And you can also find out what is the inside the microbes. So that is the advantage for the study. And this is microbial data collection, anti-base and natural compound. So mostly people work on the pharma sector. They got the very good compound, and they're jumping the very good compound, antioxidant, antibacterial, antidiabetic activities. So what happened after when 5 years completing, and then you come to know this compound is already known. Your thesis is going to go rejected because. So that's why they initially you can check your compound within 6 months. You can check your compound, and this is all the data you have provided that, and it will cost about 25,000 rupees only. So you come to know your compound is totally new or is it already existing. So that's why they help in the process of the PhD students or the researchers, what is the use of databases. Bioinformatics approach. So this is another databases that's the approach. So here if you have 100 plant or 200 plants and you want to screen. So definitely if you increase screen the compound, so it will take about 2 years, 200 compounds, I'm sure, for different activities. But with this method, sit with the bioinformatics, it takes some data, and then you will come to know after 200 compound, 200 plants, only 5 plants will be useful for your research. So this is the reduce your time. And this is the rational ADME drug candidate properties. So this is how the cysteine drug can be bioinformatics people can be helpful for you, the pharma people or the microbiology people, biotechnology people, to reduce your burden. So if you want to screen the 100 compound, they will tell you five compound is there. This is my student Akash who work on the acne. So last 5 years I am working on acne, 4 theses on acne and lot of industry products. I will discuss you later on. So what we know about acne? Acne is everybody face the acne. What I understand that it is well known acne is caused by the C. acne bacteria. This is only we know. Everybody knows acne, what happened. Let us see what happened next. Acne is also caused by the gram-negative follicular pseudoacne. We call it pseudoacne. We have an example here. And second is acne is also caused by the mutation in 2 genes, NST and NSTN. This is false acne. So if you are suffering from the last one, the false acne, you apply any cream, any medicine, anything, any good medicine of acne, it will not work. So you understand. So that's why your assistant will develop. So that is the advantage for the technology. You should know that. So acne, so what this technology does. So this is my paper published in the, so in the clinical, one person came and the doctor gives a lot of things every time. Or every 6 months he developed the acne and he could not cure. 2 years he was totally frustrated, 2.5 years. Then they come to us, we took the sample, we took some identification of microbes. We found in the sample is the another microbe, gram-positive, Klebsiella pneumoniae in the acne. So they reported the first time in the sample. So doctor gave the different treatments. So now he's totally cured. So this is the technology advancement for the common people, that how we can help the people that. Let us see you know the acne is causing only one bacteria, but here you see how many bacteria population. So we did the metagenomic analysis of the acne and you find one acne, how many bacteria, and every bacteria is source of the new information. So you can see that the work of how much work you can do, and that is interesting things. If you have a bacteria, you have isolate bacteria, if you sequence it, how much it cost? 5,000 rupees. If we got the good bacteria, good inside, you can submit on an NCBI database in your name. So that will be helpful. And the future, if anybody will work on the bacteria, they will ask you. So this is the advantage. And this is, nothing is there. Very few, if you want to do metagenomic analysis, any damn thing, it will take about the 20,000 rupees. Don't go buy the good instruments, other things, because a lot of issues. So that you simply ask the company will do. Less than 20,000, you will find about 5,000 bacteria. And you work, so every bacteria, you can see that what is the relation with the disease. So here is the smart people can do it very quickly. That. Another study that we made, that the finasteride, this is the bald people. So that bald people, what happened, that we give the medicine. So sometimes the medicine don't work. Why is not work? Let us see so we see the shorter repeat in the AR region respond to the better this drug than with the longer repeat in region. So this is why the sequence studies, mutation studies in these samples. This is also help that. You can give any drug, it will not work because they have a mutation in the study. So this is the helpful for the common people. So this is the traditional B, microbiologist, pharmacologist, they know how the isolate the microbes. But sometimes you get the good microbes, sometimes you get the bad microbes. But no, because whatever you are looking, you are giving the substrate. But you are getting some new colonies. So better you go for the 16.
Sir, 5 minutes.
Okay. Okay. So, okay, if you go for new techniques, so you will find what is the bacteria inside. Okay, so madam told me the 5 minutes, so let's say the technologies. So this is the nanopore technologies come from the COVID times. So you find the sequencing machine. Very good. So this is the new sequencing machine. It cost only 8 lakh rupees and you can do the sequencing at your lab. Advantage of, okay. So this is the new machine for the RNA extraction machine. This cost only 4 lakh rupees and you get the RNA in the 30 minutes. Otherwise, people know how to extract the RNA from the sample is very difficult. So very quickly, I will not go there. I will go for the source. What could be the good source for the isolate the microbes? So let us see what is the good source. Always you see this picture and you find any common things in this. Students, please, this is for you because how you develop the new drug, because the UV rays and the bacteria in upper surface of the leaf, they have a microbes and they can handle the UV rays A and B. They are producing some metabolites. Then metabolites, if you isolate the bacteria from the upper surface, then you get the good metabolites, which is the good for the radiance resistant, which can be used for the sunscreen lotions. This is the cartoon. Always see that. Okay, termite come and eat the wood. So what is the message here? The message the wood contains cellulose and cellular enzyme present in the termite gut. So this is just small examples. You can take. This is the joke I always tell. Rabbit is active whole life and died in 12 years. But tortoise sleep mostly and survive by 100 years. So no need to wake up early and in the morning go for exercise. The reason behind this, longer life and slow metabolic rate. So if you go work on the tortoise, you will find some compounds which is in termite gut, which may be helpful for the aging, reducing your aging and reducing your metabolic rate. Always see the sap or nebula, that mongoose and cobra, everything. What is interesting that? Because the cobra poison never affected on the mongoose. Why? Because acetylcholine receptor mutated there. So this is the very good way. We always use the soft fennel. Always take the soap after the food in Indian food. But why? What is the good source of potassium, vitamin? This is we know. What microbiology? We don't know that. First word prepared by the soap. The outer surface soap contains many lactobacillus bacteria. So sporolactic allopathic medicine prescribed by doctor increase the lactobacillus concentration in the body, because lactobacillus is a powerful probiotic. Lactobacillus is good for immunity. So you understand how you can get the good bacteria or other things from the soap. Sulfur hot springs. We have a sulfur hot springs. We go for take the bath for the cure of the skin disease. Why Ganga is holy water? Because it never get affected by the bacteria, because they contain the number of bacteriophages. And human animal also good source of the novel antibiotic molecule. So you should know source of new antibiotic. Let's say develop from where? The nosy. We can throw it. The bacteria, we isolate the bacteria from there, and some people, and then they got the new antibiotic from your nosy. This is another my paper for how you get the peptides. So you find the crabs in the normally all the animals or the small animals in the water, they have a less effect on the skin. So we isolate one then, and we did some analysis, and we found this amino acid sequence, arsine protein, which is the AMP, antimicrobial peptide. So this antimicrobial peptide could be useful for the other skin disease. This is probiotic development, how you can go for the probiotic development. So you see the bacterial population from fatty lady and thin lady. You will find and you look for the sources for this, develop the probiotic type, drugs. Post pathogen infection, when you cultivate bacteria, 2-3 cultures together, you will find the new compounds. Potato is the good source for different type potato. Nobody likes, but curcumin is a new compound from the potato with low blood pressure, 4.5 to reduce BP, help in the growth of gut bacteria. Watermelon for this cyanosulfate citrate. And this is our new paper published in the good journal. So light activated antibacterial therapy. This is my student. So we are working on the surface sterilization. So we developed some molecule, so we can spray on the surface of the bacteria to kill the bacteria. So it could be that this is the all data we have published in this paper. So if somebody is interested, can go for the paper and look for that how the surface sterilization we developed. So this is article in the newspaper. Without antibiotic, you can cure your wound. This is just initiative. So white light activated antibacterial therapy. We have developed surface sterilization in ICU, hospital office, etc. Wound healing, patches, new lining in ICU bed, treatment of acne. This is all over from my side. Thank you.
Thank you so much, sir. It was such an informative talk. I am sure, I think there was something very, very concerning for students here. So I think they saw about acne, and I think they were a really interested lot. So are there any questions from the students? Any questions from the students?
Think something different. Look for the microbes, identify microbes, and submit on NCBI database. Very simple, but you will get the good stuff for the future. Okay, thank you. No questions.
Thank you so much, sir. It was a pleasure to hear you speak, sir.
Thank you, sir. That was surely a value-adding talk. Now I would request Professor Malika Pathak ma'am and Dr. Bhupesh Sharma sir to please felicitate Dr. Hemant Gautam sir. Thank you, sir. Thank you, ma'am. Now I would request Dr. Bhupesh Sharma sir to please introduce Dr. Prakash Baligar sir.
So good afternoon again. So the next speaker for today is Dr. Prakash Baligar, who is an associate professor in stem cell research. His specialization is in stem cell research, tissue engineering, liver regeneration, organ development, and reproductive biology. He has done his PhD from Karnataka University, and he worked with National Institute of Immunology for 7 to 8 years as a postdoctoral fellow. Dr. Prakash joined Amity Institute of Molecular Medicine and Stem Cell Research in year 2015. His research mainly focuses on stem cell therapy for human degenerative and genetic diseases. Presently, he has been engaged in the development of ex vivo partial liver organ by using natural scaffold composite and stem cells to replace the damaged liver. He is also working on novel skin grafts for burns and bone injury. The topic of his talk is tissue engineering for liver diseases using stem cells. I welcome Dr. Prakash Baligar for his talk. Sir.
Thank you, Dr. Bhupesh, for your well introduction. So I guess all of you are happy because this is the last one of this session. So anyway, I am not going to take much time. Maybe around 20 minutes is enough for me. So, okay, first of all, I thank for the organizers who have given the opportunity to talk about stem cell and tissue engineering. So I really thankful to them. So most of my job is done by Dr. Is it Dr. Dr. Verma. He has already talked about a lot of things related to introduction to tissue engineering. So I'm not going to repeat the same thing again, right? So basically, tissue engineering is the creation of the tissue, right? You have to create the tissue by using the cells as well as some materials. So here, ultimately, the aim of tissue engineering is to regenerate or repair any damaged organs. So ultimately, it is the part of the regenerative medicine, right? Part of the regenerative medicine that can be utilized either regenerate or repair, or you can replace the damaged organ. So that's the simple definition of this regenerative medicine. So here I am talking about the liver regeneration. So as you already know, liver is a very complex organ. So it has a complexity in their structure and also in their functions. So a lot of metabolic functions happen through the liver only. It's a biggest challenge for the tissue engineering guys because it's very difficult to develop in vitro conditions. So even though by knowing this, we have taken a small chance of taking this opportunity to make a piece of liver or a part of liver at least. So we try to do some related to liver engineering. So basically my talk is basically on liver tissue engineering, right? So why liver? Because as you already know, the alcohol is one of the leading cause for liver cirrhosis, right? So its prevalence is going to increase even in high economic countries also, right? So this is one of the cause for liver disease. So another cause is the fatty liver disease, right? So that fatty liver disease is also affect the quarter of the global adult population, that become the second leading cause of liver diseases. But in India, HBV is the major problem in Indian conditions. So as you know, liver disease is the 10th most common cause of death in India as per the WHO. And it is spreading like epidemic in India. 1 out of every 5 adults getting affected with these liver diseases. So liver related deaths in India, so that is covering 3% per year, contributing the 18% of the global scenario. So here the interesting is alcohol kills 2.6 lakh Indians every year, either by causing liver cirrhosis or the cancer or the road accidents, that is drink and drive. So the treatment option for the end stage liver disease is the transplantation. Again, there are a lot of problems with the transplantation, as you already know. And earlier, the speaker talked about the immune rejection and transplantation. So you just recall all those things. So the transplantation, the first important thing is the availability of the donors. And then the matching of the HLA matching, that is very important for the recipients. Otherwise, the graft will get rejected from the body. And there are many other problems. Say, for example, transplantation is also very expensive and it is not affordable for the common man. And even after transplantation, the patient has to undergo a lot of immunosuppressive drugs. And those drugs also very expensive and has a lot of the side effects. So ultimately, we thought of something new, that is the hepatic tissue engineering, that has become most popular for the liver diseases. So here, the tissue engineering in combination with the stem cells, so that may given some kind of hopes to cure these liver diseases. So I'm not going to take much time here. Already Dr. Verma has said about the tissue engineering, how it can be worked, and there is a cells, scaffold materials, and some biological factors. You together, you give a optimum condition for that. So ultimately, you can create the any kind of organs or any kind of tissues. It's very as simple. Anybody can explain this very simply, but when you are going to take the challenge, then you will get a lot of hurdles, right? So specifically liver engineering. So these are some of the biomaterials. People are tried a lot of polymers. So nowadays people are using combination of this natural as well as synthetic polymers. They are making the composite to gain a lot of biophysical properties. So they are combining these polymers. So a lot of literatures are available related to this. Come to my work in my lab. So we are basically taking the embryonic stem cells, culture them on the 3D scaffold. So that 3D scaffold, the cells are differentiated into liver-like cells. After that, we try to transplant them into the mouse model, that is partially hepatotomized mouse model. So that is the idea of doing the work in my lab. So here it's a simple way to make the fabrication. What we did, we took the polymer and we make it the emulsion with the solvent. And after that, we cross-linked with the chemicals. Then this is the mode of chemical cross-linking. So after that, we sliced them, right? So here we use the calcium carbonate because the calcium carbonate, when it reacts with the HCl, that will give us the carbon dioxide fumes. So those fumes are coming out of this scaffold, making the interconnectivity of the pores. That is very important for the tissue engineering, because these emulsion pores, they are closed. They are not connected to each other. They are closed pores. So when you treat with calcium and HCl, the pores are interconnected so that whatever the media or nutrient you are supplying to the cells, that is easily can enter even inside the graft. So that is the idea of using this chemical here. After that, you neutralize it and dry it, and finally you will get the scaffold. It is around 2 diameter and 2 thickness. So that is the final scaffold that we used for our research purpose. So now you can see the electronic microscopic structure of this scaffold. It has a totally porous in nature, and even you can see the interconnectivity of the pores inside. So then when you see the average pore size is around 100. So for especially hepatocytes, so the optimum is 100 to 140 micron. So here we found in our material it is 100 micron pore size, and average porosity is about 75%. And here the wettability of the scaffold, that is showing the hydrophilic in nature. We also carried some of the physical characteristics, XRD, that will shows the the scaffold is amorphous, and this DSC and TGA studies is indicating the scaffold has a thermal stability also. And TGA, that indicates the cross-linking behavior of this material with the cross-linker. So that is forming the uh, aldehyde bonds. And now we checked for the swelling ratio also, that is around 60%. And after that, the degradation. So we have used the simple PBS here for the degradation to check whether how much stable this compound is there, this scaffold. So just simply in the PBS, you will only around 35% degradation is occur. And we also checked for some biocompatibility with the HepG2 cells. So here we check the metabolic activity of the cells by using the MTT assay, where we found the increase in the cell proliferation with the time. So we cultured up to 12 days. So this is indicating the biocompatibility of the scaffold. It means it doesn't have any toxicity. Uh, that's what the cells are growing very fine. So now enzymatic degradation, here we use some of the enzymes, because when you transplant, our body fluid itself has some of the enzymes. So the degradability chance is very more. That's what we used pepsin and trypsin enzymes to check the degradable time. So when you added these enzymes, it will take around 6 hours to complete degrade. So that's what is our scaffold. And then we also checked for the cell's viability by using a FACS assay. So there we found the more than 97% of the cells are live even after longer time culture. It is not the 1 or 2 day culture. It is up to 12 days we cultured. We saw there is a 97% of the cells, they are live. And we also checked with some other cells like HepG2 cells and THEL2, that is again the normal hepatocytes. So we look at the electron SEM images, you will find a lot of cells. They are healthy and they are attached very promptly in the scaffold. And you can see up to the 12 days, there are cells are, you can see in the images. And then we culture the embryonic stem cells. That is very important for us. That is the work of us. So the embryonic stem cells, they also grown very well on the scaffold. They are forming a lot of colonies. You can see the SME images. So even we cultured up to 12 days, the cells are looks very healthy. So you can see the histological sections below that panel. So there are, you will find a lot of the mouse embryonic stem cell colonies, right? But even though the number is less, because during the process of histology, the some of the colonies may washed away. That's what showing somewhat less colonies in the down panel. But ultimately, my mouse embryonic stem cells, they proliferated very nicely, even they are live even up to 12 days. So then the question comes whether these cells, mouse embryonic stem cells, whether they are maintaining the pluripotency or they are differentiating into some lineages. Because as you know, stem cells, if you don't provide the proper conditions, so spontaneously they can go for any kind of lineage differentiation. So that is the major problem here. So we want to check whether these cells, they are really maintaining the pluripotency or not. So you can see here, there is increased fold in oct and nano. That indicates the stem cells are still they are maintaining the stemness properties. Even we checked up to 12 days. So we will find the increase in the stemness markers. And we also checked for ecto, meso, and endodermal markers. They are not expressed. It means that our material is maintaining the stemness properties of the cells. So then we try to differentiate them into hepatocyte-like cells. So you can see once we added some of the differentiation factors, obviously the pluripotent markers expression is down-regulated and differentiation markers are up-regulated. You can also observe that early and mature hepatocyte markers, where you can observe that after 7 days and 12 days, you will get a hepatic overexpression of these mature hepatic markers. So similarly, we also compared with 2D versus 3D. So obviously the 3D culture system has a more functional, more effective. So say for example, the production of albumin. So the albumin production is more in 3D when compared to 2D. And similarly, you can see the other hepatocyte mature markers. Those are also expressed more in 2D when compared to more in 3D when compared to 2D. And we also checked the early markers, early immature markers like this hepatoblast markers and also cholangiocyte markers. They are also expressed. And other biochemical parameters. Once we took the culture media and analyzed the secretions of, again, albumin, creatinine, and also urea, ALT, AST. So all biochemical parameters, they show the normal range in 3D culture system when compared to 2D. So now we wanted to transplant this scaffold grown on differentiated these cells, mouse embryonic stem cells, into hepatic-like cells and transplanted into the mouse model, that is partially hepatotomized mouse model. So you can see here without cells and with cells. So there are a lot of cells. They are there in the with cells group, and you can see the angiogenesis. That is, vascularization is also happened within the scaffold, and there are a lot of hepatocytes. They are making the covering within the scaffold after 7 days of explantation. So once we transplant this scaffold, after 7 days, we explanted that scaffold, analyzed it for the histology, right? And even you can see the without cells also, the number of cells they are get infiltrated. We also checked for their functional assay. Say for example, the hepatocytes must express the albumin, CK18, as well as the HNF4 alpha. So these are the specific markers of liver. So we sectioned that explanted from the mouse, and we stained for all these markers. You can see there is a islands of liver tissue that is grown within the scaffold. And you can also observe the architecture of the structure where the triads, the portal triads, means there is a central vein and also portal vein and hepatic artery. Together you can call it as a portal triads. So those kind of structures are appearing within the scaffold. You can easily see in the images. So ultimately, so it is our scaffold is very biocompactable and very favorable inductive, hepatoinductive properties, so that liver related architectures they are developing within the cells, and they are also expressing the hepatic specific markers. And you can see in the last panel, that is the Ki67 staining. So the cells are also proliferating. So again, we checked the biochemical parameters after the partial hepatectomy. So you can see the ALT and AST, they are becoming normal after transplantation of these scaffolds. So in conclusion, the gelatin scaffold that is effectively promotes the proliferation, differentiation of stem cells into hepato-like cells, and it is also useful the hepatoblast cells. It means the before maturity hepatoblast cells. Those will be the useful source of 3D liver engineering, and this approach can be utilized to create a 3D model and which can be used for the transplantation. Not only that, even you can use it to test or screen any drugs also, liver related drugs. So ultimately, the future perspectives are, so one can develop this kind of 3D model to screen the drugs or to screen the, or even you can use it for the transplantation purpose also. Not only the liver regeneration, even you can address the lot many liver diseases like alpha-1 antitrypsin deficiency, hemophilia A, hemophilia B, chronic liver failure, trisomy type 1, Wilson disease, cytic. There are like many liver diseases. So one can use these kind of developed scaffold, the liver tissue, partial tissue for curing of these liver diseases. So I thank Honorable Founder President Sir, Dr. Ashok Chauhan, Honorable Chancellor, Dr. Atul Chauhan, Vice Chancellor, Madam, Dr. Balwinder Shukla, and Professor B.C. Das, Chairman, MSR, Professor Subrajit Biswas, Director, MSR, and all faculty members of MSR. So I also thank the funding agency, that is SERV DST. And most importantly, I thank for my research team. So all this work is done by Kshama Kumari. She is a PhD student. And other students are Sabia Khan, Preeti Rawat, Poonam Yadav, Gaurav Kant, Sandesh Patil, and Tejas. So I thank all these, the lab team. So thank you very much.
So thank you, Dr. Balkar. If you have any query, the session is open for questions. Do we have any query from the audience? Yes.
Yes, please.
Can you please come forward?
Thank you, sir, for the session. So I basically wanted to ask you that you showed that on treatment of the embryonic stem cells with the gelatin-based scaffolds, they are able to maintain their pluripotency.
Yes.
And after the addition of growth factors, we see that they are gradually differentiating into the liver-specific cells.
Yes.
So for liver regeneration, which is basically the aim here, is gelatin scaffold intrinsically responsible for inducing this differentiation, or is it only after the addition of growth factors we are able to achieve the same?
No, that's what I clearly showed the data also. These stem cells, the scaffold that is involved in the maintenance of the pluripotency. So if something is there, then obviously they can go enter into the lineage specific differentiations. So only once we add the differentiation factors, then only these cells are switched to different lineages.
Okay.
That's the
Okay.
thing.
Thank you, sir. Thank you so
Yes.
much. Just a sec.
Any other questions? Anybody's?
Hello. Yeah, sir.
Oh,
That was
yeah.
very good work. Like we are trying to regenerate the liver using the cells and the scaffolds. So one thing I want to know that you have used the gelatin-based scaffold and the embryonic stem cells, right, for the
Yes.
regeneration purpose and use some growth factors. So that is fine up to the animal level. But when we go for the human trials, So because embryonic stem cells, they are not allowed by the FDA. So
Yes.
for the transplantation, because only R&D is allowed. So how we are going to do it in the human and the other, I mean, animals?
It's a very right question. So at this moment, I would like to say that, so creating the partial liver or part of the liver outside the body, that is in vitro, it is a very difficult and very challenging task that everybody knows. But initiating with the animal model or animal cells, so that is the first step. So, and also in our lab, we are creating the human induced pluripotent stem cells also. So it is gradually going to develop, and we are creating the, by using the human cells only. That is the stepwise process. But at least we have to understand some basic understanding of how we can generate this liver outside the body. That's the idea of doing this.
Because I have seen a few reports also where people are trying to use the 3D bioprinting to print the small liver part or the hepatocytes and the
Yes.
that, because that architecture is very complex.
Very complex.
Yes, so probably that may be used, because around, if there is, what I know, that around 30-40% loss can be regenerated by the liver. And if it is more than that, then liver cannot be regenerated. In that case, only the transplantation is required.
Yes, yes.
So, I mean, if we can grow a big chunk of the liver, so probably that may be helpful.
Yes, yes, sir. Yes, sir, that's the idea of doing this. Even you can see if the person or the population is more alcoholic, so the cirrhosis is the end stage liver disease. The ultimately transplantation is the option for them. There is no any treatment.
Yeah. Thank you. Thank you very much.
So thank you, Dr. Prakash. Simran. Miss Simran.
Thank you so much, sir. Now I would request Professor Malika Pathak ma'am and Dr. Bhupesh Sharma sir to please felicitate Dr. Prakash Baligar sir. Give a big round of applause for him. Thank you so much, sir. Thank you, ma'am. As this is the end of the session of scientific session first, I would request Dr. Hevigre Architme sir to please come up on the stage and felicitate Professor Malika Pathak ma'am. Give a big round of applause for her.
Sir, we'll have one second. नहीं, किसने बोला? हाँ हाँ।
Development phase, which is where I and my team and people like me come into picture, which is human studies. For those 5 compounds to make into clinical trials, the likelihood of receiving an FDA approval and eventually seeing the market is only about 12%. And this is the list of number of FDA approved drugs in the last 5-6 years, only a small number, and not every drug that you see as approved make it big. There are drugs, and I think in the previous session, Dr. Heyman spoke about the very first drug that got the FDA approval from India. There are not every drug which is going to be a $1 billion product or multi-billion dollar product. There will be drugs which will not be very, very commercially successful. I'll give some examples in the subsequent section as well. So it's a high risk, high cost, high time consuming activity, which is a team sport. So different stakeholders involved in it, from clinical pharmacologists to development scientists, operations, toxicologists, regulatory affairs, safety physicians, and many more people involved in it. Working with regulators, since this section was of regulatory, I thought I'll introduce a bit of regulatory aspect as well. Every product that is to be consumed by human beings has to follow the regulatory norms, and different regulatory bodies, they have their own very clearly defined set of requirements that a product needs to comply to before it gets into the market. Why we say it takes 12-15 years to develop a drug is because the companies or whosoever is developing that molecule wants to be very sure that it is as safe to the wider population as possible. There are numerous examples of various lawsuits that happen even after a drug is commercialized. I'll give the most recent example of a baby nutrient, a food product, not from our company. Our company is market leader into that. It's from another of our competitors, which was under a lawsuit. A baby unfortunately died in US. The company received a lawsuit of $92 million just for one infant that died. So it's a very, very serious business, even if it is a food supplement. And as a result, even though it wasn't our product, our stock price fell in a matter of days from $120 to $110 a share. So that is why regulators make sure any product that they are getting into the market is tightly controlled, goes through all the safety aspects, all the efficacy aspects. And I mean, the trials that we'll see are tested in a handful of patients only. So you are taking that to a much wider, much generic population. But yeah, that's the least the companies need to do. So talking about drug discovery, there is biology involved. There is, what happened? I don't know. Someone from the team need to come and, okay, I see something else on my screen. Anyway, there are different aspects involved: biology, chemistry, in vivo, pharmacology, in silico, ex vivo, in vivo. And I think the experts here are going to talk more about it. When I was giving my introduction, I didn't mention that The last time I studied chemistry was 25 years back in college. So I was very good in chemistry, but no longer now. And my interface with biology continues with that of dealing with human beings in clinical research. So while they fix it up again in the interest of time, the subsequent slides would have spoken about the clinical development process. I think it's there. Different phases of clinical research, starting with phase 1, which is done in healthy volunteers. Phase 2, which is done in a larger number of patients, about 100 or so. Phase 3 is when the real money goes into developing the drug in clinical phase, and that's done in multiple patients across multiple sites. As I said, I was fortunate to be involved in development of molecules, both devices and drugs in first in man, right in the phase 1 itself. And the bulk of the money also goes once the product is commercialized in phase 4, where a lot of data is generated after the commercialization of drug. And this is a picture from clinicaltrials.gov, which lists the number of phase 4 studies done across the world in different continents. Different types of trials are there, which are industry initiated, people like me who initiate the trials, government initiated, we saw those in the COVID phase, investigator initiated, which are led by the investigators post commercialization of the products to generate additional evidence, and then academic trials. A lot of hospitals, a lot of academics, research institutes also do the trials of their own with or without industry funding. So I'll give an example of the product I worked on, which is Cangrelor, which is a direct P2Y12 receptor inhibitor. And it's an used via it's used via parenteral administration with a T half-life of 3 to 6 minutes, has an immediate onset of action. When I joined this company after leaving Abbott for a few years, this company had already done 2 large phase 3 studies, 15,000 patients, and that still failed. So we were asked to do another large study, 11,000 patients, for which I was taken. So the work for this started right from the rationale why we need this product. There were oral drugs which were available, which had delayed onset, prolonged effect, and unpredictable effect as well. So people needed something which is very, very fast acting, has a desired predictable action. And as I showed you, the half-life of this product was only 3 to 6 minutes. So there is almost immediate onset of action. Anyone having heart attack can be given this drug to save the life right there. The pharmacology was done. This paper is from 2010 when it was already completed the phase 3 studies which were failed. So the work for this started way back in 2001, 2002. And finally, when the product was approved, this is the presentation from the FDA approval presentation meeting, which finally saw the light of the day in 2017. So around 14-year life cycle, and almost 30,000 patients were tested on this. Multiple trials were done. Now let's shift the focus to medical devices, which is what I currently do. There is difference between the product development theories of medicine versus medical devices. The discovery of medical devices is not always complex and long. You'll be surprised to know majority of successful medical devices were developed in the kitchen, in the garage, as a prototype before they were taken for further testing and further improvement. Whereas as we saw in the cases of drug, it's a long and complex development discovery cycle. The development of a medical device is a continuous, incremental, and cyclical process, which is you develop something today, that's not going to be your final product. You continue to do multiple iterations in that. And I have an example to show of the product that I have worked on. Whereas in case of drugs, it's largely unidirectional process. If you need to change anything on that drug, you need to do something entirely new and entirely different in most of the situations. The preclinical work in medical devices is also relatively very short, includes a bit of animal testing, but not a lot deal except for the biocompatibility testing. Whereas we know from previous sessions also that the development, preclinical development in drugs is a very lengthy process. Clinical trials in devices are also not always mandatory and not for all type of medical devices. You don't need to do a clinical trial for a thermometer, right, or a blood pressure instrument, but you need to do a clinical trial for a device that is going to be implanted in your heart or in any other artery. Whereas in case of drugs, we know it's mandatory for all classes of medicine. There are different phases, like there are different phases of drug development as well. Starts with the initiation of opportunity and risk analysis. Before you put in your money, you always look into what is the opportunity available, what is the risk associated with it. Moving on to formulation, concept, and feasibility. Eventually moving on to the design development, verification and validation, final product verification, and then launching the product and doing the post assessment. There may be a requirement to do some bit of clinical work depending on the category of device in the fourth phase as well, or third phase also. When we look into the development plan, any new device that works in patient always gives great excitement and rewarding to the people who are developing it. As I said, a lot of work done in kitchen, garages, small labs. So if the developer sees it working in a patient, then that's the most happy time for that person. But subsequent trials can be very exhausting, frustrating, expensive, time consuming as well. So before you initiate any trial, you need to ask whether it is absolutely necessary to conduct a trial on that particular device. So what do we try to achieve with this rigorous risk analysis is make sure the proof of concept is carefully tested and no further learning can be done without human testing. Demonstrate that your product is effective to investors so that you can raise additional funds. A lot of these innovators, they work on developing these small devices and then eventually sell it to the investors. Make sure there is enough data to improve the chances of selling the IPR and enhance market awareness and exposure to the device through the key opinion leaders, and then work towards the regulatory approval. So this is example of another device that I worked on right from first in man days. The first in man was done in 2004 with 60 patients, followed by another phase 3 study in 300 patients, which led us to the approval of this device in non-FDA market, non-US market. So anything outside of US, we could sell this product. Eventually, we did study for US, which is Spirit 3 and Spirit 4, which were 1,000 patients and 3,000 patients. And rest, all the studies that we have done are in the post-commercialization phase. So this product is almost 20 years old now, and we have done certain incremental changes to it. And we still continue to invest in it and make sure there is new data that's coming out so that physicians can treat with confidence. As shown in this example, so the first change was a radical innovation from a landline phone to a mobile phone, which was a button phone from Nokia. And subsequent change to the touch phone was also a radical change. So once those smartphones came, everything else is incremental. You change the camera pixels by here and there, add additional this thing, and the company makes millions of dollars by these incremental innovations. But that is how the industry works, and that is the objective of putting in research into those incremental innovations as well. So when we look into a research prototype versus a commercial product, the research prototype should be safe enough, whereas the commercial product should be safe for everyone. Remember, no lawsuits, no one wants any product complaints and patients filing cases in the court. So it should be good enough for your grandmother. The research prototype is built by the dedicated engineers, whereas the commercial products are built on production lines. The research prototype is usable only by experts under guidance from inventor, whereas subsequently it's used by everyone under high stress environment. I mean, a patient undergoing heart attack has to be treated then and there only. So you can't be thinking, wasting too much time to look into, okay, what is the best option? So your product has to deliver in those high stress environment and high stress circumstances, which could be middle of the night for anyone as well. And there are other considerations as well, which is cost, and then has to work every time in case of a commercial product. So we looked into the development of drugs, development of devices. Let's look into some innovation goals. And this is considering the last few years where we have seen a lot of artificial intelligence and smart tools. Now, in the previous talk, I also gave the image of a driverless car. So everyone knows about driverless cars, which is the prototype, and Tesla has some driverless features already. So if a car can work without a driver, should I not be able to normalize my sugar like that? Yes, of course. That's the design goal of developing a smart insulin, which should be able to give the dose of insulin. So you have insulin pumps, which are already available commercially for quite some time, which make sure it's convenient for the patient. It gives no hypoglycemia, gives near perfect glucose control, significantly fewer finger sticks, and minimal dietary restrictions. That's a design goal when someone is working on developing a smart insulin pump. How about measuring your sugar? Do I need to prick my finger every time I need to measure sugar? I'm a diabetic patient. I know if I am asked to do 50 pricks in a week, which typically a lot of diabetologists ask when they have to titrate a dose, it's a non-starter. I will never prick my finger 50 times in a week to give him the range before breakfast, after breakfast, this and that. What we have is continuous glucose monitors. It's a device, what you see here, but now the app is there on the phone. All you need is this sensor, put here, put your phone, gets you reading while I can speak. I mean, my phone is there, otherwise I would have shown you the readings as well. That is the design goals of any innovation. You want, remember the first 4 aims that we saw: beneficial for the patient, effective for the hospital, effective for the healthcare system, and obviously giving money for innovation as well. What about measuring heart rates? Well, you have an Apple Watch to measure heart rate, and there are studies done. I don't think I have a slide on that here, but there was a study conducted in US on, imagine how many patients, 4 lakh patients, done in 3 months with the use of a smartwatch. It gives you the reading, the ECG reading, the sinus rhythm and all to the doctor sitting wherever in India or wherever, and the study could be completed. So those are the design goals of any innovation. And the bulk of the industry innovation is still done in 4 fields, which has been constant for last 4 years. Cardiovascular being top of those, followed by infection, followed by cancer, and I'm forgetting which is the 4th one. Last 30, 40 years, all the innovation from the industry side has been done in this area only. So from smart device to smart care to smart home, again, in the interest of time, I'll not go through each of these, but then we are talking about making sure the care is delivered right at the patient's bedside. I mean, I won't even call bedside. Whenever the patient is doing his daily routine, the patient care should be delivered there. What about artificial intelligence? Again, to simplify, artificial intelligence requires handling a lot of large volume of data, and I'm sure you people are more experts than me on artificial intelligence. Involves domains such as reasoning, knowledge presentation, machine learning, use of algorithms that recognizes pattern within a set of data, and then deep machine learning as well. Taught in school nowadays, so a lot of people, a lot of kids in school are now developing codes in this area. Again, I'll not go into understanding of artificial intelligence, but where it has an interface with healthcare is, we need to understand where all it applies to healthcare, what types of data have been analyzed so far, and what are the different applications that are available, and what are the diseases that are currently managed by. And again, this is not a, I'll finish here. So you have patient-facing mobile apps, remote monitoring solutions, etc., etc. And in clinical research, it also plays a very important role. Remember the big time cycle of developing a product, which includes clinical development. So it can definitely help you shorten the time to some extent. And again, there are multiple papers available, so you don't even need to access a journal for that. Just Google it and you'll find where all it can help. Various websites available as well. And I think in the interest of time, I'll go to how we enable change is by having a vision, identification, and prioritizing, having proper infrastructure, developing skills, including processes, making sure there is enough quality management, having a good organization model, managing the transition, and always being agile. And again, I'll end the slide with this quote, which is the great variability amongst individuals is what makes medicine an art. And the last take home message is, yeah, it's election season. Do vote whenever votes are due in your place, whomsoever you want to vote. Even if it is nota, exercise the vote and enable the change. Thank you.
Thank you, Dr. Narang, for such a wonderful talk on the clinical study of the drug and device. And I hope all participants will get benefit, because the coming area is of the medical device. And I hope the pharmaceutical companies are working gradually on the development of medical device. And hopefully in the coming time, we will have a device, means there will be no need of the pricking every time for the measurement of this glucose, but even with the speaking, or because there is some relation between the hyperglycemia and the hypoglycemia on your voice speech as well. So by speaking on the smartphone, you can have some data, key, what is my blood sugar. Thank you very much once again. Now the forum is open for the discussion. If the participants are having any question.
Variability exists, ma'am. Let me be honest. It's so the product that I showed is from my company only. Variability exists, but more than variability, and variability is maybe to the tune of 10-12% only, not very great. It's a life change. It's a game changer for me because, as I said, I can monitor it while talking to you, so I know whether it is going up or going down. So for me, it would not have been possible to do a prick and do it. And because I'm measuring it, and even if I don't measure it, the system measures it on its own, I am bound to take care of it, which would not have been possible if you don't measure it, you don't control it. The big caveat is the cost, which is, again, it's a for-profit company. In India, we sell it now for say 5,000, 5,200 or so. With the validity for the sensor is only 14 days. So after 14 days, you have to replace it with another one. So if I were to wear it throughout the year, I'm talking about 5,200 into, I did a math sometime, it was coming to roughly 1 lakh of rupees or so. Not a great deal if your life says, because I saw my HbA1c come down because I was measuring it properly. But yes, cost is prohibitive, and it's one time. When you put it, you can't take it out before 14 days, and you have to measure it.
And another very simple question is about the anxiety levels. I have seen people who are using sensors and who are also monitoring their heart rate or, that pulse, etc. So they find that they have seen that anxiety levels have gone tremendously, So how can you relate it to the quality of life and using these sensors? Definitely the cost is there. You have already mentioned that. And not everybody can afford that type of thing, but yes. But can you explain about, have you measured as a scientist the anxiety levels and the...
So I'll give the example on the other side, which is there are colleagues of mine in Japan who put it just to measure their stress level and whether their sugar goes up when they are stressed or not, and they can explain it to their bosses that, yes, you don't give me stress, and this is what happens to my sugar level in that case. So I think the information is there with the devices, the watches and the sensors like these. It's how you want to use it and what you want to do with it. Anxiety levels can go up, but then if I am a patient, either of hypertension, which I am, or of diabetes, I at least will be taking my medicines more more strictly, and also doing whatever extra needs to be done to yoga or lifestyle management or whatever to balance that. So information is there with you. How you use your information is entirely up to you. Thank you.
Thank you, sir, for this very informative talk. I request Dr. Nitin Sharma, sir, Dr. Vinay Lathar, sir, and Dr. Chitme, sir, to please felicitate Dr. Manish Narang. Can we have a big round of applause for them? Thank you, sir. Now I would like to request Dr. Tanveen Navis, sir, to please felicitate Dr. Mustaqim Abdullah, sir, as an evaluator. Can we have a huge round of applause for them? A huge round of applause for them. Thank you, sir. Now I request everyone to please proceed for the lunch and we'll get back after half an hour. Thank you.
intermediate. So for that, we have performed some control experiment. After isolation, I did the reaction, product formation is happening. And then in the second case, you can see also spiro kind of intermediate we have isolated. And then whether this is bonded acid catalysis or not, we have also performed bond through quencher. So reaction is not happening. That means this is bonded acid catalysis. In the last in situ IR, you can see how in situ you can think about carbonyl decreasing of carbonyl peaks happening. You can see in the this in situ IR graph, and then also some more NMR study to prove the intermediate really exists. And some more experiment after imine isolation, we have done the reaction. Also, I have seen that, we have seen that product formation. At the last, you can see why trifluoroethanol so special, because there is a strong hydrogen bonding in between carbonyl and trifluoroethanol. With this, I can show you some important mechanistic experiment here. So these are the first pentafluoroalcohol will activate your carbonyl, and then this amine will attack so that it will form imine, and then this C3 of this indolin indole moiety will attack to this imine, and you can get the spiro compound. And as methanol is very prone to leave from the system, you can get this kind of intermediate. And then another intermediate is forming after rearrangement, and then further rearrangement, proton shift, and then you can get the this kind of carbocation intermediate. After rearomatization, you can get the product formation. Again, your catalyst will regenerate. Another path can be feasible, but as we have isolated few interesting intermediate, we believe the outer cycle is happening, not the inner cycle. So this is the mechanism for the synthesis of oxyphenol indole as azaphenol indole. So this is the product derivation for the paper purpose we have to do. And now I'll be not showing this work, but one interesting slide I want to show you. So if you want to synthesize azonazine as a natural product, so you can utilize this scheme where we have used lithium aluminum hydride 2 equivalent. You can see in one step, 2 reaction is actually happening. Amine reduction followed by cyclization, so that you can get syn diastereoselective tetracyclic azanozine core. Now, I will show you some more interesting, as you were towards pharma, and I thought some pharmaceutical drug I can show to you. So let's see here, ibuprofen, which is a painkiller, naproxen, phenopropin, ketoprofen, baclobrate. You can see the common feature all have carboxylic acid, free carboxylic acid. I'm not going to other drugs I have mentioned here. Very recently, Professor Hartwig, my prediction is within 5 years, Professor Hartwig and Professor Buchwald will get Nobel Prize because of their Hartwig-Buchwald cross coupling. So I took the challenge. So Professor Hartwig already published one JACS paper with so many chemicals and reagent they have used. I thought about, can I make alternatives so that I can develop some drug here. I have mentioned ibuprofen, naproxen very easily in the laboratory scale. Then you can see this is the alpha relation of carboxylic acid. If you can alpha functionalization of carboxylic acid. That's why this paper became JACS, and publication in JACS not easy from India. So now as a alternative, I am showing you, can I have similar structural motif of the product utilizing alpha keto carboxylic acid. This is also commercially available. You can do reductive Fidelka reaction. First arylation followed by reduction utilizing silane. Because of time limit, I am not showing all the details. I had my slide, but I'm not showing to you. How much time left? 2 minutes. Fantastic. So you can see very easily, you can utilize arenes as a feedstock, and you can do alpha arylation so that you can reach many profene-based drug, let's say penoprofene, ketoprofen, ibuprofen, all the drug you can synthesize in the laboratory. Of course, up to gram scale, we have succeeded. We are thinking about pilot scale later. If I get funding, then only. Otherwise, only we are developing fundamental science. Then, with a similar way, we can thought about synthesize other drug molecule utilizing another strategy, reductive Friedel curve. First Friedel curve followed by reduction and then cyclization. Not only you can get 5-member, 6-member, also 7-member lactones you can synthesize very easily. And these are the some scope. You can utilize Bernstein acid, silane source. So the reductive Friedel curve reaction will happen, and you can, based on your requirement, you can synthesize small ring to large ring molecule up to 7-member. You can see in case 3F. Then in collaboration, what I have developed, sulfuric acid is very dangerous to touch. You cannot handle sulfuric acid. So I have synthesized derivative of sulfuric acid or derivative of PTSA. So that the heterogeneous catalyst. I am a homogeneous guy. Now I'm moving towards little bit heterogeneous system. Why? This is industrially relevant. So similarly, we have synthesized this mesoporous nanoparticle. At least 9 times I can recycle this catalyst and I can develop again diaryl synthesis utilizing feedstock like aldehyde, benzaldehyde, or arene source like benzene, toluene, etc. So this paper recently accepted in Jack's code. Not only that,
sir, I request you to conclude.
The last slide. So I have also synthesized some blue emitter. So with collaboration with Professor Madhusudan Singh. So as an alternative, let's say gallium will be finishing soon. Then what will be the alternative? So we will provide some alternative source of blue LED. So these are the some summary of my slide. Not only we are synthesizing some drug molecules, but also we are synthesizing some other target molecule like blue emitter, etc. And of course, I have some good publication, good patents, book chapter review, etc. And currently 11 PhD scholars are working under me. And these are my collaborator, my lab mates. Without their work, I'm nowhere to present my work. So of course, thanks to funding agent for the funding to do some fantastic reaction. And last but not the least, I would like to thank Dr. Navneet Sharma for this kind invitation to show my work. Thank you very much. Thank to you.
Definitely, Dr. Chinmay has given a very wonderful talk on synthetic chemistry, a lot of novel compounds, a lot of drugs, a lot of synthetic pathways. So if you have any doubts, I think pharmacy students are having a lot of questions in their mind how we can do something in their lab. So please go ahead. The expert is there. Any question? Any question from the audience, from the students? Okay, sir, I'm very thankful for your time that you have given us, and a lot of work has been done. I wish you a very great synthetic chemistry research in the coming future, and we are looking for a great collates for you. Thank you very much, sir. Thanks for coming.
Thank you, sir, for this very informative talk. Now I request Dr. Vikesh Kumar Shukla, sir, to please felicitate Dr. Chinmoy Hazra, sir.
Please, sir.
Can we have a huge round of applause for them? Thank you, sir. Thank you, sir. Now I would like to request our session chair, Dr. Nitin Sharma, sir, to please come on the stage and felicitate and welcome Madam Alka Ahuja. Madam is a professor and chair of the pharmacy program, National University of Science and Technology, Oman. Madam, please.
Welcome.
Thank you, madam. Now I request our session chair, Dr. Vikesh Kumar Shukla, sir, to please welcome Dr. Nidhi Sandal, ma'am. Madam is a scientist F in Mass and DRDO, Delhi. Can we have a huge round of applause for that? Thank you, sir. Now I request Dr. Vikesh Kumar Shukla, sir, to please introduce our speaker, Dr. Alka Ahuja, madam.
Very good afternoon to everyone. I would like to invite Dr. Tanveen Nawaz, sir, for this work. I think he's the good orator, and this is the best gift from him to her career. Please, sir, please.
Thank you, Dr. Vikesh, to giving me this opportunity because I can see many of my students sitting in the audience, and once we talk about the generations. So the best thing I can introduce, ma'am, that I am the student of Dr. Alka Ahuja. This is my personal honor, and it's so honor to have you, ma'am, this afternoon. Currently, Dr. Alka Ahuja is the professor and chair of pharmacy program, National University of Science and Technology, Muscat, Oman. Dr. Alka Ahuja is a renowned figure in the pharmaceutical industry with over 3 decades of experience. Currently holds the prestigious position at the National University of Science and Technology, Oman. Some of the notable roles include Chair of the Research and Innovation Committee, Professor of Pharmaceutics, and Chair of Pharmacy Program. Dr. Alka Ahuja actually began her career from the reputed Jamia Hamdard University, where she has taught me also at the time of 1995 to, I think, 2010, and then moved to Oman. Dr. Alka Ahuja contribute more than 250 publications in the reputed journal, mainly the Scopus Indexed Journal, and also supervised over 100 theses. So huge round of applause for ma'am. Over 100 theses of M.Pharm and PhD. With this, I request Dr. Alka Ahuja to give her talk. Thank you very much. Please.
This one.
A very good afternoon to all of you. First of all, I would like to thank Dr. Tanveer for his kind introduction. I'm sure all of you must have realized by now that you are very lucky to have him as your leader, who is leading you into different roles. He's teaching you, he's doing the administrative work. So I'm really thankful to your team, Dr. Tanveer, for inviting me. And I'll just share my experience, whatever I have learned all these years. So my talk is going to be on pharmacokinetic principles in drug development. So the outline of my presentation will be basically about the basic principles and the concepts of clearance, half-life, volume of distribution. I'll touch little upon the therapeutic drug monitoring and the conclusions. Now, I'm sure all of you know that when we talk about drug research, which I'm sure all of you are either from your master's or from your PhD levels. So what is drug research? Because it encompasses the role of so many professionals, but all are united by a common goal, whether we talk about pharmaceutics or by the drug regulatory or pharmaceutical chemistry. We have only one common goal, that is development of the novel therapeutic agents. Now, when we talk about the search for drugs, now search for drugs involves two stages. One is drug discovery and second is drug development. But what is drug development? These are all words which we keep on using. Basically, it is bringing a novel drug from bench to bedside. When I'm talking about bench, this is what you are doing. When you are working in the labs, you are preparing you're doing so many experiments, but the ultimate aim is to bring it to the bedside. So now when I'm talking about the drug development, so drug development, basically, it takes about 10 to 15 years, as previously Dr. Manish Narang was telling, that how we narrow down from so many molecules to a single drug which is approved. So normally it takes about 10 to 15 years for the entire journey, starting from the first experiment till the time it comes to the market. Now, if we talk about this entire process, as we all saw during COVID times, how we got the vaccines. So if the drug is the first available treatment, so that this process is shortened. And another thing is when you find a drug which shows benefit over the existing drugs, then also this entire process is shortened, maybe even to 1 or even less than 1 year, as we all saw during the pandemic. Now, if you look at this slide, basically, actually, I can't see the full slide. Now, when you look at this slide, you can see that we start with the number of compounds, which start from 5,000 to 2,000, which is basically reaching the drug discovery stage. But then when we talk about the preclinical research, the same molecules, they are narrowed down to about 250. And then they narrow down to 5 when we talk about the clinical research. And then we see that approved drug is only 1. So that is how from 5,000 to 20,000 molecules, we narrow down only to 1 molecule in the end. But have you ever thought that what is the reason for the failure in development of the formulations? If you look at all these points, you find that the last point, which is the poor biopharmaceutical properties, is the reason for the maximum failure. Now, what is that percentage? You can see it is almost 41%. So what are we trying to achieve? So what is the important thing which we must focus in the drug development? That means our drug should have very good biopharmaceutical properties. Now, I'm sure all of you know that what is biopharmaceutical properties. When we talk about good absorption, distribution, metabolism, and excretion, but what are the causes? Why is 41%, that percentage is such a big number? basically either the drug is not properly bioavailable because it does not show good solubility, or it shows high first pass metabolism, or drug might have inadequate duration of action. That means it has very fast metabolism and clearance, or there could be unanticipated drug interactions, which could be normally seen in phase 2, or we see them in phase 3 studies. So that is what happens. Or there are some undesirable drug interactions. So all these lead to poor biopharmaceutical properties, which lead to failure of our drugs in different stages. Now, what are the questions which we need to address as the scientists? One is, first, we should know what does the drug do to the body. Second is what the body does to the drug. And third is, even if the drug is potent, is it safe? So all these questions, they need to be answered. So what is the difference between pharmacokinetics and pharmacodynamics? Basically, pharmacokinetics is what the body does to the drug. And our basic aim is that the right concentration must reach at the site of target site. And second is what the drug does to the body. That means the drug concentration at the site of action, whether it is really producing some action or not. Now, if you look at this slide, why do we all need to study pharmacokinetics? Because if we do not have good knowledge of this, then all the toxic drugs would accumulate. We will have drugs which have no benefit. Either the doses are too small, or they are too high and they can cause toxicity, or our drugs would be rapidly metabolized. So these are all the basic problems if we do not actually study the pharmacokinetic properties well. Now, it's very important that when we talk about drug development, we should have very clear picture of any drugs, its ADME properties or the biopharmaceutic properties. And these are some very few regulatory bodies which approve our drugs. Now, we all know about US FDA. Then we have European Federation of Pharmaceutical Industries and Associations. We have European Medicines Agencies. And then we have International Federation of Pharmaceutical Manufacturers and Associations. So ultimate aim is that our drug should be approved by the regulatory bodies so that they can come to the market and benefit the mankind. Now, this is about the ADME, which we have been referring to. Now, this is the entire journey of the drug in our body, that how the drug, when it is getting absorbed, it is reaching the blood circulation, how it is getting distributed, and how the drug is getting excreted. So these are the different stages what the drug goes through that. Basically, we need to quantify these processes. All these processes, we should know what is quantification. That means their extent and then also the rate. Now, when I'm talking about importance in drug development, I must know about the interactions, the food interactions, because most of these studies are done in the fasting patients or fasting individuals. When we take them with different food and fasting state or in the fed state, the entire pharmacokinetic of the drug changes. Then we give multiple drugs, polypharmacy, then a lot of drug interactions, they happen. So, and people who have compromised kidney functions, compromised liver functions, so what will happen? The entire disposition of the drug will change. So this is the picture which we all see when we do our even bachelors, that there is a therapeutic window which we need to maintain. That means neither drug should be less than the effective concentration and it should not be more than the toxic concentration. So now, basically, when we do our proper pharmacokinetic studies, they provide us with the foundation. So that means these studies must be done in the early stage. Why they should be done at the early stage? Because they will help us to know what are the next studies we need to do. And they will also help us in designing the proper dosage regimen. Now, we normally think, okay, fine, the early stages, but it extends also to the later stages. We do these studies at the early stages and then also in the later stages. Why? Because we also know there are a lot of variability because of the gender, because of the weight, because of the age, because of the different pathophysiological conditions. So much of variations happens in individuals. And now I'll just talk about these few points. Now, which route of the administration does not have the absorption step? I will ask you a simple question. So which route of administration does not have the absorption step? IV. So rest all these routes of administration, they have to go through the absorption step. When we talk about absorption, what is absorption? It is basically the amount of drug which reaches the blood circulation. Now, if I'm talking about the absorption, I must know about the lipid solubility of the drug, and I must know about the pKa and pH. Now, can you tell me out of pK and pH, which one is constant, which cannot be changed? When I'm talking about pK and pH, what is that which cannot be changed? pK of the drug, that is constant. You cannot do anything. But can you change the pH? Yes. How will we change the pH? We can add something to our drug formulation. So when drug is released, the pH in that area will be changed. Now, suppose we are adding sodium bicarbonate to our drug formulation. So when the drug releases, the pH will be changed from acidic to alkaline. So maybe the absorption is better in the alkaline state. So that is how the ionization concept is very, very important in drug development. So we must know that the drug has, in which form should we use the drug? Ionize or unionize? I could hear some people saying ionize. No, unionized. Why unionized is very important for us? Because only unionized form of the drug will be more lipid soluble and it will diffuse through the membranes. So that is why we must concentrate that a drug remains in the unionized state. And in which part our drug is getting absorbed? In our small intestines. We all know that why. Now, can you tell me, when we talk about bioavailability, do we say our drug is effective? When I say my drug has 100% bioavailability, does it mean my drug is fully effective? No, definitely no. The bioavailability is only talking about the drug reaching the blood circulation. It has nothing to do with the effectiveness. Effectiveness is something when the drug is attached to the receptor site and it exerts the action. So remember that bioavailability is only referring to the drug is reaching our blood circulation. That is where it ends. Now, when I'm talking about the rate and extent, rate means how much time it is taking, and extent means how much it is reaching the blood circulation. Now, we don't achieve 100% bioavailability. We all know that. If we are giving by other routes, what are the basic reasons which we really need to take care if we are developing the drugs? Our drug should not be destroyed in the gut wall. It should not be destroyed in the liver. It should not have incomplete absorption. That is what, if we can achieve all these, that means we can achieve the best results. Because what happens? Only our drug is not reaching the blood circulation because of so many other factors. So which we need to address too. Now, this is simple curve, which all of you must have seen. So now it is basically the comparison. How do we do the comparison? We take drug in its IV form or in its most soluble form. That means in most available form is either the solution form or the IV form, which we say. So whenever we are comparing bioavailability, we are comparing it only with that form. Now, when I'm talking about area under curve, what does area under curve measure? Sorry? What does area under curve measure? Can you speak loudly? It's bioavailability. So area under curve measures bioavailability. So what are we measuring in this picture? We are measuring Cmax, maximum concentration, which it achieves when the drug is having its half-life, and what is the minimum concentration it needs to achieve. So these are various things which we can obtain from our area under curve. Now, if you look at this figure, can you tell me what is this figure? It is for the same formulation digoxin, 0.25 milligram, but it is showing different lengths. That means the different makers are showing different bioavailability. So what is this digoxin? Which category of drug does it come under? Narrow therapeutic index, right? What is narrow therapeutic index? That means there is very low margin of safety. So when there is very low margin of safety, can we switch brands? Can we switch brands? Now I have this brand A, then I'm moving to brand B. If I have to change my brand, can I do that? I cannot. I cannot change my brands because I have to do proper studies when I'm switching the brands. So that is why we need to know about these steady state concentrations. We need to know about the loading doses and food drug interactions. I'm sure all of you have studied that how we need to be careful when we are giving food in the fed state or in the fasting state. Why do we give drugs as empty stomach? Thyroid medicines are when we take our thyroxine or levothyroxine, we always give it as empty stomach. We take it as a first thing in the morning. Why? Because if we take it with food, its absorption is affected. How did they come to this conclusion? Because they did pharmacokinetic studies. If they would not have studied this, would they have been able to find out? So there are still many patients, if you go to the clinical side, where doctors sometimes, if they do not tell them, people take their breakfast and then they start taking their thyroxine medicines or thyroid medicines because they are not told. So these are few things which as a pharmacy people, we must know that how the drugs need to be taken. Now there are certain drugs, like even if you look at simple drug like penicillins or you take like tetracycline antibiotics, they saw that when it was taken in the fasting state, its absorption was almost 50 to 80% more. So that is how we need to emphasize on importance of before food, after food. Sometimes they cause gastric irritation. So we need to write down all these things in our labels. How do we reach this? If we have done proper pharmacokinetic studies. Now, there are some antifungal drugs like griseofulvin. How do you take them? You don't take them empty stomach. How do you take them? In the fed state. Can you tell me one thing? We always take it after food. Why do we take it after food? What is that which is making it better absorbed in that state? Because when we take it after food, what is that? We have more bile production. And what does bile contain? It has more bile salts. What do the bile salts do? They have emulsifying agent. So what have we seen? Again, our pharmaceutical properties, our biopharmaceutical properties, because of improved emulsification, we are giving drug in the drug after food. So these are few things which we need to understand. Now, when we talk about distribution of the drugs, now you know that even if we try, we need drug only for the heart. Does drug only go to the heart? No, it is going to every organ, general organs, specific organs. It goes to the body fluids. So now you can see that when I'm talking about distribution, now there are patients with low albumin content. Can you tell me where do you have low albumin content? Where is low albumin content? People have hypoalbuminemia. Yes, they have some liver problem where the synthesis is a problem. Or they might be having uremia. They might be having kidney failure. Now, what is happening? Kidneys cannot discriminate what it needs to retain or what it needs to filter. So what will happen? Our distribution will be affected when we have low albumin, or we have any problem with our heart or with circulation or with diabetes. Then now, how is our membrane functioning? What type of protein binding it is going through? And this is a very interesting slide, which I personally like. It is talking only about the volume of distribution. Now you can see when I say drug has very low volume of distribution, what does it mean? Where is the drug confined to? When I say drug has low volume of distribution, where is the drug? That means drug is only in the blood. It has not reached the tissues. And which drugs we call as a low volume of distribution? Now, drugs which have very high molecular weight and drugs which are strongly bound to plasma proteins, they have very low volume of distribution. They cannot reach the tissues. But when I'm talking about the mid volume of distribution, I talk about this extracellular water, intracellular water. Then I'm looking at volume of distribution of 12 to 14 liters. but then again, high volume of distribution, which is more than 42 liters. So which drug has a high volume of distribution? Can you just name one drug which is very high volume of distribution? Digoxin. Now, digoxin has a very high volume of distribution. What does it mean? It means it is not confined to blood, but it is reaching the tissues. So that is the point of volume of distribution which we need to focus on.
Ma'am, sorry to interrupt you. Time is over. Your time is over.
40 minutes?
No, ma'am, already over.
40 minutes over?
Yes.
Okay. So give me just 5 minutes. Just 5
Please,
minutes.
please, ma'am.
Yeah, just 5 minutes. I'd just like to touch upon these different time course studies. Now, this is the slide where we talk about different disease states, that how renal failure is now affecting the binding of acidic drugs, how it is affecting the binding of basic drugs, how hepatic failure, inflammatory diseases, they are affecting the binding of various drugs. Now, I'll just talk about the time course of the studies, which are, the time course of studies is basically about the steady state. Now, what is steady state? We when we give the loading dose to our patients, there's a difference between loading dose and maintenance dose. Loading dose is basically helping to achieve the steady state. Once we have achieved the steady state, then we shift to the maintenance dose. So this is what we need to also understand. And also we should know that how different population, they are having a different dosing issues. Now, therapeutic drug monitoring is something which we all need to focus on when we are developing the drug, because of the interpatient variability and because of the pathophysiological conditions. We should see linear kinetics. We should see non-linear kinetics. Non-linear is where saturation happens. So we need to also see that drug is not reaching that saturation state. Michaelis-Menten kinetics, we all need to learn when we are doing that. These are some softwares which we use for our pharmacokinetic studies. So basically, this non-MEM is the most widely used, but we have our integration of R with physical this. So these are some take-home points which we must know, that search for new drugs includes drug discovery and drug development. And what are the basic causes for failure is the poor bioavailability and drug interactions. And TDM is basically to achieve the right dose and also to individualize the dose in different types of the patients. These are few of my publications with my students where we use pharmacokinetic principles for drug development. We also published a book on biopharmaceutics where we try to use our research in all these applications. So it's a very, very important field which we all must study. And there is no drug which produces a single effect. Remember, when we are chewing our drugs, we are also chewing lots of effects along with that. And thank you so much for your patience and for listening. And these are some beautiful pictures from Oman, which I'm just sharing. This is the place where I live. Thank you so much. Thank you. Have any questions? I can.
Any questions?
Yeah.
Please.
Can you speak a bit loudly? You can take. Yes, please.
Thank you so much for wonderful presentations. I have a question, ma'am. How do the preclinical assay work to define the ADME biotherapeutics of a drug? How do preclinical assay work to define the ADME profile? Preclinical.
In preclinical studies, how do you do the ADME profile?
Yeah.
That's what you're asking. Basically, first we do the in vitro studies. We all know that we start with the dissolution, which gives us only an idea about the drug release, because if the drug is forming a complex with its excipients, it will not release, right? So first is you start with that, and then you do your in vivo studies in the animals, and then you establish the correlation. If the relationship is linear, that you know that your drug is getting released from your dosage form, and it is also going into the circulation. That is the first correlation which we develop in our preclinical stage. Once our relationship is linear, then we move on to our toxicity studies to see, and also whether it is drug is properly metabolized or drug is being eliminated, and check its half-life. So these are all the studies which we continue after that.
So, ma'am, we need to perform the preclinical study in a multiple species or
In multiple?
Multiple species means like rodents, small
Normally,
animal.
no, we don't do our studies in multiple species. Normally, we choose I remember we used to use mostly on rabbits or our guinea pigs and all that. So these are studies which we used to perform, and we also used to actually check the release of drug inside the blood. Now, when how we do that, we do through various methods, like we use tagging also. We take blood samples at different time intervals, and we have a lot of analytical techniques. And these are things which we do. And we used to normally do in only one species. Only when we used to do our toxicity, or we still do our toxicity studies, and then we do the pathological studies. And we take out their liver samples or their kidney samples and etc. And we see if they are causing any changes in that thing. These are must. You cannot reach any stage till the time you have completed the toxicity studies and the in vivo availability studies. I've seen still sometime I'm evaluating the thesis, I find those studies are not done. These are a must. Any work must have in vivo release studies.
Yeah.
Yeah.
Thank you.
Okay. Yeah. That's all.
Thank you, madam, for this very resourceful talk. Now I request session chair, Dr. Vikesh Kumar Shukla, sir, and Dr. Nitin Sharma, sir, to please felicitate Madam Alka Ahuja. Can you have a big round of applause for them?
Thank you.
Thank you, ma'am. Moving ahead, now I would like to request session chair, Dr. Nitin Sharma, sir, to please introduce our next speaker, Madam Nidhi Sandal.
Good afternoon, ladies and gentlemen. We are fortunate enough that we are having one scientist from the INMAS, Dr. Nidhi Sandal, ma'am. This is my opportunity to introduce Dr. Nidhi Sandal is a scientist working in INMAS, which is a DRDO laboratory. She is doctorate in the pharmaceutical science with more than 15-year experience in the field of the pharmaceutical science and intellectual property right. Prior to joining DRDO, she had worked as a research scientist at Vocard Research Center, Aurangabad. She has also served at IPR group of DTE of ER and IPR for 9 years. At her present position in INMAS, she is working on the development of formulation for decorporation of internalization radionucleotides. She has the first ever technology development fund project of life science cluster, which is successfully.
Thanks.
Sure, ma'am.
Thanks.
Okay. Although ma'am is a wonderful feather on her heads, but because we are having the short of time, so the stage is yours.
It's very nice, and yeah. Very well. Thank you, Nitin. No, it is directly for presentation. I think that we are running out of time.
I'll take a minute, ma'am. Just.
No, thank you.
Ma'am, just a minute.
Yeah, go to the first. Thank you, Dr. Nitin. Dr. Nitin, Dr. Navneet, Dr. Mahendra, Dr. Deepti, so many of people are there from my institute, and they are I think the most bright stars of INMAS, and I am sure they are shining as bright as here also as they were shining at INMAS. So, and I think organizers are getting a little bit worried. Time nahi hai, jaldi jaldi karna hai. So I will not take much of the time. There are a lot of students, and I'm the last speaker of this entire program. And when I saw this particular program, I think the title was Translational Research, like how to translate the research that your people are doing in the laboratory and then getting it into the commercial market. Although I could have chosen any other topic to speak at this particular forum, but I thought let me share my the product that has come out from my lab, which has actually translated from the lab to the commercial use. And I would like you to give a very big round of applause for your own faculty, Dr. Mahendra, who had been the most instrumental person when we were doing all this work. And he has contributed. It's a very special drug on which we are working. INMAS, as you know, it's a nuclear medicine institute, and all the faculty whom I named, they have worked on all these special medicines. They have not worked on the commercially viable products. So this is a very unique product. And also the development of these products is also very unique. But we were very much focused that we have to bring it to the market so that it should become available to the general public at large. It's an emergency drug. So the topic is the development of India's medical countermeasures for radiological and nuclear emergencies in India. We have two products, Prudicorp and Prudicorp MG, which are commercially available. I'll just give you a brief. This is the outline of my presentation, although I will not take much of the time in covering each and every aspect. I'll just be touching everything very superficially on this. Now, what exactly happens in case of a nuclear emergency situation? Since in INMAS, we are discussing this topic almost day, night with every student. The day anybody enters my lab, I will have to tell him, तुम्हें पता है what happens in the nuclear emergency situation? Actually होगा क्या? कैसे हो जाएगा? So actual में, if you go there, the first thing that will happen is that in case of any nuclear emergency situation, there will be external irradiation, external contamination and internal contamination. See, these people are nodding their heads like this. उन्होंने पिछले 6 साल Nitin is there. They all have, worked on all this. इसको उन्होंने breathe in, breathe out किया है. So actually the irradiation happens. Irradiation is a problem. Suppose if there is any nuclear radioactive source, so you all will be getting irradiated out of that. That is irradiation. But there is another problem. It may get stuck onto your body, onto the external surfaces. That is external contamination. Then there is another probability that it may enter your body itself. Unvoluntarily or unknowingly, you happen to come here and you touch that area, and then, it through your mouth or nose and any part of the thing, it can go inside your body. Now, what will happen when it will go inside your body? Can anybody guess? क्या होगा? The radionuclides, what will they do? When they go inside their body, they will start behaving like your normal physiological ions. Cesium, radioactive cesium-137, when it will go inside your body, it will start behaving like potassium. अब आप मुझे बताइए potassium कौन से part में नहीं है हमारी body के? It is everywhere. So what will happen is, although your external contamination has been removed, but you yourself is a source of radioactivity. Aapka internal viscera is getting affected. So the situation becomes very complex and very dangerous also. You are under a threat of such a big problem. These are certain data which has come up from the Fukushima accident. I hope you people can recollect in 2011, there was a major earthquake in Japan. And then the Fukushima nuclear reactor number 4, it bursted, and a lot of radionuclides, they got released. and that particular area. In fact, Chernobyl also is one of the example where this blast has happened. So those are the places. And let me tell you, I think more than 2,000 square kilometer area is still deserted near Chernobyl. Still the impact is still there. It's going to be, I think, more than 30 years or something, 86, you can just calculate. So these are the radionuclides which generally get released: iodine, cesium. They are primary cause of concern for our health. They contaminate the flora and fauna. They get into the food cycle, they get into the water cycle, and they do come inside. They have a very high probability that they can come into our bodies also when we take these contaminated things. This is ARS, as I told you, outside external irradiation that takes place. Then there are certain strategies. Don't be afraid. ऐसा नहीं है कि कुछ भी नहीं है हमारे पास, कुछ है. So these are certain drugs which are already approved by US FDA, and fortunately they are available in India also. And we are using them as an, in case of any cancer therapy, these drugs are used and they are available, although they are not being, stockpiled or approved per se. If I say the regulatory approval nahi hai, but still we do have these medicines with us. This is the drugs which are required for the internal decorporation. When the radionuclide goes inside your body, these are the drugs which are required. These are approved by US FDA and several regulatory bodies like European Medical Agency has approved it. Japan Medical Agency has approved it. There are quite few medicines, but unfortunately, these are not available in our country. So, but as you know, India is a nuclear state. We have 22 nuclear reactors and 8 nuclear power plants. So our, probability of happening such kind of accidents cannot be denied. It can happen. And then plus there are certain, antisocial elements who can do such kind of damage. So that is also not, an absolutely no situation. It may happen. So India also has to have such kind of remedies which should be available in our country. So my lab is very much dedicatedly working on one antidote. See, this is a very big problem. I cannot make you understand, means the persons who have never worked in or never studied, I cannot make you understand the magnitude of the problem that I am talking about. So whatever we have done, it's just a very small initiative that we have started by doing this work, but still we have been able to achieve it and we have been able to make it commercially available in India. So we are working on cesium-137 very, very specifically. Cesium-137 is basically gamma rays are emitted out of it. It's gamma radiated, and there are certain, the most important aspect of cesium-137 is it has 30 years of its half-life, radioactive half-life. So if you have a particular radioactive source, which is, the radioactivity is say 1 curie, so half of this will go in 30 years. So till 30 years वो आपको irradiate करता रहेगा. अगर वो आपकी body में है तो वो आपको irradiate करता रहेगा जब तक आप उसको remove नहीं करोगे. But there is another aspect. Second aspect is its biological half-life. I think everyone can correlate what I'm talking about biological half-life. That is 110 days. That's also not less. 110 days, if something is there inside your body, it's quite a huge time. So there has to be some mechanism, there has to be some strategy so that its removal should be, done as fast as possible. So there are certain, pharmacological properties, as Alka ma'am was highlighting. These are very, very important. So I'm not going into details of that much. So as far as radioactive cesium is concerned, there is only one drug that is available commercially. That is RadioGuardase CS. That is available in US, Europe, Japan, and some more developed countries, but not in India. This is one of the very expensive drugs. That is an antidote, although the drug is, the dose is very, very high. It varies from 3 to 10 grams per day, and the therapy would continue for 60 days, 120 days, depending upon the contamination that takes place. And let me tell you, I had worked with many patients. This is an antidote for thallium poisoning also. Thallium poisoning, I think you people must have heard in recent times. It has become very, known to the people because of the several cases that have emerged. This is the only drug that is recommended for that. And one capsule cost is 1,000 rupees if you import it from US. ये तो मैं आपको 1 साल पहले का रेट बता रही हूँ, आज का तो मुझे पता भी नहीं है। तो आप सोच लीजिए अगर आपको अराउंड 10 कैप्सूल्स भी एक दिन में लेने हैं तो 10,000 रुपये पर डे थेरेपी कॉस्ट है इस पर्टिकुलर ड्रग का। सो ऑब्वियसली इन केस ऑफ एनी न्यूक्लियर इमरजेंसी सिचुएशन ये आपको नहीं मिलेगा। पहली बात तो है कि गवर्नमेंट हाउ मच दे विल बी एबल टू एक्सटेंड यू, एंड देन द कॉस्ट इज एग्जॉर्बिटेंट, एंड कंटिन्यूइंग अ थेरेपी फॉर 60 days 120 days, यू कैन योरसेल्फ इमेजिन क्या कॉस्ट रेपरकशंस होंगे इसके। Radioguarded CS is basically a Prussian blue. I'll just go there. It is basically a Prussian blue insoluble. Prussian blue, I think, is a, जैसे ही वो हम शब्द बोलते हैं, everyone correlates कि ये कोई डाई है, ये डाई ही है, ये एक्चुअल में डाई ही है जो कि आपको मार्केट में मिलती है, एंड लेडीज आर वेयरिंग सो मेनी इंडिगो कलर कुर्ताज एंड साड़ीज एंड दुपट्टाज, ये वही डाई है। बट यू पीपल आर वेरी वेल अवेयर, हम वो डाई नहीं खा सकते। इनफैक्ट लेट मी टेल यू 2021 में एक जब हमारे पास केस आया था, थैलियम पॉइजनिंग केस आया था सर गंगाराम हॉस्पिटल में, 4 पेशेंट्स, 4 तो नहीं, आई वुड से 3, क्योंकि एक की तो डेथ पहले ही हो चुकी थी। वो जो केस था, आई थिंक अगर आपको याद हो, सन इन लॉ ने अपनी इन लॉज फैमिलीज को फिश में थैलियम मिला के खिला दिया था। सो द गर्ल डाइड, सिस्टर इन लॉ डाइड इमीडिएटली विदाउट बीइंग डायग्नोस्ड। बस उसकी वाइफ, उसके फादर इन लॉ और उसकी मदर इन लॉ, they were the survivors when the doctor contacted me, means our lab, they contacted us because we, I think in entire world, in India's map, my lab or maybe somewhere in BARC, some people are working on this problem. So they contacted us. So that at that time they wanted to have this drug and they said, इन्होंने नेट पे चेक किया, अरे वो तो 340 रुपीज पर केजी मिल रहा है, उसको ले लेते हैं, वही खिला देते हैं उनको। But we all know that is not possible. So we have to have a product which is free from all the impurities, which is GMP certified manufacture facility में वो बना होना चाहिए, approved होना चाहिए, because all the parameters have to be complied as per the CDSCO norms. And there is one more important thing. When I was dealing for this particular product with the CDSCO, I found that their first and foremost concern was safety. एफिकेसी अगर 19 से 20 भी होगा, मतलब 20 से 19 भी होगा तो भी चलेगा, पर सेफ्टी किसी लेवल पे कॉम्प्रोमाइज नहीं करते हैं। तो बिकॉज व्हेन वी वेंट टू द CDSCO विद ऑल द डेवलपमेंट दैट वी डिड, ऑल द पैरामीटर्स दैट वी वर एबल टू वैलिडेट, दे वर वेरी क्लियर, it has to be safe, their purity level, there should be no impurity, there should be nothing of that sort. So that was there. I think मैं ज़्यादा बोल रही हूँ, but I'll just try to wind up. Prussian blue insoluble के ऊपर हमने बहुत intensive research किया है अपने lab में, and let me tell you, as I told you right from the beginning, मेरा objective था कि it should be made available in India. तो हमने regulatory point of view से उसकी research की थी, और regulatory point of view से ही हमने parameters define किए थे। तो मोस्ट इंपॉर्टेंट पैरामीटर था वो प्रोडक्ट बनाने का जिसका सेफ्टी इंडेक्स बहुत ज्यादा होना चाहिए। सो दैट इज व्हाई ट्रांसलेशनल रिसर्च में ये बहुत जरूरी है दैट वी शुड बी राइट फ्रॉम द बिगिनिंग, वी शुड नो दैट व्हाट एग्जैक्टली द स्टडीज वी हैव टू डू सो दैट द CDSCO would be satisfied, or the CDSCO would be convinced that they can give the approval for this particular drug. Now in this particular drug, since it's a orphan drug, it's not required in at large in general population. So the parameters that need to be defined, they were also very, very important, and not much literature was available on that. So we did the entire thing. It's an antidote for cesium. It's an antidote for thallium also, as I told you. So in the laboratory, as I told you, with this perspective only, we did all the research. हमने कोई भी ज़्यादा research नहीं किया. Okay. So we did all this laboratory research. I'm not going in all these things, but let me tell you, ये सारे parameters right from the beginning ही identified थे जो CDSCO को satisfy करने के लिए होने चाहिए थे। उसके अलावा एक तो हमने उसका indigenization पे काम किया, दूसरा हमने एक novel product पे भी काम किया, which was basically for the rescue responders, because I work from a defense laboratory. So my first priority is my defense forces. So my defense forces need to be protected when they are entering into such kind of zones. So the prophylactic product is also very, very important. So we did work on that. After that, we did the industrial development. Industrial development is huge serpentine process, which goes up, back, so many steps happens for the API as well as for the formulations. Then we submitted, we did the review, the products got approved. We also protected the intellectual property rights very, very carefully. Being from IPR and having a good experience in the IPR, that helped me a lot in understanding the dynamics that should go behind when I'm talking to the industry. The publications were equally important. Many a times people don't think a publication important, but for each and every parameter, DCGI subject expert committee asked me, have you done the publication for this? Is it a peer reviewed? Or then only we will, entertain this. So these are the two commercially available products. Both are available commercially, and recently in the G20 summit, AIIMS Trauma Center was designated at the CBR and center to handle any kind of emergency. These drugs have been stockpiled there. And unfortunately, recently one thallium poisoning case emerged in AIIMS also. They are using it for this purposes also. Now, this is a very, very important thing. हम लोग अप्रूवल तक ही सोचते हैं कि वो हो जाएगा, बट अप्रूवल ही सब कुछ नहीं होता है. इसकी तो कहानी अब शुरू हुई है. एज आई टोल्ड यू, ये ऑर्फन ड्रग है. इसका कमर्शियल बैच बनाकर करना क्या है, ये एक अनदर चैलेंज है. So the post-marketing approval management of this particular drug is very different from all the commercial review. What I'm trying to highlight through this particular thing is that whenever you are working on any kind of a product or any kind of a research area, you should be very, very thorough in where you want to take it further. Otherwise, what happens is, like, as we are facing the criticism, all the academic institutes, sometimes they face this criticism that they are doing so many research work, so many PhD students are getting generated, so many MPharm dissertations are happening, but कुछ आ नहीं रहा है. तो मेरी बस इस पूरी presentation से एक ही request है कि right from the beginning it has to be done. It cannot happen कि आप, ठीक है, there are certain areas where you have to do some research and then उसको how to take it forward. Obviously एक baseline के above ही हम इसकी बात करते हैं, but I will not take much of your time. Thanks for your attention. Thank you.
Thank you, Nidhi ma'am, for such a wonderful presentation and sharing your view and experience on this decontamination of radioactive material. Though you have mentioned that you are working for the soldier, but at last the common population, our kind of the common public, are also under the threat of this nuclear disaster, and I hope ki INMAS are also working on that field as well. So now, after this presentation, the platform is open for the question answer round. If any, yes, please. Can you just come here because we are having the short of mic.
Thank you for the presentation, ma'am. This is really a unique topic for us to learn. I just want to ask that you have said one product is approved from CDSU. It got approval last year. So what are the trial data which you showed and how you got the patients?
See, this is an orphan drug. That is what I'm telling you. Right from the beginning, we had worked on its regulatory approvals and everything. I didn't go much into the details of that. Prussian blue insoluble is a locally active drug. It does not get absorbed into the systemic circulation at all. So as such, as per the Drugs and Cosmetic Acts, the BA/BE of this particular drug cannot happen.
Right.
So that is why there was no trial required. So phase 1 was not required because there is no BA/BE or any pharmacokinetic is to be done. Phase 2 trial of orphan drugs cannot be done. Right. So
But
that is
phase
why.
3 is required.
No, it is not like that.
Phase 3 is required if there is no global clinical trial data in that case.
It gets approved, and as and when the cases emerge, these drugs are used, data is collected, it is being documented and submitted to the DCGI. Okay. So the clinical trial part was not there in this particular drug at all.
Okay. And similarly, for other products, you have got approval from US FDA and EMA also?
No. US FDA, though, I was telling you the present state of the art.
Okay. So only one product is approved in India as of now?
Two products have been approved in India.
Precorp, okay.
The Prudicorp and Prudicorp MG.
Okay.
Yes,
And the second question is that you said that these drugs are used for emergency situations and you cannot manufacture the drug before. So what is the shelf life? I mean, in case of emergencies, how much time manufacturers will take to develop a drug?
No, these drugs can be manufactured at any point of the time, but the problem is there is no demand for
There's no
these drugs.
requirement from the market.
Yes.
So why manufacturers
So,
will invest?
yes. So what happens is then it becomes the priority of the government to stockpile these medicines for emergency situations.
In that case, how much is the shelf life for stockpiling?
Shelf life as on date, it is 3 years. But as I told you, I didn't go much into the details. We have already put up the commercial batch into the shelf life extension studies.
Okay.
So there is a probability that we can get it extended up to 5 years or 10 years.
Okay.
So if we are able to do it, then it's a win-win
Okay, so
situation.
that will be a good situation. Thank you.
Thank you.
Thank you, madam. Now I request our session chair, Dr. Nitin Sharma, sir. To
Just
please-
a minute, just a minute. Yeah. So there are two products, ma'am. And what is the basic difference between these two products?
And what happens is the efficacy we have made the hand that the pH of the gets increased, and when the disease is not find it with 1 hour
Okay.
so within for 1 hour it becomes more active. That I'm saying
So in this case, if you see the cesium and thallium, these isotopes should be, means they should enter stomach first to impact. If ingestion is not there, the area is there where this kind of radioisotopes are there. So then how this particular drug will help? Okay. Then only this. Okay. Thank you.
Ma'am, I have two questions, and for one, I got answers. But is the difference between these drugs? And the second question, which is the most important, you told me that the US FDA drug, which cost single pill is 10,000 rupees, and what is the cost of our this drug, indigenous drug? Okay, so means it is relatively less. Okay. One time. Great, man.
Thank you, madam. I request session chair, Dr. Nitin Sharma, sir, and Dr. Vikesh Kumar Shukla, sir, to please felicitate Madam Nidhi Sandal. Can we have a big round of applause for ma'am? Thank you, madam. To conclude this session, I would like to request Dr. Chitme, sir, and Dr. Bhupesh Sharma, sir, to please approach to the stage to felicitate our session chairs. Dr. Vikesh Kumar Shukla, our session chair, sir. And Dr. Nitish and Nitin Sharma, sir. Can we have a big round of applause for him? On this note, we conclude with this scientific session 4. We'll be starting with the validatory ceremony soon. Thank you.
रूपेण समस्थिता नमस्तस्य 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 नमो नमः. A mantra which is a salutation to Goddess Saraswati, invoking her divine blessings for intellect, creativity, and learning. With the Sis Saraswati mantra, a very good afternoon and a warm welcome to all of you to this valedictory session. I, Ramanpreet Walia, along with my co-coordinator, Dr. Swati Madan, welcomes you all to the valedictory session of this 2 days SERP-sponsored international conference on pharma technology and translational development in Chem-Biology research, traditional to pharmaceuticals 2024, PTT DCBR 2024. Every ending is an opportunity to move forward. With this saying, let us initiate utilization from all the learnings of the conference to foster the curiosity and critical thinking, promoting innovation and creativity, and develop a problem-solving skills. Over the last 2 days, we had a deep insights into several issues of traditional scientific knowledge, phytopharmaceuticals, tissue engineering, pharmacology, and stem cell-based drug delivery systems. We also focused on drug discovery, formulations, and regulatory compliances in aspects of pharmaceutical and medical devices. This had given an opportunity not only students, but also the faculties to build up the confidence in academics and research. So without further ado, I invite all the dignitaries on dais to come forward for lighting of lamp. Thank you, everyone. Let me pause and mention an important note that one of our guests, Dr. N. Zahir Ahmed, Director General, CCRUM, Ministry of Ayush, Government of India, who is not able to join today's valedictory session due to some unavoidable assignment. However, he has conveyed his best wishes to the organizing team for a successful event. Thank you so much, sir. As a pious tradition, let us welcome all the dignitaries by offering a Tulsi saplings. So now I request Professor Dr. B.C. Das, sir, Dean Health and Allied Sciences, Amity University, Noida, to come forward and offer Tulsi sapling to our chief guest, Dr. Asim Ali Khan, Dean, School of Unani Medicine, Education and Research, Jamia Hamdard University, and Chairman, Scientific Advisory Committee, CCRUM, Ministry of Ayush, Government of India. Although Dr. Selva Murthy, sir, President FSTIA, couldn't able to join on in person. So he has joined all night. A very warm welcome to you, Selvamurthy sir. Now I would request Dr. Havagire R. Chitme, Deputy Director, Amity Institute of Pharmacy, to offer Tulsi sapling to our own Professor Dr. B.C. Das, Dean Health and Allied Sciences, Amity University, Noida. Thank you, sir. Taking forward, now I welcome Dr. Havagire R. Chitme, Deputy Director, Amity Institute of Pharmacy, Amity University, Noida, to deliver a welcome address for today's valedictory session.
Thank you, madam. Warm greetings to everyone. Godly Founder President, Sir Dr. Ashok K. Chavan, Honorable Chancellor Dr. Atul Chavan, Sir, Honorable Vice Chancellor Professor Dr. Balwinder Shukla, Madam, most respected Chief Guest of the function, Dr. Asim Ali Khan, Sir, Dean School of Unani Medical Education and Research, Jamia Hamdard University, esteemed W. Selvamurthy, Sir, President ASTIF, the most regarded Professor Dr. B.C. Das, Sir, Dean Health and Allied Sciences, Amity Institute, Amity University, Uttar Pradesh, esteemed dignitaries on and off the dais, my dear colleagues, dear students, dignitaries, participants, and sincere volunteers. It is with great pleasure and honor on behalf of the organizing committee of the second PDT CAB 2024 that I extend a warm welcome to you all to the valedictory function of the 2 days international conference. The 2-day deliberations and talks by eminent intellectuals, scientists, professors, and academicians were fruitful, with each sharing and learning from the others. I am confident that throughout the course of these 2 days, attendees had the chance to network with academics and industry professionals and broaden their understanding of pharmaceutical technology. We would want to sincerely thank each and every one of the distinguished panelists and speakers who visited us both on campus and virtually and shared their research experience with our attendees. We have made every effort to provide you with the most insightful and useful information possible. Our volunteers have given their all to ensure that your time at Amity University, Uttar Pradesh is both comfortable and productive. We sincerely apologize for any issues that these 2 days may have caused you. We will compile an extensive report on the conference and share it to all our stakeholders along with the six most important recommendations that have emerged from the deliberations that spanned these 2 days. The first one, so in India, strategic shift is urgently needed from the volume-driven to the value-based pharmaceutical industries. The second one was to achieve Viksit Bharat, efforts must be made to foster entrepreneurship and startups in the pharmaceutical industry. The third recommendation was well-designed and executed pharmacokinetic and pharmacodynamic study could facilitate the successful development and commercialization of Indian system of medicine. The fourth one was to ensure the effective launch of the Indian medical system, a multidisciplinary research method involving stem cell and tissue engineering, CAR T cells, immunology, and molecular research is required. The fifth recommendation was to promote the advancement of AI-based drug discovery and development process. The last recommendation is the Indian traditional medicine system should focus on better management of chronic diseases and disorders as core therapy, adjuvant therapy, alternative therapy, and complementary therapy. So I would like to thank our founder president, sir, for his blessings, our honorable chancellor, sir, for inspiring and motivating us, and our honorable vice chancellor, madam, for her wise leadership and guidance. Special thanks to the chief guest for sparing valuable time and sharing his thoughts with us. I would also like to thank the most lovable and adorable Dean of Health and Allied Sciences for being here despite of his busy schedule and addressing this important gathering. I would also like to thank Dr. Selvamurthy sir for joining us online and blessing us sir all the time. So I greatly appreciate sir. So I would like to extend a hearty welcome to all dignitaries and attendees again for this valedictory function. Once again, thank you so much for all your active participation and making this event a grand success.
Now I would request, thank you so much for these wonderful welcome address, sir. Now I would request Professor Dr. B.C. Das, sir, Dean, Health and Allied Sciences, Amity University, Noida, to address the gathering.
Well, very good evening to one and all, and the esteemed dignitaries and the dais. I welcome all to this august valedictory function. You had a very quick or fast conference for 2 days conference, which was the international conference on, it is mostly not international, but national. Some participants from or speakers from outside. So Pharma technology translation development in Chem-Biology research. Translational to biopharmaceuticals. So most important is the everywhere translational. You have traditional to biopharmaceuticals, but it's a translation research or translational means something you develop, means which is just you study, do research, but which is translated to product or processes. But before I speak few words, because on the yesterday during the inaugurations, I was not there because of my urgent work or some medical reasons. I had to go somewhere for the family reasons. So which was scheduled, pre-scheduled. So I could not be here in the inauguration. So I would say a few words of that. Before that, it is with the utmost the blessings of our honorable, most respected founder president, Dr. Ashok K. Chauhan. You have come to know those who have come from outside. Inside people know, but those who have from the Amity, but those who have come from outside, they may not be knowing. I hope during your 2 days hectic conference schedule, you must have had some time in the evening to see around this university. This is a huge campus, but one campus here only. So you could have looked into some opportunity you must have seen. So this is one of the, or this is a flagship university, which is the original and the first one to be established by Amity, this foundation, which is the founder is Dr. Ashok K. Chauhan. He is a great philosopher, scientist, and whatnot. So he created this institute. There are 12 more universities in the country, and there are 17 campuses abroad, including 28 schools. So Amity, if you enter into the KG in the schools, then you can come out with the PhD or postdocs. So even you can build up your career here if you are so great. So this is the beauty of this Amity organization, Amity University, that you are in for 2 days for this excellent conference. The first of all, that on behalf of our Honorable Founder President, our dynamic Chancellor, Dr. Atul Chauhan, and our respected Vice Chancellor, Honorable Vice Chancellor, Professor Dr. Balbinder Shukla. You must have seen her speaking in the inauguration time. And on behalf of all the Amity fraternity, my colleagues, my deans, HOIs, and all the faculty colleagues, and all fraternity of Amity, I welcome to this valedictory function. And I welcome all the guests. And the first important is Dr. N. Zahir Ahmed, who was to be the chief guest to address this occasion, who is the DG, Director General of CCRUM. So he could not come because of the, say, secretarial positions. So some important emergent meeting with the government ministry or somewhere, he could not come to this, though he was very eager to come, and I know him through all the, and he once came to Amity also, but this time he was as a chief guest to address. But nevertheless, we have a guest of honor, Dr. Asim Ali Khan, who is already told that he is a Dean School of Unani Medicine, Medical Education and Research at Jamia Hamdard, one of the top pharmacological or the pharmacy institutes in the country. But he was also the former DG of CCRUM, which they now Dr. N. Zahir Ahmed holding the position. So he is extremely, Dr. Asim Ali Khan is very much scientific oriented, and I have had the opportunity to interact with him, and he has recently, last week, he has done the PhD from here, Amity University, means he has awarded the PhD. So PhD Viva was held. So you can imagine that the age is no war. At this age, coming over and doing the PhD, having that academic interest or research interest, that proves that what is his, how he is interested with the science and innovations. So thank you so much for coming over and addressing our students and colleagues. And also my colleagues all are there, the Deputy Dean, Dr. Nabed, or Dr. Chitme, who is the recently taken over joined this Amity Institute of Pharmacy. So he is the Deputy Director and Deputy Director and the officer in charge of the officiating head of this Amity Institute of Pharmacy. And also along with that, Dr. Binay Lathar, Professor Binay Lathar, he is also center head of the pharmaceutical chemistry, but he is also the officiating head. So joint officiating head. And then your organizer. So who is your organizer? Navneet Sharma. So you know that, you understand, you recognize him. He is your organizer, because any scientific meeting or conference we go, we very well understand who is the organizer, because everything you have to refer to him before joining, to phone him, accommodation, this thing, that thing. You will always know is the person. There may be many more important person, but for the participants, the most important, the organizing secretary. So he is the Navneet Sharma. So he is the young, energetic. He has also not joined long time. I think it is a year now. 1 year, it is 1 year. So great, within a year, he is organizing a excellent meeting where there are more than 400 participants. That's great success, great, thank you. And so this is, this conference, I understand the 2 days you have several very distinguished speakers, and you had a very good sessions, or I would say scientific feast on the pharmacy subjects, various subjects that which can be translated, that which is the title goes, the translational development. So how the translational science can be done from the pharmacy product or processes, mostly product, drugs or anything, drug delivery, many things, which would be the translation. Of course, pharmacy is a translation subject itself, but it is very much reiterated again, the translation development, how you can imbibe that. So that the distinguished speakers, they are from the very distinct institutes in the country, like your the pharmacy organization, the industry like Sun Pharma, DRDO, DPAS, IGIB, high grade, high level scientists and molecular scientists over there, and IITs, then the Hamdard, UCLA from USA, the one of the top institute, the UCLA, then you have the DIBR and the INMAS and all such great institutes. But one thing I do not know, because I had not much time, it's a huge busy schedule, you can understand today. I know you must be waiting for more than a half an hour, 30-40 minutes here, but we are busy with the writing or having the MOU signed with, you must have come across the chemical company, the Merck, MERK, so biosciences. So in your experiment laboratory, those who do, even in the pharmaceutical, you need those chemicals. So they are the chemical company. So they had 5 people came from Bombay, and we had the MOU signing. That's a historic signing because we want to collaborate. Our students will be placed there. This year they will recruit 20 students to do their interns there, and then they will be accommodated later. So it's now the terms of pharmacy institutes also. It is for MOU for whole MET. So we'll take the next journey, but first time biotechnology is taking part. So this is how it is a busy schedule. I could not come to this inauguration, so that's why I don't know what is all going on. But I am sure these distinguished speakers have spoken many of the things that which are in the forefront of this pharmaceutical or the pharmacy research. And most important one thing is this at this stage is that this is a health sciences or health research. It's part of the health research. This is not all the pharmacy science, but it's the most important facets of the healthcare. But in healthcare is nowadays has come into a enormous change. What is that change? Can anybody guess? Digital health. What is that? AI. When you enter into the MET through gate number 4, it's a big banner. It is just 1 week has gone, it has come up. That banner was there, the great cricketer, what is his name? Captain. Huh? No. The banner was there in the walls of the MET. Who was there? Dhoni. In that place, it has come the AI, artificial intelligence, digital health. So whatever you do, you add the artificial intelligence. It will reduce the time at least, if not more, 20 to 30%. So what you would have done 100% time, it will be done in 70 or 60% time. You can complete that. And then it is the beauty of the things that the excellent and you can do very fast. And many things, as you know, everybody has the Android phones. If you see something and again you come back, then immediately it will recognize it comes. It is nothing but artificial intelligence, simple way. So this is what the artificial intelligence, you give a little clue and it will come of its own. So this is what artificial, and most important area of use of artificial intelligence, I would say it is in the healthcare, because it relates to the human life, saving of the human life. There is nothing greater than this. This is the service to human, is the service to God. So this is what is the mantra, and this is what you have been getting exposed. And if not, has not been discussed, but you look for this opportunity in a future opportunity, future meetings, where, and it will be a big center has come up in this university. It's a newly created Center for Artificial Intelligence. So it's a huge center. A lot of money has been spent, and there are good experts, and it is in the engineering building. And I do not know, you didn't have the time to go through, but then this is a great institute created at the great juncture that it can be used in the maximal use in the field of any field. But we being biologists and medical biologists, or the biomedical scientists, or the healthcare people, so that has a immense applications of artificial intelligence in this field. It may be Unani, it may be Ayurveda, even the Indian system of medicine, or a modern system of medicines. Everywhere it is simply can be used. So I will not take much time. So so you must gone through all these lectures, and I hope there may be so many people, so it may not, because at the same time, there are a lot of meetings going on. So there may be some problem, your stay or any other things or food. So I hope it is whatever, if it is something has been gone wrong, it is not intentional, but I would appreciate if you pardon them or pardon us for this, any mismanagement has been done, but certainly we try to do the best possible, and all these arrangements are there in the campus, but there may be any mistake, quite possible. Everything cannot be 100% correct. So I hope you will pardon that, and then also take with the good memory of the amity, and I wish that you 2 days you have spent, I hope you carry some knowledge. That's very important. The workshop or the conference, what was meant for, there you have certainly knowledgeable, at least if you are at least 2%, 3%, 5%, anything knowledge has increased, that's the great achievement. That is what we look for. We go, we meet, we connect each other, we talk with the senior person, the faculty comes for lecture, we talk and we connect them, and you build up the friendship, as well as from the academic friendship, as well as other personal friendship through this conference. But the most important point is the academic achievement or the knowledge that you gain. So that's very important. That is the take-home message. So thank you very much once again, and I wish you all the best in your field. Thank you.
Thank you so for being an inspiration always. We are blessed listening to you. You are always a wonderful mentor and guide, sir. I now request Dr. Navneet Sharma, Organizing Secretary of the conference, to summarize the conference report.
थैंक यू मैम। सभागार में उपस्थित सभी गणमान्य व्यक्तियों तथा देवियों और सज्जनों को नमस्कार। Ladies and gentlemen, good afternoon, and a warm welcome to the valedictory session of the International Conference on Pharma Technology and Translational Development in Chem-Biology Research 2024, hosted by MIT University, Uttar Pradesh, sponsored by SERB and DRDO. It is an honor to be here with you today, as we will not wind up, but to celebrate the exploration of the fascinating fields of pharmaceutical technology, and translational development in Chem-Biology research. In the memorable and wonderful past 1.5 days, over 400 participants from various backgrounds, including pharmacy, biotechnology, life sciences, and chemistry, showed a glimpse of their research. As per the objective of our conference, to examine the scientific basis behind traditional remedies and practices by elucidating the chemical and biological mechanism of action, we have covered the scientific tracks of traditional scientific knowledge, stem cells, pharmacology, emergency healthcare, phytochemistry, drug discovery, and drug regulatory compliances. We had the scholars and students' scientific paper presentation on the different fields of chem bio research. Our inauguration ceremony was started by and inaugurated by Honorable Drug Control Journal of India. We were extremely grateful to have esteemed speakers from the industry, such as Sun Pharma, Mankind Pharma, Abbott and Emil Pharma, from esteemed research labs of DRDO, CSIR, IIT and CCRUM, as well as from UC, LA and National University of Science and Technology, Oman. Researchers and students from various research labs of DRDOs, IITs, NIPERs, and university across India and the globe join us to exchange knowledge, encourage conversation and discussion, and drive forward the field of pharmaceutical sciences. On the behalf of MIT University Noida, I extended my heartfelt gratitude to all the distinguished speakers, delegates, sponsors, and organization for their invaluable contribution towards making this conference a resonating success. May our deliberations be fruitful, our interaction enriching, and our endeavors inspire positive change in the field of pharmaceutical sciences. Thank you. Thanks a lot.
Thanks, Dr. Now I request. Now I request W. Silva Murthy, DG ADSI and President Amity Foundation for Science, Technology and Innovation Alliances, FSTIA, Amity University, Uttar Pradesh, to address our delegates.
Thank you so much. A very good evening to every one of you who has joined us at the valedictory function of this two-day international conference. Dr. Asim Ali Khan ji, my friend, and also a very senior official in the government of India who has occupied the highest position of the Director General of the Central Council for Research in Unani Medicine, CCRUM, and the Ministry of Ayush. And he is now very actively pursuing his endeavor, which was there in the ministry in a different institution after the superannuation. He is now continuing his mission in Jamia Hamdard, which I had the opportunity of visiting his Center of Excellence in the research on Unani medicine at Jamia Hamdard. It's a wonderful facility. All of you must go and see. And this is a great institution. And I wish you all the best, Dr. Asim Ali Khan, in your new responsibility. I'm sure through this, you will connect with many institutions in the country and across the globe and bring new innovations, innovative products in Unani medicine through the research. I must compliment MIT Institute of Pharmacy, particularly the people who have been responsible, right from Dr. Navneet Sharma, Dr. Naved, Dr. Chitme, and Dr. Ladar, and the guidance of Dr. Das, BC Das. They have been able to organize this conference so successfully because I was carefully listening to the report which was presented by the organizing secretary, Dr. Navneet Sharma, and in which I could see that this conference has really led to specific recommendations, as most of them conclude with Sabashi. But here I could see that they could formulate specific recommendations. This is what should be the outcome, so that we should be able to pursue further the outcome with the ministries, with the government, with other academic institutions, with the industry. So I must compliment all those who are connected with the Amity Institute of Pharmacy, who has organized this wonderful conference here. The recommendation I suggest that we should send it to, after refining, polishing, and making it very crisp, we should submit recommendation to Ministry of Ayush and also the various departments in Ministry of Ayush, all the councils, Drug Controller General of India, who came here for the inaugural, send it to him. Department of Pharma Industries, we should also percolate this down, and to be all the stakeholders who will be benefited from the outcome. We must make now the concrete plans. So out of these outcome deliberations, what is that Amity needs to follow? So this is what is the mission outcome Dr. Ashok K. Chauhan, the founder president, keeps talking about. That call out what needs to be implemented from our own Amity group, and then identify the process owners, which is the core team which will drive the outcome from these recommendations and the outcome of this conference. So I would be expecting from the Dr. Naved and also Dr. Shitmi and Dr. Leder and Navneet Sharma, such a kind of document that very 1 page, 2 page document that these are the actions, these are the process owners, and these are the timeline by which we will follow it up, so that we can keep reviewing such a contribution which will come out of this conference. Now to conclude my address by a few carry home message. The first thing is all of us need to focus on translational research. I would like to tell the faculties, participants, delegates who have come here, India has done very well in publication. You know, we are third in number of publications, 7th in Nature Index. We have done well even in IPR. We are 9th in patents today in the world. But where we are lacking is actually in the innovation index, global innovation index. Even though we jumped from 81 to 40, that's not the right place for India to be, the innovation index. Why we are lacking is we are not focusing on deliverables. Our research is not culminating in a product, technology, or a process, so that will contribute to Atmanirbhar Bharat, which our Honorable Prime Minister Shri Narendra Modi ji has been promulgating, and also pronouncing in all platforms, that Atmanirbhar Bharat, which will come only when we focus on translational research. That is why in this conference, the theme itself was kept as translation. That word is to be emphasized. So one message I like to convey is the students, the pharma students, B.Pharm, M.Pharm, PhD, and all of us, it is our responsibility to see that our country becomes a hub of innovation in pharma as well. We have done very well in generic medicines. We are the pharma of the world, pharmacy of the world. India is the pharmacy of the world. But we have only achieved excellence in generic medicine. But now we need indigenous molecules, indigenous products from traditional knowledge systems like Ayush, Ayurveda, Siddha, Unani, and also even in homeopathy. We need to look at how do we bring many applications. So I would like to give us next focus is on our own biodiversity, which is available, where India can take a leadership role, advantage India, because we have a large number of practitioners of Ayush system. We have many centers, academic and research centers. We have many industries in this Ayush system. And that is why we can take a leadership role if we look at that system, because a new molecule to come, it takes 15 years, 20 years, like the time taken for a molecule to come from ideation to the market. But then natural product can come very fast. So that is why I would request, second message I like to give is, let us harness the potential of this biodiversity and the root of practice and the system of traditional knowledge which we have in our medical system, of indigenous medical system of Ayush. Let us put that in a scientific pedestal through research and innovation. Now the last part which I like to convey to all of you is that industry connect. Because there is a weak link in our country is academia is not connected very well with industry, be it a pharma industry, biomedical industry, life sciences industries. There is a weak link. The confidence level from the industry on the academia, and also the creating the culture which the industry needs in academia by the universities and academic institution. Because of this, there is no proper linkages, interaction. So this is what is the message I like to give to all the people who are in the auditorium today, who are listening in the online, that let us foster a very close linkage with the industry. Academia should connect closely with industry, involve them in curriculum design, academic council, which Amity is doing. Fortunately, Amity is doing, and then also connect with them for translational research, product engineering, and also ultimately commercialization and marketing. Today, Amity has filed more than 2,100 patents. We have published 40,000 research papers. We have transferred 35 technologies. So we have started giving this emerging as Amity model for translational research. We have established the Amity Center for Translational Research. So all this is because we want to give a focus on the translational research. And Dr. Ashok Chauhan, the founder president, has given a very clear message. Our research should culminate in any one of these three: product, technology, process, or it could lead to an exciting path-breaking research outcome in terms of advancing knowledge or addressing a societal problem and giving a solution. So this should be the culture we must keep, because otherwise, if you publish paper, you become a fellow of an academy, you get invited for a conference, you are known in the scientific field. And if you file a patent, you become rich. But what you give to the society is when you give a deliverable. That is why, as a scientific social responsibility, all of us have this, that our research at the maximum should lead to the deliverable, which will bring Atmanirbhar Bharat and also contribute to Viksit Bharat, developed India, which our Prime Minister keeps talking about, the vision which he has given to the nation. And Dr. Ashok Chauhan, the founder, is strongly, he has envisioned it long back in one of his meetings. And so all of us together, we will realize their dreams, their vision to make India a Viksit Bharat, which in turn will create a happy world. So we will create a healthier, happier, peaceful, and prosperous world. Thank you so much, and best wishes, and thank you once again for Amity Institute of Pharmacy for organizing this such a wonderful event. Thank you.
Thank you, sir, for your captivating words. You are indeed an ocean full of knowledge in every domain of science and technology. It is pleasure listening to you again and again. It is such an honor to invite Dr. Asim Ali Khan, Dean, School of Unani Medicine, Education and Research, Jamia Hamdard University, and Chairman, Scientific Advisory Committee, CCRUM, Ministry of Ayush, Government of India, for being our chief guest today. It is indeed a great privilege for us, sir. I now request Dr. Tanveer Nawid, Deputy Dean, Health and Allied Sciences, Amity University, Noida, to introduce about Dr. Asim Ali, sir.
Very good evening to one and all. It's my pleasure to introduce the chief guest of this valedictory function, Professor Asim Ali Khan, to you. Professor Asim Ali Khan currently holds the position of Dean at the School of Unani Medicine, Education Research at Jamia Hamdard. Dr. Asim is also the former Director General of Center Council for Unani Medicine, Ministry of Ayush, New Delhi. Dr. Asim obtained bachelor degree in Unani Medicine from Jamia Hamdard. I think, sir, this qualification, which I just mentioned, signifies a great journey that you take an admission as a UG student and later on become the dean and obtain the coveted position of dean of the same institute itself. A great accomplishment. Big round of applause for our esteemed guest. Later on, Dr. Asim completed his master's degree in Unani Medicine from Jamia Hamdard itself. And as Dr. B.C. Das just informed you that until the last week only, Dr. Asim successfully defended his PhD viva voce from Amity Institute of Hospital Administration and Public Health under the very able guidance of Dr. Selvamurthy, sir. So congratulations once again, sir, to you. And the most importantly, during the tenure at the DG CCRUM, Dr. Asim has taken many initiative to propagate, to promote the Unani medicine, especially the research in Unani medicine, which is now, across the world also. At the every 11th of February, the whole world celebrates the World Unani Day. And during his tenure, many regional research center across the country, and especially in the remote area like the Northeast, has been opened and, working day and night to obtain the data from the various sources and the validation of the various Unani formulation through the research projects. But the most important accomplishment during his tenure was the establishment of the National Institute of Unani Medicine, not very far, but at Ghaziabad, which was inaugurated by the Honorable Prime Minister of India, Shri Narendra Modi ji. So that is another accomplishment during his tenure to establish a national level institute in the Unani medicine. Dr. Asim is also holds the very important positions like the co-director of Center of Excellence for Unani Medicine, which is a wonderful state-of-art facility at Jamia Hamdard. Also the Chief Medical Superintendent, Majidi Hospital. Is the chairman of AYD 04, Bureau of Indian Standard, Government of India, and also member of Advisory Committee, National Commission of Indian System of Medicine, Government of India. With utmost respect and with a great pleasure, I invite Dr. Asim to address the gathering. Thank you.
Thank you very much, Dr. Tanveer. Honorable Founder President, Janab Dr. Ashok K. Chauhan Sahib, Honorable Chancellor of MIT University, Dr. Atul Chauhan Sahib, Honorable Vice Chancellor, Professor Dr. Balwinder Shukla ji, my mentor, guide, and a great scholar, the Director General ADSI and President ASTIF, Dr. Silva Murthy Sahib, Dean and Allied Health Sciences and a renowned scientist of the country, Professor B.C. Das Sahib, Deputy Director AIP, Dr. Chitmeji, Head Surgical Chemistry, Professor Vinilata, Organizing Secretary, Dr. Navneet, my friend, Dr. Tanveer Naved, Dr. Swati, heads of the departments of different departments of MIT University, delegates, their students, a very good evening to all of you. At the outset, I would love to put on record my sincere gratitude to the leadership of MIT University for providing me this opportunity to be here and address this August gathering. Congratulations to MIT Institute of Pharmacy that for organizing this international conference. I was listening to Dr. Chitme, and we were discussing that many international delegates also participated in this international conference, some offline and some online. And it was really wonderful to provide this wonderful platform last 2 days in the field of pharmacy and allied sciences to have interactions. And it's a great opportunity for everyone. So thank you so much and congratulations to you that you provided this opportunity for the people. I know MIT, as it has been discussed, that I continued my PhD from here in public health. MIT believes in that research is a powerful tool for shaping life and society, and I know this system very well here. The theme of this conference, traditional biopharmaceuticals, in fact, is very apt and very timely taken and chosen. In an era marked by rapid technological advancements and evolving healthcare needs, is indeed crucial to recognize the invaluable contributions of traditional biopharmaceuticals. These time-tested remedies, often rooted in centuries-old knowledge, continue to play a vital role in addressing a myriad of health challenges faced by communities worldwide. As I said, that MIT I'm a family member to this MIT, being a PhD from this organization, is an ultimate destination for education, training, and research in many disciplines. Through a large number of graduates, this university is catering to different parts, not only within the boundaries of our country, but outside the country. And I know that. And the Department of Pharmacy of this university, I know, I have been visiting earlier also, has already attained high standards in education, research, and innovation under the dynamic leadership of this university. My journey, in fact, with this MIT University formally began almost 4 years before. I was, as a Director General in the Ministry of Ayush, was sitting with the Secretary Ayush and others, officers, and we were deliberating upon that how Unani system of medicine is doing and how other Ayush systems of medicine are doing in the country and abroad. And we thought that we shall dig deep into the reasons, the level of awareness, the level of its utilization, the level of consumption patterns, that how many people in the country, despite so many efforts government of India is doing, a lot of funds are being provided, and number of funds is provided to development of Ayush systems of medicine. So we wanted to know that what is the level of understanding about Unani system of medicine, how many people are aware of it, how many people are using it, and if they're using it, for what diseases they are using it. And if they're using it, are they using it separately, individually, or they are using it in combination as an adjuvant therapy with allopathic or some other sciences like Ayurveda or Siddha or homeopathy. And who are the people who are not using it? And if they are not using it, why they are not using it? So we wanted to dig deep into this ocean to understand in the society what is going on. We wanted to have the systematic analysis also, reviews also, that what shall we do? And we also wanted to understand first-hand information from the ground by doing surveys and talking to the people that what is going on. And we were discussing what shall we do. And the best thing that was that probably I shall enter into my PhD. It will be a win-win situation. And what better university could be than the MIT University to get into this? Because when I entered here and I met Professor Silvamurthy Sahib, and we discussed it. Dr. Rajiv Sahib was also here. He's in Chennai these days. So we discussed the matter, and Professor Silvamurthy Sahib, I'm very thankful and really honored that he readily agreed to guide and mentor this journey of PhD in this university. And we continued, we designed, and under the leadership of and guidance of Professor Silvamurthy Sahib and other colleagues, Dr. Shazina and Dr. these days, the gentleman, Dr. Shanawaz, they also were there. Dr. Achal was also there earlier. Now I think she has shifted to some other department. So with these people, I started my journey here. And recently I concluded by doing my last viva for that successfully. In the meantime, when I was a DG, we have there the collaborative research projects. And for that collaborative research projects, I wanted some very senior minds and senior people, senior scientists of the country of national, international repute. And I could request Professor B.C. Das Sahib, and he was kind enough to be there. And B.C. Das Sahib was there with us to chair many sessions, and he critically evaluated many projects. And through his critical evaluation and his guidance and mentorship, a lot of projects got refined there, and we could get a good work done, which has been still carrying on. We provided many research projects to many leading scientists, including your university, I mean my university. Here also, Dr. Kumud Bala is here. She is doing one good research project. Many projects are going on in pharmacy. Also, Mariam Sarwat is also doing good project. And in Gurgaon also, some projects are being carried out there. So, in fact, the pharmaceutical industry plays a very important role in the global healthcare system by developing drugs that are used for prevention, alleviating or treating diseases, and enhancing quality of life for billions across the globe. Drug development, because most of you are from the pharmacy background, you all know is a very delicate and at times quite a complex process that involves meticulous arrangements at many levels, coupled with scientific innovations and stringent regulations to follow. For the layman, it is very difficult to appreciate the journey as to how the drugs reach the market pharmacy shelves, how the treatments are born, what challenges are faced by the scholars during this tough journey. It requires indeed an action-packed researches at various levels like literature review, like preclinical, the clinical, the toxicity studies, and details are then worked out about its pharmacokinetics, its absorption, its metabolism, its excretion, clinical research structured with phase-wise clinical trials in all 4 phases, development with all products. Its packaging, its marketing, its advertisements, its post-marketing survey is a huge task when people receive the medicine. And the development of this medicine is this group who is here. So I'm thankful to all of you and congratulate all of you for having this wonderful hard work for developing the drugs and medicines. As you all know that our country, India, has a very rich heritage of several systems of traditional medicine, which are in popular use in the country, and not in country, but not subcontinent, but some other parts of the globe. We have a vast resources of medicinal plants and huge repositories of knowledge in traditional medicine. Many countries in our subcontinent also have few of these systems in place, and they are catering to their health needs these days. The important role played by the traditional system of medicine in meeting the global healthcare needs, we all know have been universally acknowledged. And post-COVID, now most of us are more aware about what Ayurvedic, Unani, Siddha, and homeopathic yoga systems could do. Today, we all know that we are exposed to a range of communicable diseases, lifestyle disorders, nutritional issues, and medical care problems. The incidence and prevalence of diseases, its complications, and the impact on the quality of life of patients and family members may be minimized, I understand, to a significant extent if quality assured healthcare services, including traditional medicine services, are accessible to everyone. And there is a lot of scope to educate public about the relevance of traditional health practices, which happens to be culture friendly and acceptable to people. The Ayush system of medicine, I think how many of you may be aware about it, maybe many of you, that they advocate the holistic wellness approach aiming at prevention of disease and promotion of health and well-being. The government of India, I know that it has been promoting like conventional medicine, it has all been promoting a lot about the Ayush systems of medicine, specifically Ayurveda, Unani, Siddha, homeopathy, and so on. And huge funds is being pushed into. A lot of infrastructure is being developed. Like they say, the national institutions, not only national institutions, we have central institutions, national institutions, regional institutions. We have most than 750 colleges. We have different universities. We have, starting from the Ayush health and wellness centers to the primary healthcare center, secondary healthcare center, tertiary healthcare centers. So we have a huge infrastructure. And today, I think in terms of Unani system of medicine, though it came from somewhere, it originated somewhere from Greece, as Unani we call as Greece, it came from Greece to Persian areas and Arab areas, and with them it came to India in 8th century AD. And now India is, we can proudly say this is the world leader in managing the Unani system of medicine and its systems. We know that traditional systems of medicine are time-tested for their safety and efficacy. Factors like changes in geoclimatical conditions, environmental pollution, changes in human lifestyle, onset of new causative factors for diseases, new disease entities, etc. They have all necessitated the research and revalidation in traditional medicine. Further, different regulatory provisions in different countries for market authorization and use of traditional medicine products also underline the need of a state-of-the-art research in traditional medicine. And in order to strengthen the Ayush systems and their revalidation, various initiatives have been taken, which includes the research infrastructure development, as I told. And in these circumstances, I think when this much of challenges are there, and people are also looking positively to have the traditional system of medicine in their own lives and the problems. Now the question arises that in this ever-increasing quality competition, what is the solution? How we can match the expectations of the people which they really wish and will, that they want to have the Ayush systems of medicine. And there are certain issues and concerns, as I said, that there are a lot of issues and concerns which also need to be addressed, We at Ayush systems of medicine have a lot to do, and we are doing many things we are doing already. We have a lot of institutions, as I said, in the name of national and institutes and national institution and central institutes and regional institutes of research and colleges and teaching, undergraduate and postgraduate and PhD researches, but still we have to go a far long way. And for that, probably we cannot wait for that long. So I think the only solution comes to my mind is that we shall have an integration. Integration approach is the only approach which Professor Silvamurthy Sahib was also speaking just a minute before, that one shall have the integrated approach. Integration, when I say, I mean collaboration. Integration does not mean amalgamation. Integration does not mean that I lose my identity as a Unani specialist, you lose your Ayurvedic, or you lose as a scientist or biotechnology. Let us all remain who we are. Let us all maintain our individuality, but still we can come together under one roof. Honorable Prime Minister Sahib, Shri Narendra Modi Sahib is also, these days you must have heard, that we are working on the integration model. These days in Safdarjung Hospital, we have opened up, it is a tertiary care hospital, but in that hospital, we have opened all Ayurveda, Unani, Siddha, homeopathy, and yoga centers. Similarly, we also need to understand initially that earlier we were in segments not only with conventional medicine and other sciences, but with our own systems. We also need to understand what is good in Ayurveda, what is good in Unani, what is good in Siddha. We need to understand ourselves more. And for that matter, we have also come up with the Ayush Wellness Center concept. Rashtrapati Bhavan is such a model in Delhi that we are under one roof. We call it Ayush Wellness Center. Where Ayurveda, Unani, Siddha, homeopathy, yoga are working. And this model is so successful. Presently, this is working only for catering to the health needs of the people who are residing in the Rashtrapati Bhavan complex. But there are many demands to the government of India that such kind of integration center can also be replicated in different parts of the country. Maybe probably soon in Assam or some other areas, probably we would be replicating this center there as well. So what I'm saying is that not only India, but we are talking integration. Recently, there was a conference in Geneva where it was a World Health Conference where almost 50, 60 countries were participating. And they also invited, India was a country guest of honor there. And luckily, I was also given a chance to speak in that for 35 minutes slot. And we were talking and the whole world the questions were more relevant about how India is successfully integrating these alternative medicines, unlike any other part of the world like this other than China, that into the main healthcare delivery in our country. We have same site, same place, in the same hospital. We have Ayurveda, we have Unani, we have Siddha, we have homeopathy, we have yoga, we have allopathic. So such kind of centers, whole world is now looking forward for that how India is doing and what kind of a mechanism India has put in place. Iran, I visited as an official delegation with the Secretary Government of India. We went there. They are also very keen. They are also having some traditional Persian medicine. So they were very keen that how India has successfully modeled this way that they are successfully doing into the healthcare delivery system. So I think we are doing very well in IU systems of medicine. And after this government in 2014, when Honorable Prime Minister Narendra Modi Sahib took charge as a Prime Minister country, earlier it was our section was a part of the Health Ministry. We were a department there. After 2014, it became a separate full-fledged ministry headed by a minister and a secretary and other officers. So this way the ministry has been created and we are doing a lot of good work, but we don't have much time. And this is a time of integration. We know each other well. So like we have the projects here. Similarly, in other institutions, like CCRUM, as I was a Director General of CCRUM and CCRAS in Ayurveda and Siddha, we have collaborative research projects. So I invite some of the professors have already done there. These days, I am heading as a chair of the Scientific Advisory Committee of CCRUM, where all these projects support. So I request all of you who have this urge that they please write the good projects. And the projects which I say to float in Ayurveda Council or Unani Council, not something very conventional. See, I was talking to Professor Chitme Sahib just now and Sir Professor Das Sahib, that conventional way, whatever, for example, stability studies are there. For example, dose designing is there. A lot of things are there. So all these things, we have a good network of institutions with us in the country, which are within the purview of the Ayurveda, Unani, Siddha councils or institutions to hospitals. We require some more advanced researchers. That's why we need to join and collaborate with the professors and the scientists of other institutions like this MIT University, the leading university of the country. So kindly come up with the good projects. Dr. Nitin, I met him, he was in Punjab. He also applied for the project. Recently, he told me that he has shifted here. I thought day before yesterday, I received his message. He said that if any assistance in this university required, I'm available. I thought that he is coming here to join the conference. He said, no, I have joined the institution. So he's a wonderful scientist. So similarly, other scientists also, I request that please come up with the good projects and proposals. I am 100% confident because I'm seeing, and as DG also I saw, and now as a scientific committee chairman, I'm seeing in other parts of the world, I keep on traveling and I see that there's a huge scope that very soon this harmonized approach based on the best acceptable existence model in the country and other parts of the world could be instrumental in steering the unified development of traditional medicine, education, practice, and regulation with mutual recognition, qualification, pharmacopoeia, other related aspects. I also request all the students here who are sitting here and all the faculty members that This has been time and again said by the Health Ministry and the Ayush Ministry also, and both the ministers, Manvia Sahib and Health Minister, Honorable Health Minister of India, and Honorable Sonowal Sahib, the Honorable Health Minister of Ayush, that, and both the secretaries, we are very keen that the education and understanding of the Ayush systems of medicine and the conventional system of medicine, they should be brought into the notice and attention of the youngsters. Whatever courses they are doing for their treatment, to guide, not as a doctor, but as a normal citizen, educated, learned citizen, they should be well aware of what kind of systems are, treatment systems are available for us in the country or outside the country. So I think some basic understanding shall be developed. Some kind of a course curriculum has to be designed. I think it is coming from the government also, probably. But I think within the universities are autonomous in themselves. So they can also take this call that they can add some small chapter in different courses which may be made essential, that everybody has to go through this chapter, maybe in the first year of it, so that every one of us, particularly the allied sciences people, if not social, I suggest for the social sciences people also, but at least for the allied sciences people, that allied health sciences people, that we all should understand the basic understanding about the treatment options available for us, so that in our family, and to at least we can refer, we can recommend. Similarly, for the healthcare professionals like pharmacy or modern medicine or Unani medicine, we should also know each other by imbibing this knowledge and by giving the chapters into their books and their chapters into our books. I think that way we can really benefit the masses in a good way. We can support our society in a good and healthy way. So this is what I feel that I wanted to speak here. I wish that, because I know that MIT University has developed a department of Indian system of medicine, where I met other day one professor. She is from homeopathy, and some other people are also in that system. Yoga people are also there. I wish that soon that one Unani system of medicine wing, particularly some research wing, may also be initiated here. I will request Professor Silvamurthy Sahib and Professor Das Sahib that if this kind of, because this is a wonderful institution. I see Hamdard, because Hamdard I know, we have Government of India has granted Hamdard a center of excellence, and it is really developed in a wonderful facility. I requested Professor Silvamurthy Sahib, and he was kind enough to visit the center, and he was very happy to see the center. I will request Professor Das Sahib also that please find time, invite you so there, please have a look on the center, and all other faculty members that please come there in the conferences and seminars which you organize in cognosy and phytochemistry and pharmacology and Unani. So please join us there and have understanding the facility. What I'm trying to say is, what I see in Hamdard, it is a close-knit organization where different departments work like extended family. And that atmosphere is required for any kind of good researchers to move on with. I find the same atmosphere here also. I mean, the different departments come together, they have good interactions with each other. I think this kind of atmosphere is needed. So this is a wonderful platform where we can sow the seeds of the researches in Unani system of medicine, advanced research in Unani system of medicine. I wish and I pray that soon the leadership of MIT University, Honorable Vice Chancellor and Chancellor Sahib, and Professor Das Sahib and Silvamurthy Sahib, they look into this. And with the ISM, if Unani Wing Research Center is also added. I will not take much time. Thank you very much for a patient hearing. And again, thank you to the organizing team, Vikas Sahib, Professor Silvamurthy Sahib, and Madam Shuklaji for inviting me here and giving me the opportunity to interact with you. Thank you so much, and Jai Hind.
Thank you, Dr. Asim Ali Khan ji. We were so happy and highly motivated, inspired by your very, very valuable inspirational address. And we have already started, after you mentioned to me during the visit to Hamdard, that we should look for some strong center of excellence for research in Unani medicine in Amity. We have already started making proposal with Amity Institute of Pharmacy as the nodal institution. Dr. Tanveer Naved and the other team, whole team is now working a big document under the guidance of Professor Das, BC Das. We will come out with a proposal to you soon. And so I'm sure Dr. Das and Dr. Tanveer Naved will take it forward. And he has given us such a wonderful offer that, we can expand, deepen our relationship
with him, with his university, and also with Ministry of Ayush, CCREM. Still, he continues to be the chair of the Scientific Advisory Committee of CCREM. So please make use of this offer and also harness this. Thank you so much.
Thank you so much, Selvamurthy sir. Thank you, Asim Ali sir, for sharing ocean of information, ideas, and sharing wealth of experiences and knowledge. We will be happy to listen to you again in our future events also. Now I would request my co-coordinator, Dr. Swati Madan, to come forward for the felicitations.
Very good evening, one and all. Now I request Professor B.C. Das, Dean, Health and Allied Sciences, to step forward and felicitate our Chief Guest, Dr. Asim Ali Khan, Dean, School of Unani Medicine Education and Research, Jamia Hamdard University, and Chairman, Scientific Advisory Committee, CCRUM, Ministry of Ayush, Government of India. Now I request Dr. Hawa Girichitme, Deputy Director, Amity Institute of Pharmacy, to come forward and felicitate Professor Dr. B.C. Das, Sir, Dean, Health and Allied Sciences, AUP, Noida.
Now I would request BC Das sir and Asim Ali sir to felicitate our organizing team members, Dr. Hawa Gire R. Chitmes sir. Felicitation for Dr. Tanveer Nave, Deputy Dean, Health and Allied Sciences also. Felicitations for Dr. Vinay Latha sir. And felicitation for the most important pillar of the conference, Dr. Navneet Sharma. Thank you, sir. Now we move forward to our most awaited moment of the day, announcement of results. I would call Dr. Swati to please announce. A big round of applause. It is the pillar behind this conference who was working day and night for this.
Now we are moving to the results of the scientific session for which we all are waiting. And I request all the dignitaries on the dais to come forward and please present the awards. For track 1, traditional scientific knowledge and ancient wisdom, third prize goes to Mr. Lokesh Kumar, Amity Institute of Biotechnology. Second prize goes to Ms. Sakshi, Amity Institute of Indian System of Medicines. Third prize goes to Mr. Lokesh. Second, Ms. Sakshi. First prize goes to Mr. Sparsh Kakkar, Amity Institute of Indian System of Medicines. Just. Okay. No, but go fast. Mr. Lokesh Kumar, Amity Institute. First prize goes to Mr. Sparsh Kakkar, Amity Institute of Indian System of Medicines. Second, Ms. Sakshi, Amity Institute of Indian System of Medicines. Mr. Lokesh Kumar, Amity Institute of Biotechnology, third prize. For track 2, stem cells, tissue engineering and pharmacology. Third prize goes to Ms. Nikhila Shekhar, Pharmacology, Dipsar. Second prize goes to Mr. Sarthak Dhaya, M.Pharm Pharmacology, Amity University. And first prize goes to Ms. Ariba Khan, M.Pharm Pharmacology, Amity University. For track 3, drug discovery, formulation and biologicals. Third prize goes to Kabil Malhotra, AIP Noida. Kabil Malhotra, AIP Noida. Second prize goes to Komal Chaudhary, FG IPC, New Delhi. And first prize goes to Abhishek Vahi, Dipsaru, New Delhi. Now I request Dr. Rajiv Khara, Professor AIP, to please felicitate Dr. Jamshed Hanif, Assistant Professor, Jamia Hamdard University, New Delhi. And Dr. Saeed Salman Ali, Lloyd Institute of Pharmacy, Greater Noida. Dr. Saeed Salman Ali.
इनको अच्छा
पहले इनका बोला है इनको कराना। For track 4, phytopharmaceuticals regulatory compliance in practice, third prize goes to Namita Joshi, Graphic Era Hill University, Bhimtal. Second prize goes to Sonal Sharma, Amity Institute of Pharmacy, track 4. And the first prize goes to Sana Sidesco, Ministry of Health and Family Welfare. Sonal Sharma, Amity Institute of Pharmacy, second prize for track 4. First prize goes to Sana Sidesco, Ministry of Health and Family Welfare. Track 5, Emergency Healthcare and Combat Casualty Management. Third prize goes to Priyanka Grover from INMAS, New Delhi. Priyanka Grover from INMAS. Second prize goes to Ashrit Nair from IIT Delhi. And first prize goes to Anushka Khanna from IIT Delhi. Congratulations. Second prize, Ashrit Nair, IIT Delhi. And the first prize goes to Anushka Khanna from IIT Delhi. Heartiest congratulations to all the winners. Thank you so much, everyone.
Without the support of the faculty members, this event would not have been a success. So I would request the faculty members one by one with the name so that they can be felicitated by our guest. Dr. Bhupesh Sharma, sir. Equals है. Dr. Vikesh Kumar Shukla. Dr. Mariam Sarwat is not available. Dr. Rajiv Kharab. Dr. Amanpreet Walia. Myself.
Dr. Nirupma Dhiman. Dr. Nitin Sharma.
Dr. Archana Sharma. Dr. Swati Madan. After this, Dr. Kalpana Nagpal. Dr. Dheeraj Nagpal. Dr. Shikha Chauhan. One more announcement that the participation certificate will be available at the registration counter. The participation certificates will be available at the registration counter. Dr. Alka Lohani. Is she available? Dr. Annie Gupta. बच्चे उठ रहे हैं और उन्होंने बोला बोल दो बच्चे बहुत देर से वेट कर रहे हैं Dr. JB Senthil. Dr. JB Senthil नहीं है Dr. Sangeeta Gupta. Dr. Shikha Saxena. Dr. Navneet Sharma. Okay. Dr. Neha Jain. She available? No. She's not available. Dr. Puneet Gupta. Dr. Kavita Munjal. Dr. Priyanka Saroj. Dr. Mahendra Yadav. Dr. Smriti Sharma. Dr. Hemlata Nimesh. He was also working day and night with the organizing team. Dr. Smriti Sharma. Dr. Hemlata Nimesh. Dr. Indu Singh. Dr. Shreya Kaul. Dr. Saurabh Mittal. Dr. Sweta Bavari. Dr. Saurabh Verma. Dr. Rimpi. Dr. Richard Hingra. And last but not the least, a very important person who has also worked a lot for this conference, Mr. Rahul Tyagi. Dr. Deepti Sharma from AIB.
So I very quickly, thanks to the Youth Veda who, accept my request and present all the wonderful gifts to all the faculty members. Due to some urgent work, our Honorable Founder President could not join the valedictory session. But as all you are aware that yesterday he gives all his blessing to the inaugural session, and he conveyed all the best wishes to the organizing team, and also conveyed very hearty welcome and greetings to Asim Ali Khan sir. So this is the message from Honorable Founder President. Now I request Dr. Vinay Lathar to propose the formal vote of thanks.
Respected dignitaries on the dais and off the dais, resource persons and faculty colleagues from Amity and other organizations, and dear delegates, I think most of them have left already. So good evening all. First of all, it's my pleasure and we are very fortunate for the founder president, Honorable Founder President, Honorable Chancellor, Honorable Vice Chancellor, for providing us this platform that we could successfully conduct this 2 days international conference. As we draw the curtains on this enlightening and interacting international conference, it's my privilege and honor to extend heartfelt gratitude on behalf of the organizing committee and Amity Institute of Pharmacy. We extend our sincere thanks to our esteemed chief guest for this valedictory function, Dr. Asim Ali Khan, Dean School of Unani Medical Education and Research, Jamia Hamdard, for his thought-provoking ideas and amalgam of knowledge with all the participants. Your expertise and passion have been instrumental in shaping the success of this conference. We extend our heartfelt gratitude to Professor B.C. Das, Dean Health and Allied Sciences, Amity University, for bestowing upon his scientific knowledge and guiding us through his thought-provoking ideas. Sir, your expertise has been instrumental in taking Amity Institute of Pharmacy to accelerate in research. I'm very thankful to Professor Dr. W. Selvamurthy, President STIF, for sparing his time and sharing his scientific knowledge and guiding us through his thought-provoking ideas. Our deepest appreciation goes to each one of you who graced this conference with your presence, actively contributing to the stimulating discussions, sharing your insights, and enriching the collective knowledge. A special note of appreciation is owed to all the presenters whose research, innovation, and ideas have ignited intellectual discourse and fostered collaboration across diverse fields. Your dedication to excellence and willingness to share your expertise have elevated the quality of this conference. We are deeply grateful to our sponsors and partners for their generous support and unwavering commitment to the advancement of knowledge and innovation. Our sincere gratitude also extends to the dedicated members of the organizing committee, Dr. H.R. Chitme, Deputy Director AIP, Dr. Tanveer Nave, Deputy Dean Health Sciences, Dr. Navneet Sharma, Organizing Secretary of this international conference, all the center heads, the faculty members, and student volunteers whose tireless efforts behind the scenes have ensured the seamless execution of every aspect of this conference. Your hard work, dedication, and attention to details have not gone unnoticed and have been pivotal to the success of this event. I would also like to thank to all the non-teaching staff members of AIP whose hospitality and support have contributed to the smooth functioning of this conference. As we depart from this gathering, let us carry forward the spirit of collaboration, innovation that has defined our time together. May the connections made and insights gained serve as the catalyst for future endeavors and contribute to the collective pursuit of knowledge and progress. Once again, thank you all for your participation, enthusiasm, and unwavering commitment to excellence. We look forward to meeting again in the near future, enriched by the experiences and memories shared at this remarkable conference. Thank you very much.
I request all the participants, student coordinator, everyone to come forward for the photograph.